Good afternoon, everybody. Is that okay? So, good afternoon to everyone. It's my very great privilege to welcome all of you to this sixth Endo update, which is being held here in a virtual platform and is being conducted by the Usmania Medical College in Hyderabad. So Usmania Medical College in Hyderabad has a glorious history for last 100 years. It has been in existence, and it has been a place where many discoveries like the chloroform anesthesia was discovered here. So in this medical college, we have the Department of Endocrinology, which is existing for more than 50 years or close to about 50 years now, and we have been having the training program in endocrinology for last 20 years now. And so I have great privilege in introducing, I mean, in welcoming all of you. And for this inaugural function, we're really indeed privileged to have a galaxy of invitees who are here with us. So at the outset, I would like to invite and introduce our scientific chair for the meeting, Dr. Bipin Sethi. Professor Bipin Sethi has been associated with the endocrine, I mean, from the endocrinology department of Osmania Medical College for more than 30 years now. He was in the department. He served in different capacities in the Department of Endocrinology in Osmania Medical College. Then he went on to to also work in the departments of endocrinology in Gandhi and Kurnool Medical College, and now he's associated with the care hospitals where he's running a training program for DNB endocrinology. So I have great pleasure in inviting him to join this session, and then we have with us the past president of the Endocrine Society of India, Dr. S. V. Madhu, who's the professor and head of endocrinology at the GTB Medical College in New Delhi. And we also have with us Dr. Sanjay Kalra, who's the current president of the Endocrine Society of India. He's based in Karnal. He's been very active in his role as the president of Endocrine Society of India, and he also has been previously the editor of the Indian Journal of Endocrinology and Metabolism. Uh, then we have with us our current president-elect of the Endocrine Society of India, Dr. Ganpati Bantwal. Dr. Ganpati Bantwal is the professor and head of endocrinology at the St. John's Medical College in Bangalore. He was instrumental in conducting the previous endocrine update in 2019, which focused on the adrenals. And in this update, we are focusing on pediatric endocrinology. Then we have with us Dr. Sujay Ghosh, who's the secretary of the Endocrine Society of India. He's a professor of endocrinology at the Medical College IPGMR, GMER Medical College in Calcutta, which is a very prestigious institution. And he's involved in several different research projects in endocrinology. He's just joined us. So welcome, Dr. Sujay. Uh, then we have with us Professor N. Sudhakar Rao, who's also been associated with the Department of Endocrinology in Usmania Medical College right from its early days of inception. He has served as a professor of endocrinology even at Gandhi Medical College, and currently he is the president of the Telangana Society of Endocrinology. So I have great pleasure in inviting him to join us today in this inaugural function. And we have with us the principal of Usmania Medical College, Dr. P. Shashikala Reddy, who has been very dynamic and has been the principal for the last 2 years, and during her tenure in Usmania Medical College has made several progresses in the past 2 years. She is a professor of microbiology at Usmania Medical College, and currently she is the nodal officer for COVID testing in the state of Telangana. So I welcome her for this inaugural function. And finally, we have with us Dr. Nagesh, who has worked very hard. He has been associated with our department since the last more than a decade, and he has been interested in pediatric endocrinology and has been always he's been very active in organizing this update, and he is the coordinator for this function. I welcome him also for this function. We will now move on to the lighting of the lamp. So I would request uh, the video, because we're doing it virtually. Uh, Traditionally, we light the lamp to to dispel ignorance and bring in bring in bring in wisdom and knowledge. And so we'll do the symbolic lamp lighting virtually.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीप
Endo Update is an exclusive program organized by the premier teaching institutes of India for endocrinologists from across the country. Journey of Endo Update started in the year 2015 with a focus on one gland every year. Since then, adrenal gland, pituitary gland, gonads and bones and minerals are covered. Endo Update has been graced by 24 international faculties and more than 1,200 delegates till date. 75 endocrine topics have been discussed for more than 80 hours. Regional Medical Councils of India has awarded 24 credit points to the program till date. More than 100 posters and oral presentations have been presented by postgraduate students, and best 3 are being awarded every year. Endo Update has been rated one of the best platforms for clinical endocrinologists within India. Department of Endocrinology, Osmania Medical College, Hyderabad, a premier teaching institute of India, welcomes you all to the 6th Endo Update, which is focused on pediatric endocrinology. 6th Endo Update is graced by 7 international faculties and 6 master plenary sessions. We once again welcome you all for this academic feast in the next 2 days.
Address the gathering.
Thank you, Dr. Rakesh. It's a great pleasure to be involved in this activity. Pediatric endocrinology for the common physicians is just about growth, type 1 diabetes, and neonatal hypothyroidism. But pediatric endocrinology field is vast, and it is very difficult to choose among that field the topics that would be of scientific and clinical interest. Dr. Nagesh has helped us a lot in connecting with the right people, and we have come up with a program which I hope will find favor with the audience. This program was to be done in an actual platform in July. We could not do it for reasons that are known to everybody. We do hope that this will be conducted face to face soon next year. Till such time as that, as a proud member of Endocrine Society of India, which has the endeavor to spread academic messages relevant to the community across the country in the medical profession. This is a small endeavor, and as Dr. Rakesh said, an update which was planned about a year ago. And when we had the topics to choose from, unanimously everybody agreed that it must be pediatric endocrinology. So we look forward to an academic feast in the coming few hours, and the platform is there, which is virtual. We wish it was something otherwise. The names that we have in faculty are the who's and who in the world. We have read their names in textbooks, and it is a personal pleasure to see them virtually. Thank you very much for this opportunity.
Thank you, sir. Thank you very much for the kind words there of the introduction that you've given. And I would now like to invite our coordinator for this meeting, Dr. Nagesh, who has played a very important role in organizing this meeting. I would request him to give a brief introduction to this meeting and also introduce the international faculty who are available, who have joined in for this meeting.
Thanks a lot, sir. Respected faculty, respected professors and dear friends, it is indeed a privilege to be the coordinator for this pediatric endocrine update. Last year, when we were planning this update, we had a choice between thyroid carcinoma and pediatric endocrinology, and everybody was unanimous about pediatric endocrinology. This update was actually supposed to be held in July 2020, but unfortunately, because of COVID, it's been pushed to September, and it's a virtual update this year. But fear not, because firstly, we are going to have a very stellar program this year. And next year also, we are going to have a live update. And again, that is going to be a pediatric endocrine update, which underlines the importance that Usmania Medical College, Endocrine Society of India, and the endocrine community at large in India gives to pediatric endocrinology. It is an essential part, and it is an academic pleasure for every endocrinologist to be seeing cases of pediatric endocrinology. And this meeting is a meeting which will help our practicing clinicians know their pediatric endocrinology better. The best thing, actually, in fact, we have not lost because of COVID. We have essentially gained because of COVID, because we are going to get 2 stellar meetings. As far as the faculty is concerned, this is one faculty which does not need an introduction. This is virtually the dream team of pediatric endocrinology. But still, for form's sake, I'm going to do the introductions. The first speaker we have today is Professor Zvi Laron. I'm sure every undergraduate the world over in medicine knows who Professor Laron is. Everybody in the world has heard of Laron's dwarfism. I don't need to speak any further about Professor Laron. He's one of the greatest. Next, we have Professor George Krosos, who is going to come tomorrow. He's famous as the person who has discovered Krosos syndrome, and is also reputed, he's also the most cited endocrinologist in the world. It's not every day that you do a meeting where you have 2 people as faculty who have syndromes named after them, Laron's dwarfism and Krosos syndrome. Third, we have Peter Lee, Professor Peter Lee. He is going to speak again tomorrow about puberty and disorders of sexual differentiation. And if you have read any major pediatric endocrine textbook or guideline, you must have seen this name, Professor Peter Lee. He's written most of the guidelines over the last 25 to 30 years about puberty and DSD. Then we have Professor Francesco Chiarelli, one of the elder statesmen of European and world pediatric endocrinology, who is going to speak about diabetes and monogenic obesity. The other speakers we have today are Professor Stefano Cianfrani, who's very familiar to all of you if you have read the journal Hormone Research in Pediatrics, and I'm sure all of us read the journal. He's the editor. He's been the editor-in-chief of the journal for past many years, and it is an excellent journal. And thank you once again for the quality, sir. And we have Professor Linda Di Meglio, who is one of the leading lights in North America as far as the management of diabetes and pediatric bone disorders are concerned. And the youngest of our faculty, and also one of the most prominent people in the world, we have Professor Khalid Hussain. He is one of the foremost experts in pediatric hyperinsulinism, if not the foremost expert in the world today. Again, he's a person who is very familiar to all of us. Many of us have interacted with him over the years, over the last 10 to 15 years. He's an extremely friendly, approachable man who has never said no to any of us when we have approached him with our queries and our doubts, and who has played a major role in the understanding of Indian endocrinologists with respect to hyperinsulinism. With this kind of team, I'm sure for the next 2 days we are going to have a huge academic fiesta, and I welcome all of you to take advantage of this stellar faculty. Thank you.
Thank you, Nagesh, for the good introduction that you've given to the program and to the faculty. I would like to now invite our uh, past president of the Endocrine Society of India, Dr. S.V. Madhu, to address the group. So you're muted, sir.
Thank you, Rakesh, and it's a privilege to be involved in this inaugural function for an extraordinary endocrine update on pediatric endocrinology. And as Nagesh was saying, even though it's a virtual meeting, we're likely to have stellar speakers and world-renowned personalities will be talking on various facets of pediatric endocrinology today and tomorrow. And I'm sure all of us, including me, are going to learn quite a lot from their deliberations and all the interactions of all the other experts in the fields, national and international. I congratulate Dr. Sahai and Nagesh for organizing this event and Osmania Medical College for co-hosting it. And I wish the conference a grand success. Thank you.
Thank you, sir. I would now like to invite our very dynamic president of the Endocrine Society of India, Dr. Sanjay Kalra, to address the gathering.
Thank you, Professor Sahai. On behalf of the Endocrine Society of India, it's a great pleasure being part of this update, which is organized by Osmania Medical College. Osmania Medical College is one of our best academic departments. Hyderabad city is one of the most dynamic cities as far as endocrine care is concerned in India. And Telangana state is second to none in terms of the quality of care that is prescribed. Endocrine challenges are becoming more and more. The field of endocrinology is becoming more vast by the day. But the world is becoming smaller thanks to modern technology. And thanks to this, we're able to have the best speakers from across the world, the best experts to share their views with us. So today and tomorrow, we'll have very good sharing of information and knowledge, thoughts between Indian and foreign thought leaders, which will help not only the Indian students and the Indian faculty, but the entire endocrine and pediatric endocrine fraternity of the world. A warm welcome to all our guests from the Americas, from Europe, from United Kingdom. We wish you a happy and a fruitful endocrine update with us this year. And we hope that we are able to invite all of you in person next year, the moment things come back to normal. So once again, a warm welcome to all our faculty on behalf of the Endocrine Society of India. We wish the endocrine update, the pediatric endocrine update, all the best. Thank you and Jai Hind.
Thank you. Thank you, Dr. Sanjay Kalra. I would like to now invite our President-elect of Endocrine Society of India, Dr. Ganapati Bantwal, to say a few words.
Thank you, Dr. Rakesh. Respected dignitaries, international faculties, and my dear friends. So on behalf of ESI, it gives me immense pleasure to be a part of this inaugural function of the 6th Endo Update conducted by Osmania Medical College under the stewardship of Rakesh Sahai and team. This is an annual event. Last year we had done the adrenal update, and this year the theme has been on pediatric endocrinology, and for which we have a galaxy of stars already, which has been described by Dr. Nagesh. I think the young endocrinologists will be really privileged to listen to them and improve upon them. And I think tomorrow's program on oral presentations and posters, I think that's another very important thing. I think the focus should be on that also for the future ones also, so that we can improvise on and we can stimulate our postgraduate students also to do more of original work. So that's one important aspect I felt, which we are doing it tomorrow. So I wish you a success for this academic feast and hope to see you in physical form next year. So thank you once again for all of you. Thank you.
Thank you, Dr. Ganapati. Thank you for the kind words. And then I would now like to invite our Secretary of the Endocrine Society of India, Dr. Sujay Ghosh, who's going to address all of us. Dr. Sujay.
Thank you so much. A very good afternoon. And first of all, I would like to thank all the international faculties for having agreed to be part of this meeting. We are really, really privileged. And of course, a big thank you to Team Osmania led by Professor Rakesh Sahai, and also Dr. Nagesh has helped in actually putting the meeting together. Pediatric endocrinology is probably one of the relatively more neglected areas of endocrinology. You have so many meetings on diabetes, thyroid, even bone metabolism, but seldom do we have a meeting on pediatric endocrinology alone. So that itself is a very novel idea. I think the entire team should be congratulated for that. And over the years, USV is actually been supporting this program of Endo Update. I still remember we did the pituitary meeting in Kolkata, like Dr. Banpal was talking about the adrenal meeting in Bangalore. So I think we need to thank the sponsors as well for having supported, programs which has nothing to do with their products, which is relatively rare in India. So that's something that I would like to congratulate them on. And of course, we look forward to welcoming the same group of international faculties again next year to India. Thank you very much.
Thank you, Dr. Sujay. I would now like to invite the president of our Telangana Society of Endocrinology, Dr. N. Sudhakar Rao.
Dr. Sahai, thank you. Dr. Shishikala Reddy and Vipin Sethi, Dr. Babu, Dr. Ganpati, Dr. Sanjay Kalra, Professor Sujay, and Rakesh Shah, and Dr. Nagesh, and other international faculty, national faculty. It is a pleasure to associate with inauguration of Endo Update, which is virtually occurring at Hyderabad, under Usmania Medical College. I have studied my MD from Usmania Medical College. That is one of the important area. Done as endocrinologist for some time there, before moving to Gandhi. And I welcome the international faculty and also the national faculty. It is a pleasure to associate with this. Actually, we would have been physically at Hyderabad. Hyderabad, you would have tasted the hospitality of the Hyderabad, which is great. And hospitality of Hyderabad, especially biryani also. Both of you are missing, all of us. And I feel the scientific session as narrated by Nagesh, which was done excellently by Dr. Sarakesh and other Bipin Sethi, and it is a very good one. And I wish success for the conference and proceedings to go on well. Good luck. Thank you.
Thank you, sir. I would now like to invite the principal of Osmania Medical College to say a few words. Dr.
Rakesh.
Yes, a very good afternoon to all of you, to all the distinguished guests from all over the world and also from India and from Osmania Medical College. It's indeed a great pleasure and privilege and an honor for me to be here with all of you. I would actually like to sincerely express my gratitude to all the eminent physicians from all over the world who are here to share their knowledge and guide our young endocrinologists. So on behalf of all the young endocrinologists, I express my sincere gratitude. Most of those present here today are leaders in the field of endocrinology, and we are indeed fortunate to learn from them. I remember what the eminent British statesman, Mr. Churchill, had said once. He used to say that I'm always ready to learn, although I do not always like being taught. So here's to many hours of wonderful hours of learning from these eminent people from all over the world. Actually, to be a teacher of medicine, the doctor must always be a student. So this should be the spirit of a good scientist, because in science, the absolute truths of today are always the relative truths of tomorrow. So today's endocrinology endo update is an excellent choice of topic, because pediatric endocrinology is a source of stress and anxiety to the parents, and it's actually a source of insecurity to children the world over. I appreciate Dr. Rakesh, Dr. Sri Nagesh, and other organizers in bringing this together, and I thank them for making me a part of this. All the best, and thank you very much.
Thank you, madam. Thank you for the kind words that you've given us. And I once again thank all the faculty, all the international faculty who have joined in today in the inaugural function and who are going to be with us for the next 2 days, and who have joined in spite at being in different time zones. Some of them are joining us very early in the morning. Some of them are at in the afternoon. But it's a great. But I mean, stressed to join early in the morning, but I sincerely appreciate their efforts in joining us here today. And I thank all the national faculty members, all the distinguished faculty members from across the country, distinguished professors from all the institutions across the country who are going to be part of the program, for having accepted for being part of this program. And then I also thank our sponsors, USV Limited, who have extended a unrestricted grant for this meeting without any conditions. And so therefore I thank them for the support rendered. Then I would like to also thank all the participants who are here, because without the participants there is no meeting without having enough participants, or participants who are listening to the program. So I thank all of you, and with that I think I would like to request the video of welcome of the Endo update to be played once.
Endo Update is an exclusive program organized by the premier teaching institutes of India for endocrinologists from across the country. Journey of Endo Update started in the year 2015 with a focus on one gland every year. Since then, adrenal gland, pituitary gland, gonads and bones, and minerals are covered. Endo Update has been graced by 24 international faculties and more than 1,200 delegates till date. 75 endocrine topics have been discussed for more than 80 hours. Regional Medical Councils of India has awarded 24 credit points to the program till date. More than 100 posters and oral presentations have been presented by postgraduate students, and Best 3 are being awarded every year. Endo Update has been rated one of the best platforms for clinical endocrinologists within India. Department of Endocrinology, Osmania Medical College, Hyderabad, a premier teaching institute of India, welcomes you all to the 6th Endo Update, which is focused on pediatric endocrinology. 6th Endo Update is graced by 7 international faculties and 6 master plenary sessions. We once again welcome you all for this academic feast in the next 2 days. Institute of India welcomes you all to the 6th Endo Update, which is focused on pediatric endocrinology. 6th Endo Update is graced by 7 international.
And now we will move on to the sessions, and I would like to invite uh, Mohan Chennai, the rapporteur for the first session, to take over and invite the chairpersons and the panelists.
Good evening, everybody. So I'm an endocrinologist based in Trivandrum. I also see pediatric cases. So we are here gathered today in a virtual platform with 2 days of academic festive activities. So the session 1 will focus on growth. So I am the rapporteur. I will be available here to mingle with the chairpersons and the panelists, as well as introduce them to you. So without wasting much time, let us have the CV profile of our faculty. The chairpersons for this session focused on growth would be Professor Rajesh Gatkawat. He's a professor of endocrinology and metabolism at the All India Institute of Medical Science, New Delhi. He has published several papers and he has also presented several articles. And you can see that most of his papers are also gathered best paper awards as well. So the next chairperson for you is none other than Professor K.V. Subramaniam sir. Sir is the professor and HOD of Department of Endocrinology, Andhra Medical College, Visakhapatnam. He is a life member of ESI, IMA, ITS. He has also organized several diabetes prevalence programs in and around Visakhapatnam. He is also very active because he has gathered a lot of interest in thyroid by devising a thyroid RIC index for identifying patients with thyroid disease in the community. So we are giving a stage to you, sir, and we are also having 3 panelists. So introduce them as well. I think the speakers will be introduced by the chair themselves. The panelists for you are from various institutes. The first one would be Professor Shubhankar Chowdhury. Sir is a professor and HOD of IPGMR and SSKM Hospital, Kolkata. He is a past president of Endocrine Society of India. He is also patron of the SAFIs. He has been the president and he's still the president of ESB. He is the editor-in-chief of the IJEM. So I think he has got many publications in peer-reviewed journals. He is an active academician as well as a research guru. He is interested in gut microbiome and gestational diabetes mellitus. He is also focused on pathogenesis of Graves' orbitopathy, biology of fat in different compartments. The next panelist, Dr. Professor Tushar Bandar. He is MDDM. He is the professor and HOD in KEM, Bombay. He is investigator and co-investigator in several journals, several trials of the short stature, that is a Genesis trial, the Gilead trial for the type 2 diabetes, the Pfizer type 2 diabetes study, the dual study, and also IDAV study. He's also conducted the study called Living, a lifestyle intervention program for the prevention of type 2 diabetes in South Asian women with gestational diabetes. He has published 124 articles. I think you can just rewind 2 slides. I think we have missed the one. I wanted that 2 more slides behind this. Yeah, Professor Anil Bansali, sir. He is the one who has published recently for our PG students and DM students 2 books, clinical rounds in adult as well as in pediatric endocrinology. He is the panelist. He is a revered teacher. He is professor and HOD in Department of Endocrinology at PGIMER, Chandigarh. He is president of ESI in the past. He has also got the P.N. Shah Oration Memorial in 2007. He is recipient of the prestigious Professor M.N. Sain ICMR Award 2009, as well as the M. Vishwanathan Award by the RSSDI. He has got a lot of publications. To count his publications, it would be above 500. So the top index of him is H index of 45. So I think I should hand over to the experts themselves. Professor Rajesh Katkawat and Professor Subramanian, the stage is yours.
Yeah, thank you, Dr. Mohan. I welcome Dr. Subramaniam in chairing this session for a very noble speaker. My job is very easy as each and every medical student all over the world knows our speaker, Professor Javi Laron, because he was the first person who described Laron's dwarfism, what we call as primary IGF-1 deficiency. Professor Laron is Professor Emeritus at Tel Aviv University and have received numerous awards, has a lot of publications. I cannot list them all because time would be very short. So it's my proud privilege to invite Professor Javi Laron for his lecture. Professor Laron, welcome.
start? Okay. מה קורה שם?
אם אתה רוצה, אתה עושה על enter.
מה? נו, אני צריך לדבר.
כן, אתה יכול, תדבר.
Hello, I'll start now. I would like to thank the organizing committee for inviting me to this important endocrine meeting, which unfortunately will be Zoomed and not be present in person. I would like to tell you about our 6 years follow-up of patients with Laronde syndrome and how we came to discover it and how we developed its treatment. In 1958, at a time when no assay for human growth hormone was as yet available, 3 siblings, aged 3, 5, and 1.5 years, and a newborn baby were referred to me. They belonged to a consanguineous family of Yemenite origin. Their appearance, dwarfism, obesity, acromegalia, hypogenitalism, and the history of severe hypoglycemia resemble children with pituitary hormone, growth hormone deficiency, as you can see on the right side of the picture. In the early 1960s, few years afterwards, when radioimmunoassays for growth hormone became available, we found to our great surprise that the circulating growth hormone was very high, reaching acromegalic levels, as you can see, up to 140 and even more nanogram per milliliter. We also studied by measuring every 10 minutes over 24 hours growth hormone secretion. We found that as similar to normal patients, they are a growth hormone which is secreted in pulses, but the peak pulses reach 300 or 400 nanogram per milliliter, especially at night. The 2 graphs here and the control on the bottom of the right illustration. We concluded that we have discovered a new syndrome involving human growth hormone. We submitted the paper to the Lancet, and Lancet refused to accept it, telling us we should try another journal. Therefore, we published it in the Israel Journal of Medical Sciences and said that we had a new inborn error of growth hormone. We envisaged 2 possibilities. 1, an abnormal molecule of AGH, or 2, lack of responsiveness to the target organs, naming resistance. It lasted 20 years to prove scientifically which of the 2 possibilities were right. We found by immunological and radioreceptor tests using human or rabbit receptors obtained from human livers in case of kidney transplantation, and found by a variety of tests that the human growth hormone of this patient was of normal behavior and structure. These findings were interpreted as evidence that these patients have a defect in the growth hormone receptor and that the disease is caused by growth hormone resistance and not an abnormal growth hormone. It took again some time until 2 families agreed to have the livers of 2 of their children tested. We prepared the membranes of the liver of these patients and found that radioionated growth hormone did not bind to these membranes, in contradistinction to the controls, as you can see, and to the right, no binding of growth hormone to the receptors of these patients. To prove that this tissue is biologically active, We also tested insulin binding and found that the insulin binding is normal. Therefore, we had a definite show that this is a resistance at the liver level. Cloning of the growth hormone receptor gene by Leung in 1987 and its characterization in 1989 by Godowski et al. From our patients, as well as new laboratory technologies as PCR, enabled the study of molecular defects of the growth hormone receptor in this disease. The growth hormone receptor, as cloned by Leung, gene is located on the short arm of chromosome 5. It has 620 amino acids preceded by a cedar sequence. It consists of 9 exons and is divided into 3 domains. The extracellular domain from exon 2 to 7, exon 8, the transmembrane zone, and exon 9-10, the intracellular domain. An interesting finding was that the extracellular domain is identical with the growth hormone binding protein. Thus, if growth hormone binding protein is low, we know that there is a defect in the extracellular domain. This illustration shows that there are also gene deletions. We see here that exon 3, 5, and 6 deletion in some of our families. And this picture shows that if we do total exome examination, we found a series of mutations. At the present time, there are more than 70 growth hormone receptor gene defects. The majority of them are in the extracellular zone, mainly exon 6 and 7. Now, we know, as I said before, that patients with molecular defects in the extracellular domain present low or undetectable growth hormone binding protein. Defects in the transmembrane or intracellular domains, as well as post-growth hormone defects, have normal or high serum growth hormone binding protein. The definition of Laron syndrome can now formulate it as follows. Short stature, -4 to -10 SDA as the height, low to undetectable serum IGF-1, which does not rise upon the administration of exogenous growth hormone, as seen on the illustration on the right side. The lower part shows no response in patients with LS. The upper part shows that growth hormone deficient patients respond to growth hormone by a rise in IGF-1. Our cohort so far consists of 75 patients, and the age at referral, as you can see, was a young age, below age 9, the majority. The gender distribution is equal, and in the beginning, there were patients who came as adults. There was no IGF-1 available until 1989. The age distribution at present shows you that the majority are over 20 or 30 years old. Therefore, we could follow up many patients, both who were untreated in childhood, as well as patients who were started to be treated at a younger age. The ethnic origin of these patients were a majority of Oriental Jews from the Mediterranean area, also from Syria, Lebanon, Afghanistan. There were also many Muslims, 1 Druze, 22 Christians, and you may be interested to see that we also followed 2 patients for Hindu. The disease is recessively inherited, and we can see the illustration of the families, which are consanguineous. The family in the middle shows that heterozygous family members had a high growth hormone binding protein, and this was a family in which the patients had a defect in the transmembrane domain. Now I would like to present you clinical findings of this syndrome. The deliveries were uneventful. Some mothers decided that the fetus had weaker movements than that of their normal siblings. The birth length in the majority was 42 to 46 centimeters. The same was found also in other countries where the diagnosis was made. Birth weight is normal, and as I show you, this is because the adipose tissue was already well developed in utero. There are other typical signs. As you can see, the head, seen from the lateral view, shows that there is a protruding frontal bossing due to the underdevelopment of the lower facial bones. Nevertheless, when we measured the head circumference, we see that the head circumference was either below normal or at the limit of normal. We see on the left side picture also that the hair is very sparse. And on the right side, we see that the hair is abnormal and has breaking when observed by electron microscopy. Looking at the face, we see that the patient on the left has blue sclerin. But we came to learn that this is not typical of the patients as described in the early phase, but is a feature of the whole area of the Middle East and Lower Asia. We see that the teeth are crowded because of the small facial bones, and in early age in the middle, they are defect, both because of the crowding, but also because of the hypoglycemia. Babies and young infants are fed more frequently with glucose. These patients, similar to growth hormone deficient patients, have also defects in their hearing. And in this illustration I show you that when early treated, there may be some repair of the hearing defect. The marked description shows that these patients are dwarfed. And on the left side, we see that very shortly after infancy, they slow more and more their growth velocity. We, from the patients who were untreated, we designed a new graph, specific growth chart for this syndrome. And as you can see, even their upper 2SDs is below the third centile from Tanner. Nevertheless, as we can see in the middle picture, they still grow. And you see the difference in loss due to congenital IGF-1 deficiency is expressed as a difference between the 2 girls of the same age. The heterozygous member of this family, the parents and siblings, we see that the females are below the 50th centile, but some even below the 3rd centile. The males are all below the 50th centile, but fit in the low normal range. When we measured the ratio between the upper body to the lower body, upper-lower segment ratio, we found that these are higher than normal, as shown by the picture on the left side. And this denotes that they have shorter limbs compared to the trunk. This in contradistinction to what is mentioned in many textbooks, that children with growth hormone deficiency, therefore also IGF-1 deficiency, are symmetrical. In the middle, we see that they also have small hands, acromicria. We see the comparison between the hand of a 4-year-old patient with LS to that of a normal child of 2 years. The same is true also for the foot size on the right. They also have genitalia which are smaller than normal, both at early age and later on, both in boys as well as girls. They also have a delayed puberty, and we can see that the males on the left side grow until the age of 20, and the girls earlier, up to the age of 18, 19. The major thing is to see that the aged menarche, which is the biological equivalent for development, in girls is spreading between the age of 30, which is normal, but also up to the age of 18. In boys, the equivalent is the first ejaculation or spermarche is also delayed. Not only the general spectral development is delayed, we can see here that the penile length in boys is low, as well as the testicular volume. Nevertheless, as seen in the right picture, they developed full sexual development, and some of the girls show even large breasts, which may be due to hypersecretion of prolactin, as we know that there are cells in the pituitary, somatomemotropic cells, which secretes both growth hormone and prolactin at the same time. All of our patients, the adult patients, had sexual relations, and a large proportion, we can see here that 20 are married, reported sexual, and 10 are married, and 9 have children. Nowadays, we have performed pregestational diagnosis and prevent the birth of Laron syndrome patients in families which are consanguineous and implant only the normal embryo. We can see here that if the patients, in this case 2 girls, marry normal individuals, they can have also quite a few children. But now, as I said before, with pregestational diabetes, we also helped couples who were heterozygous to have a normal child. The nutritional state is quite highly developed. As you can see already from the infant, has a double chin. And here you can again see the sparse hair. Becoming adults, we see that all are very obese, and the females can show up to 60% of their body volume is fat. And you see on the right side, both the adipose tissues as well as the visceral fat are highly developed. This is also accompanied by raising values of serum cholesterol and also causing fatty liver in the patients that we examined. Now, due to the hyperinsulinemia, which follows the adiposity, they develop abnormal oral glucose tolerance tests, as can be seen already in pubertal age. And subsequently, around 40 years, they develop also type 2 diabetes. If not treated, they develop the complications as renal complications as well as diabetes retinopathy, as I will show you a little bit later. We also found that these patients have a high adiponectin. And here we compared, so you can see how the difference between LS patients who have 60% the female, 60% body fat, with obese females who have a normal, also the same amount of body fat, but the adiponectin is double in the female adipose, in the female LS patients. You see that also on the right, that the male LS patients have double the adiponectin levels than the normal controls. The controls, simple obesity of the same degree of obesity. Now, doing imaging by X-ray, CT, and MRI, we found that quite a few things. Namely, the skeletal maturation is delayed, and also the sutures are united at a much later age, as well as the fontanelles. We can see that when we do the skull X-ray, that they have underdevelopment or deficiency of the sinuses. There are also lacunar infarction of the caudal nucleus, or leukomalacia, or hypoplastic corpus callosum. We can certainly also think, as I will show you later, there are consequences to these developmental changes. Interestingly, that some of them also have EEG findings, and 2 of these patients had developed status epilepticus. In the skeleton, we found that they cannot really straighten out the arms on the left side, and they have stenosis, spinal stenosis, as seen in the right, which causes neurological disturbances at later age. Simple DEXA showed that they have osteoporosis, but when correcting this for the area, the bone composition is normal. Taking the blood chemistry, the idea is, as I showed you before, due to the adiposity, they have hyperinsulinemia, and in the early ages, they have low blood sugar, which I will show you is not insulin related. Examining the vessels of the eye, we see that the Laron syndrome fondi have a lower number of vascular branches than the controls and normal fundus on the left. The 2 patients who did not follow a good metabolic control of diabetes developed diabetic retinopathy, as seen on the right. Also, the cardiopulmonary system has its lower output of the left ventricle, and the pulmonary function showed a reduced maximum aerobic capacity and resting blood pressure that is normal, as seen on the right. Their heart also shows as other organs are smaller than normal, showing organomicria, the same as acromicria. Due to the findings in the brain, we also examined the intellectual capacity And here I show you a series of patients who were examined twice after 10 years interval. You see the IQ full scale is lower in the first examination and remains stable in 10 years later. However, distinguishing between verbal and performance IQ, we see that with time the verbal IQ can improve, not so the performance. But let me say that not all patients have a low IQ. We have 3 patients who went to the university, and 1 patient has even a PhD. Now, with the start of getting clinical grade IGF-1 in 1981, the Israeli quarters, we were able to start treatment. We have treated so far 23 children and 5 adults for 1 year. We couldn't get permission to treat them for longer periods. As you can see on the left, the structure of IGF-1 resembles very much that of proinsulin. And on the right, you see the first injection. I closed my eyes because I didn't know what to expect as the result of that injection. On the left, we can see that both insulin, growth hormone, and also glucose were reduced. And this is better shown on this slide. We see that glucose and insulin are suppressed at the same time. This is due to stimulation of somatostatin by IGF-1. And we can also explain now that the hypoglycemia seen in infants is not due to hyperinsulin levels. And interesting, here we can see that following up patients, IGF-1 treatment causes an increase in the growth velocity. And on the right, you see that 1 patient reached almost the same growth as a patient with isolated growth hormone deficiency, but most patients are below and do not reach a final height similar to those treated by growth hormone. In contradistinction, the smaller growth head circumference increased very quickly, denoting that the brain responds very fast to IGF-1 therapy. This is also seen in the acromicria, but what is important that IGF-1 does not reduce the adipose tissue. In the contrary, it increases it, as is also seen in long-term treatment of growth hormone. Interestingly was to find that IGF treatment increased the hemoglobin and the number of red blood cells, but this we found is not due to erythropoietin, but clinically this is not exploited as erythropoietin is used and more active. If one administers higher doses of IGF-1, there are a series of overdosage. And here there is 2 schools of treatment. The producers give 2 twice a day injections because they thought that the half-life of IGF-1 is relatively short. We found that 1 injection a day suffices to get the same results. If you give 2 injections a day, you have more adverse effects than when you give 1 injection. And one injection a day has to be given during feeding because, as I showed, IGF-1 induces hypoglycemia. Now, among the adverse effects found with increased dose are hypoglycemia, headaches, papilledema, or because of water retention, widening of the nose as shown on the right side, and if you stop treatment or decrease the dose, you get again a normal stage. Interestingly, there is also hyperandrogenism, so that you can get acne and therefore decrease the dose. Mortality we found only in 5 patients so far, and the oldest one died on a road accident. The first patient we didn't see is the sister of one of our patients, and she was supposedly dead because of encephalitis. I think that they are hypoglycemia. Also, many deaths in the Ecuadorian group died of hypoglycemia. One of the most interesting findings that we found is that patients with Laron syndrome are protected from developing cancer, whereas their heterozygous family members are not. Also, patients with congenital isolated growth hormone deficiency or GHRH receptor defects, if they secrete the smallest amounts of growth hormone, they are not protected. Here we can see that first-degree family members in total of all these diagnoses develop malignancy, and even if we examined only compared the siblings only, not the parents, we see also that the siblings had an increased number of malignancies compared to the patients who had none. Using immortalized cells from these patients, we are trying to elucidate the enigma, why these patients do not have cancer. We are working together with Professor Hai Werner of the Human Molecular Genetics Biochemistry Department. We see here, when we look here at the chip analysis, that the number of genes these patients have is reduced compared to the total gene number of controls. We can also see that looking at various genes, there are differences between the controls and the LS patients. In some, they have more of one, or in others, less. To summarize this examination, we can see here that patients with LS have an increased number of tumor suppressors genes, whereas the heterozygous relatives have a reduced number of these tumor suppressor genes. In contradistinction, the LS patients have a reduced number of oncogenes, and their relatives have the opposite. So I can say that we are really lucky to go through this syndrome with our first observation from 1958 to description 1966, to finding out with the help of Doede, who has discovered the IGF-1, that they lack IGF-1 synthesis, finding by liver biopsy in 1984 that they have a defect in the growth hormone receptor, and in 1989, being the first to start IGF treatment, learning both the physiology as well as the pharmacology, and also the sequence of not having congenital IGF-1 as shown before. I would like to show something in other, that as you may know, that neighbors from your country found a skeleton on the island of Flores, 18,000 years old. When we looked at the skeleton and compared it to the bones of the skeleton of the x-rays of our patients, we found that they are similar. Therefore, we developed a following hypothesis, that the founder gene of LS is in Indonesia. And during the centuries along the Silk Way, Spice Way, started to wander westwards to Indonesia, Cambodia, Vietnam. There are patients. In your country, there are many patients. And then to the Middle East, Afghanistan, Iran, Turkey, all these patients to the Mediterranean area where there are quite many patients. From the Mediterranean area, Morocco, Spain, in 1492, the Jews fled the Inquisition to South America and the Caribbean. And we found that the same gene as the patients in South America have, like the cohort in Ecuador, is the same gene, only one gene, that we found in Moroccan Jews, which are of Spanish origin. This proved that their gene wandered from the Mediterranean to South America. I just want to show you of the distribution of patients reported from your country. And as a total of patients, there are, what we know, over 500 or 600. There are patients who in various indigenous families where there is consanguinity but are not reported. And here is another proof that in the Middle Ages in Italy, and Professor Chiarelli may recognize this lady, 1463, went to Italy, and here you see the large cohort from Ecuador with the same gene as the Jews in Spain. As you may understand, all these studies were done by groups, and I would like to recommend by Talia Perzelan, Aviva Silberger, that the studies on the IGF-1, Rina Esche to compare the biopsy, Carrot, Pellet. I want to thank also Professor Day, who helped develop the growth hormone IGF-1 stimulation test, Godowski, who helped us with the structure of the growth hormone receptor gene. And there are many more, which I cannot mention in the short time. Lately, Professor Kopchik and his group in Ohio knocked out the growth hormone receptor gene in mice and developed the Laron mouse. Recently, the same technique was used in pigs in Munich, and there is now also a growth hormone receptor knockout. Well, thank you for your attention, and I would be very glad to learn from patients that you have diagnosed in your country. Thank you.
Thank you, sir. Thank you very much for this elaborate and very knowledgeable exposition. And I request invite questions from delegates.
Pardon?
Request questions from the delegates. Sir, before waiting for the questions, can I ask you one thing, sir? I am the co-chair with Rajesh. Sir, how do you want to follow up these patients? How do you want to follow up?
Pardon?
How do you want to follow up these patients? Follow up these parents, your patients? Yes, as with the other therapies are.
No. We see Almost all of the patients.
Yes, sir.
There are only 2 patients followed in other clinics.
Yes, sir.
Yeah, Professor Leron.
Yes.
Yeah, are you able to hear me, Professor Leron?
Well, I can't
Are you able
understand.
to hear me,
Yes, yes. Yeah.
Professor Leron?
Yes.
Yeah, so now you must be dealing with second generation of these patients.
I can't. Can you type out your questions?
So are you now you are dealing with second generation, their kids also.
Doshani. You're dealing with second generation.
Sir, otherwise,
Second
sir, he says,
The
sir, he
second
says,
generation of whom?
you are following these
patients with
patients,
Laron
and the next
syndrome.
generation also come up. Children of these patients.
Laron syndrome. Doshani Sheshlam.
There is, well, they are, we are preventing that patients who have Laron syndrome should marry other patients with Laron syndrome. So we don't have patients of the second generation. We have the patients who have married, but to normal persons.
So are you doing antenatal diagnosis?
We are doing pre-gestational diagnosis.
No,
And,
during pregnancy.
preventing more patients.
Okay. So there are any questions from the participants?
Sir, there is a question, sir. Can I share the question? It is there on the
Yeah,
screen.
sure. Please go ahead.
It is there on the screen. Professor Laron, there is a question on the screen in the chat box. I will read it for you. Can GH resistance present without acromegalia? And what protocol of generation test
Second
adopted?
generation, I replied. The first question was growth hormone resistance without acromegalia. No. The approval for IGF-1 generation test is we give 5 milligrams of growth hormone for 7 days.
I think we are awaiting more questions, sir. Yes, sir.
Can I ask a question?
Please, sir, carry on.
Yeah, go ahead, sir, go ahead.
Professor Zvi, thank you very much for an excellent lecture. This is Khalid from Qatar. I'm fascinated to hear about the mechanism of hypoglycemia.
Somatostatin suppression, stimulation. Stimulation of somatostatin.
Does IGF suppress or increase somatostatin? What does IGF-1 do?
It increases somatostatin, as I told you.
Okay. And that suppresses glucagon? Is that why they become hypoglycemic?
Glucagon, there are few changes, not much.
Okay. All right, thank you.
So there is another question for you on the chat box. How could Professor Laron help in IGF-1 availability in India?
By persuading one of your companies to synthesize IGF-1.
That's a very clever answer, sir. Very nice.
You see, the one problem that I proposed that the patients who are treated and everywhere should receive 1 injection. The pharma told me that in order to accept this, FDA will ask them to produce clinical studies. There are not sufficient patients, and this would cost them a lot. The other question that I raised was why, because we treated 5 adults for 1 year, that also adult patients would benefit to some degree by strengthening their muscular system and therefore mobility and also some of the bone changes. And they told me again the same thing, that to perform this, would cost them a lot of money before FDA would approve it. Of patients, this is not worthy for them.
Zvi Franco speaking. May I ask you a question? First of all, thank you very much. Very nice presentation as always. I wonder if you could speculate why patients with LS could have, obviously we understand why they do have type 2 diabetes, but what I would like you to stimulate the discussion is why they have a major risk of developing complications. Because in theory, there are receptors for the IGF-1 in the kidney. So if these people have less IGF-1, they should develop less diabetic nephropathy.
They have an increased amount of adiposity with an increased amount of insulin, as shown by the oral glucose tolerance test, already in puberty. And further in older age, they develop around age 40, 45, they develop type 2 diabetes and need therapy. Oral therapy, in a way, is the regular thing. And as I showed you, if they are not well treated, they have the complications. The same is true. Go ahead.
Sorry. In theory,
Franco, continue.
If they receive IGF-1, they should be in some way protected by the complications?
No. The hyperinsulinemia, insulin also acts via the IGF-1 receptors. So that hyperinsulinemia, we know it very well, that this must be the insulin and not directly the IGF-1.
Okay, thank you.
So
Now,
Dr.
as
Mohan,
you took
we have,
the coat, I'll take it off.
so Professor Leron, there is one more question. Professor Leron.
Yes,
sir,
I'm
ahead,
here.
sir.
I'm here.
Yeah, so do dysmorphic features of Leron syndrome differs from that of features of isolated growth hormone deficiency?
In general lines, patients with congenital IGF-1 deficiency resemble the same. But now we know that patients with congenital IGF-1 deficiency or infantile growth hormone deficiency are treated immediately. So all these abnormalities seen with IGF-1 deficiency who are not treated are not seen with growth hormone. Growth hormone is available for many years, since 58, 59, and slightly later being available to since 85, when it recombinant it was available. All the patients are treated. So we do not see what we see in IGF-1, which was available later and not available to everybody.
So there is one more question, sir, on the chat box. This is a tricky one because we know that there are many molecules that are available under low cost.
No. I have read Dr. Azar's paper. I wrote to her indirectly because we do not have, we have, let us say, indirect relations with doctors in Iran. And she did not reply whether she has followed the patients, because there are many patients, very many patients in Iran.
Yeah, this is a question
So far
because
I know they're untreated.
Yes, sir. This question was regarding cyproheptadine because that is a very commonly used and misused for getting people. So I think we have Dr. Nia had asked this question. So I think the chairpersons can decide if there is time. I think I handle it over to them, sir.
Yeah, Dr. Mohan, I think we are already over. So I think we can thank Dr. Leron for a wonderful lecture. And Professor Leron.
Yes, I hear you.
Thank you very much for a wonderful wonderful lecture.
Thank you.
So thank you very much.
Thank you.
Thank
So
you, sir.
now I invite my second chairman, Professor Subramaniam, to introduce our second speaker, Professor Stefano. Dr. Subramaniam, please.
Yes,
Very
I'm
good
here.
evening. Very good evening. I welcome Professor Stefano Ferrani, full professor of pediatrics in Tor Vergata University, Rome, Italy. He is the chief of the diabetology and growth disorders unit at the Bambino Gesù Children's Hospital, Rome, Italy. Visiting professor at the Department of Women's and Children's Health, Karolinska Institute, Stockholm, Sweden. He is the editor-in-chief of Hormone Research in Pediatrics. And with this, I request Professor Stefano to speak about the long-term safety of growth hormone therapy in childhood. Professor Stefano, please.
Yeah, I try to share my screen.
Yes, please. Yes, you are on the screen. Please
Okay.
share the screen, please.
Okay.
In the Indian fora also, as far as growth hormone therapy in our growth hormone deficient children, as well as both growth hormone deficient, as well as those indications where there is no growth hormone deficiency, but still we use growth hormone for improving the height of the children.
Can you see the
Stefano
slide
is
now?
already on the line.
Yes,
Please,
sir. Yes,
please,
sir. We can see you, sir.
Okay, very good. So first of all, I'd like to thank the organizers, especially Dr. Sri Nangresh, for inviting me. I'm very pleased, a honor to take part of the faculty of this meeting. And as you see, I try to touch some issues related to the safety, the long-term safety of GH treatment for childhood onset GH deficiency, mainly reporting the results from this European consortium project called SAGE. The experimental evidence in favor of a role of growth hormone in developing cancer is quite strong. This is one of the first evidence showing that the transplantation of mammary cancer to a rat, you see the wild type Sprague-Dawley rats, and then the spontaneous dwarf rats. So dwarf rats means that these rats had no pituitary in their body. See, the development of cancer was much increased quite fast in the wild type rats in comparison with the dwarf rats. This is just one of the many actually observations showing that the growth hormone, as well as IGF-1 and IGF-2, can play a role in the development of cancer in animal models, as well as in cellular models. As Professor Lauren already mentioned, there is also epidemiological evidence in humans showing that actually the children, or better to say, the individuals, the patients with the growth hormone receptor deficiency, actually this is the Ecuadorian cohort, followed for a long time. You see they show quite, as expected, quite low levels of IGF-1 and IGF-2 in comparison with their non-affected relatives. But the observation for this Ecuadorian cohort was that actually, if you look at the causes of mortality in the non-affected relatives in comparison with the affected patients with the growth hormone receptor deficiency, you see that the prevalence of cancer, death for cancer, is almost nil in the affected patients. And you see here in the bar column the cancer in the relatives, and almost no cancer at all in growth hormone receptor deficient children, patients. Just to remind you, the axis, the growth hormone IGF-1 axis, starting from, of course, first of all, hypothalamus and then pituitary gland. And then we know that there is a specific, actually, stimulation of IGF-1 expression, production, and release from liver, mainly from liver, but not only from liver, because we have IGF-1 expression and production even in peripheral tissues, many different peripheral tissues, but mainly from liver, at least the IGF, the circulating IGF-1, which we can measure in the blood. The IGF-1 and IGF-2 circulate bound to IGF binding protein, and then after the detachment of IGF-1 from IGF binding proteins, there is the final biological action of insulin-like growth factors, mainly IGF-1, in peripheral tissues, including epithelial cells as well as stromal cells. And if the final action, bioaction of IGF-1 and IGF-2 is mediated by a network of post-receptor signaling, and you see that the final effect will be the reduction of cell apoptosis, a stimulation of protein synthesis, and a stimulation of cell proliferation. So this biological action of IGFs actually tell us that the potential role of IGFs and then the IgH, IGF-1, and IGF-2 axis is not involved in the transformation of a normal cell to a cancer cell, but just to increase the proliferation of an already transformed cell. As you see in this slide, actually, when the transformed cell, already cancer cell, is exposed to in an environment with high IGF-1 levels, of course, the proliferation rate and survival rate is much higher in comparison when the cancer cell is exposed to a lower IGF-1 and IGF-2 environment. So the final point is that GH as well as IGF-1 are not able to transform a cell, but are able to produce an environment which is prone to stimulate the proliferation of an already transformed cancer cell. From an epidemiological point of view, there are many observations linking the levels of IGF-1 in blood and the incidence of different cancer. In this slide, you see that the relative risk of developing prostate, breast, and colorectal cancer is higher in individuals with higher IGF-1 levels. And if we look at the risk of cancer in acromegalic patients who actually have a spontaneous increase due to the, of course, the tumor of GH and IGF-1, they show that they are at higher risk of developing colorectal cancer as well as thyroid cancer. This is a meta-analysis and systematic review of recent literature. So we can say that the hazard risk for the association between IGF-1 and all-cause mortality has a U-shaped curve, which means that the higher risk is related to the very low or very high levels of IGF-1, and the very low levels are associated with the cardiovascular risk, whereas the higher levels are associated with the cancer risk. This is one of the first, probably the most important paper published in the long-term observation of patients treated with a growth hormone for childhood onset growth hormone deficiency. In this case, the treatment was done with a human pituitary growth hormone. And in this paper published in Lancet in 2002, you see that the incidence of colorectal rectum cancer was significantly increased in patients treated with growth hormone, with pituitary growth hormone, in terms of standardized mortality ratio and standardized incidence ratio. And the mortality as well was significantly increased for colorectal cancer and Hodgkin disease. Of course, I mean, if you look at the absolute number of cases, you see that the absolute number of cases is very low, just 2 against an expected number of 0.18. And the same is for the mortality data about colorectal cancer and Hodgkin disease. So although the statistical significance is acceptable, I mean, is high, the overall absolute number of cases is very low. So the key points to consider is that GH treatment causes exposure of tissues to increased GH and IGF-1 levels. Both GH and IGF-1 have the potential to promote tumor growth and progression, but do not lead to abnormal differentiation of cells. So they are not able to transform a normal cell to a cancer cell. Acromegaly is a condition characterized by long-standing excess GH secretion and IGF-1 production, and is associated with increased risk of colorectal and thyroid cancer. So the cumulative evidence from epidemiological studies supports an association between raised circulating levels of IGF-1 and increased risk of specific cancers. Just to give you an overall idea of what I'm just saying is that if we look at the strength of evidence, we see between for the link between GH IGF-1 exposure and cancer risk, we see that the evidence is quite high. The strength of evidence is quite high in vitro and in vivo studies coming from cellular models and animal models. We have a moderate strength of evidence from epidemiological studies in humans. And so far, we have low evidence for association of cancer risk with GH treatment. But this low evidence is also due to the small number of studies. And the other point is that many of the available evidence comes from pharma company sponsored studies. This is the reason why we decided to set up a European consortium, which was funded by a European Commission, including 8 different European countries: Belgium, France, Germany, Italy, Netherlands, Sweden, Switzerland, and United Kingdom. And the objectives of our project were, first of all, to constitute a large meta-cohort of young adults treated with a recombinant growth hormone in childhood, with the aim to evaluate the long-term results of treatment on height, the correlates of height gains with the quality of life in young adults, and, which is the theme of our talk, the long-term mortality and the cancer morbidity and mortality, comparing it with the general population morbidity and mortality. For doing that, we decided to choose 2 main indexes. One is the standardized mortality ratio, which is a ratio between the observed number of deaths in a study population and the number of deaths which would be expected in the same population and with the same age and sex-specific matched population. And the standardized incidence ratio, which is the same, but just for the number of cases, which is, in other words, an index of morbidity for cancer or for other diseases. The overall cohort of patients we collected was subdivided according to the different diagnoses. And we analyzed the cohort altogether. Then we subdivide the cohorts in patients with isolated growth failure, which means isolated GH deficiency, idiopathic short stature, and prenatal growth failure, which means children born small for gestational age. Then another group of cancer patients, and then an intermediate risk group of children with no cancer and with no isolated growth failure. For example, panhypopituitarism, or girls with Turner syndrome, or patients with the Noonan syndrome, or anyway, or chronic renal failures. All the diagnoses in between the isolated growth failure and cancer diagnosis. The first paper which came out from the SAGE consortium was actually a paper from the French part of the SAGE consortium. And probably you remember that it was a paper reporting the mortality in a quite big, quite wide population of children treated with a growth hormone. We are talking about isolated growth failure, so children with isolated idiopathic growth hormone deficiency, SGA, and idiopathic short stature. The cohort was of about 7,000 patients, and the results were that actually 93 of these patients died. And looking at the standardized mortality ratio, the results showed that actually there was a significant increase in mortality for malignant cancer of bone and articular cartilage, as well as for cerebrovascular disease, including subarachnoid hemorrhage, intracerebral hemorrhage, and other intracranial hemorrhage. You see, once again, instead of having a significant standardized mortality ratio, however, once again, if you look at the absolute number of observed cases, the absolute number of cases is quite small. In this paper, there was a correlation between the risk of mortality for cancer and the mean growth hormone doses. So the risk was quite higher in those with who were treated with a dose more than 50 microgram per kilo per day. In the same issue of the same journal, the Journal of Clinical Endocrinology and Metabolism, another paper coming from another side of the SAGE consortium, including Belgium, the Netherlands, and Sweden, reported the number of deaths and the cause of deaths in their registries. And you see that in this case, the overall cohort was of around 2,500 patients. But it is quite interesting that not a single case of death for cancer and cerebrovascular disease was reported and observed in this cohort coming from these 3 North European countries. In 2013, actually, we decided to perform a systematic review and meta-analysis of all available studies about mortality and morbidity in subjects treated with the growth hormone during childhood. And you see that actually, once again, we took standardized mortality ratio as the index of the mortality risk. And we also included studies reporting standardized incidence ratio and the relative risk for second neoplasm in subjects treated with growth hormone. And if we looking at the all-cause standardized mortality ratio in GH-treated subjects, we were able to show in this meta-analysis that actually there was an increase in the all-cause mortality ratio in the 3 papers published until 2013, and it was quite significant, although you see that the standardized mortality ratio confidence intervals went from 1.0 up to 1.3. But if we looked at the single causes of mortality, we didn't find in these previously published papers a significant increased incidence of death for malignancy, and we didn't find a significant increased mortality for cardiovascular diseases. The overall standardized incidence for malignancy which means an index of morbidity for cancer, was just at the limit of significance in the previous published papers. On the other side, looking at the previously reported papers about the risk of second neoplasms in patients treated with growth hormone but with a previous history of cancer, there was a significant increase of relative risk, about 2, with in confidence intervals quite, after all, quite narrow. This increase was quite clear. So the summary was that the meta-analysis showed a significant increase of all-cause mortality, but no significant increase in the malignancy and cardiovascular disease mortality. However, it is important to distinguish between standardized mortality ratio from other metrics, such as absolute risk of a number needed to harm, with the latter being more relevant to counseling patients and families about the risk of therapy. The risk of second neoplasm in patients treated with growth hormone after primary cancer was significantly increased in our meta-analysis. However, this risk in child cancer survivors is higher early after GH treatment, and it tends to decline with longer follow-up. And GH therapy can be considered like an accelerator of the occurrence of second neoplasm. This was then confirmed in studies conducted for a longer period of time, so a longer follow-up, showing that actually after many years, the incidence, the relative risk of second neoplasm in those treated in comparison with those untreated was almost the same. Later on, a Swedish study reporting the mortality, once again, the standardized mortality ratio in individuals treated with growth hormone during childhood, but using a particular continuous hazard function, taking into account the birth characteristics as well as gender, age, and once again, focusing on the low-risk group, which means children with diagnosis of idiopathic isolated GH deficiency, idiopathic short stature, and SGA, in comparison with the Swedish medical birth register and cause of death register. And they looked at the population of patients of about 4,000 patients. You see that the main outcome measure, and there was no change at all, and no difference at all between the observed and the expected death in both males and females. So applying this particular approach, statistical approach, which takes into account the birth characteristics, specifically the birth length and birth weight, this Swedish group was able to report no difference at all in mortality ratio. So compared with the general Swedish population, the ratio of observed and expected deaths was not increased at all when applying this new model, adjusting the results according to birth characteristics. In 2017, the Genesis study, Eli Lilly sponsored study, reported standardized mortality data about a quite large population. We are talking about around 9,000 GH treated patients. And what they found report was that the standardized mortality ratio was increased only in patients with organic cause for GH deficiency. So patients treated with GH, but after a history of cancer. And it was just slightly increased, borderline significant, in patients with no history of previous cancer with organic GH deficiency. So what about the SAGE results? Just to remind you that we enrolled patients treated with during childhood with a recombinant GH only. So the initiation of treatment was after 1985. older than 18 years in 2009. They were recruited from national and regional registries or from patient databases collected from large regional centers. And our cohort comprised almost 24,000 patients for mortality and about 10,000 patients for morbidity for cancer. The follow-up was about 16.5 years for mortality and around 15 years for the cancer incidence. The mean age at the end of follow-up was 27 for cancer mortality and 26 for cancer morbidity. This is just what I said. And these are the results. The results show that, first of all, the cohort subdivided according to different countries. This is the most represented age range, which was between 10 and 14 years at the beginning of GH therapy. And the most represented the diagnosis was isolated growth failure, so the low risk group. Then we had Turner syndrome and multiple pituitary hormone deficiency. The fourth group in terms of number was the tumors for central nervous system, including craniopharyngioma. And these are the results. If you look at the results, actually, and you compare the initial diagnosis of cancer to in comparison with the initial diagnosis of non-cancer, which means actually the children with the intermediate risk group, you see that almost all kinds of cancer in terms of morbidity and incidence, mortality and morbidity, actually the risk was increased for all types of cancers in subjects with initial diagnosis of cancer. Whereas the mortality for cancer was increased only for prostate, and the incidence for bone and bladder cancer in the group, the intermediate group, risk group, which includes, for example, Turner syndrome, Noonan syndrome, or panhypopituitarism. But it's much more interesting to compare the low risk group, which is the group with isolated growth failure. Once again, idiopathic GH deficiency, isolated GH deficiency, idiopathic short stature, and small for gestational age, with the group of non-cancer patients. And you see that in the low risk group, there was no significant increase in both mortality and morbidity for cancer. So the main findings that in patients with initial diagnosis of isolated growth failure, the overall risk of cancer was not raised, both in terms of mortality and morbidity. The incidence and mortality risk were raised in patients after a cancer treatment. Only for bone and bladder cancer, the incidence was raised in GH-treated patients without history of previous cancer. So the second group, the intermediate risk group. The cancer risk was unrelated to the duration and cumulative dose of GH. But for patients treated with after previous cancer, the cancer mortality risk increased significantly with increasing daily dose of GH. And quite interestingly, the Hodgkin lymphoma incidence increased with the longer follow-up. So probably we need, in this case, even longer follow-up than 16 or 17 years for having a right idea of what is the real risk, at least for the Hodgkin lymphoma. Later on, in 2018, from the French group again, there was another paper published showing that actually in cancer medicine, showing that there was an increased risk of bone tumors after growth hormone treatment in the low risk group. You see here the observed deaths in comparison with the expected deaths were significantly increased in terms of standardized incidence ratio. So that this actually was the analysis of the same cohort of around 9,000 patients, which the same group reported as a mortality risk before. Our final report was about the mortality in our SAGE cohort, in the overall SAGE cohort. And once again, we subdivided the patients according to the risk of mortality. In this case, we have two group 1, which means group 1A, including isolated growth hormone deficiency, idiopathic short stature, and mild skeletal dysplasia, including hypochondroplasia and dyschondrosteosis. The risk group 1B, including SGA children. And then once again, the risk group 2, the intermediate risk group, including, of course, multiple pituitary hormone deficiency. We have Cushing syndrome, we have Turner syndrome, Prader-Willi, Noonan. And finally, the risk group 3, the high risk group, including all patients with a previous history of cancer. And you see that overall, the mortality, the all-cause mortality, was a significant increase in risk group 1B, risk group 2, and risk group 3. But then when we looked at the specific cause of mortality, we observed that the mortality for cancer was increased only in group 2, significant increase only in group 2 and in group 3. Whereas the mortality for disease of blood and blood-forming organs was increased in group 1A, significant increase in group 1A, group 2, and group 3. The disease for circulatory system, so the mortality for this kind of diseases, was increased in all 4 groups, 1A, 1B, 2, and 3. And if we subdivide the cause for circulatory disease and specifically looking at the mortality for cerebrovascular disease, we observed that this mortality for cerebrovascular disease was significantly increased in group 1A, in group 1B, not significant, but a tendency, but significant increase once again in group 2 and group 3. So the main message from this paper about mortality of the SAGE cohort was that, first of all, this is the first large population-based cohort study of patients treated with the recombinant human growth hormone in childhood to report overall and cause-specific mortality for up to 25 years of follow-up. The all-cause mortality was associated with the underlying diagnosis and not significantly associated with the increased mean or cumulative recombinant human growth hormone dose. And in patients with a low-risk group, isolated growth hormone deficiency, or idiopathic short stature, this was not associated with a significant increased all-cause mortality. However, mortality from certain causes, including blood, circulatory, and cerebrovascular disease, was increased even in the low-risk group, including isolated GH deficiency and idiopathic short stature. However, we have to consider some biases and confounders, which are in all available studies published so far. First of all, no comparison data were available for untreated patients. Then there is sufficient duration and completeness of follow-up. Then, of course, our study, as well as many other studies published before, I would say all studies published before, the data come from multi-center study, which means that we have many missing data and identified confounders. The population heterogeneity, including age and diagnosis. After all, limited sample size, the low event rate, even in SAGE cohort, as you see, have you seen, the absolute number of deaths, for example, although significant, was around 5, 6, or 7 absolute cases with death in comparison with the expected number of, for example, 0.5 or 1. So from a statistical point of view, it was significant, but the absolute number was very low. And then, of course, all these studies, including such lack of key data, such as familial predisposition to certain diseases, including, of course, cancer or cardiovascular or cerebrovascular disease, exposure to environmental hazards, lack of local mortality and morbidity indices, and moreover, the most studies, the mean dose and duration of GH treatment, as well as the follow-up length, were not reported. And these are almost the same weaknesses which we are in our study. No information on GH treatment beyond pediatric ages, so the treatment duration for some patients may have been underestimated, with consequent dilution of any true effect of duration of treatment on cancer risk. Then the aggregation of data from 8 different countries adds the complexity of heterogeneity in patients' mix and the treatment. We have no information about IGF-1 levels in this cohort. The follow-up included only few person years beyond the age of 35, and then had limited power for cancer prevalence at middle age and older ages. So we cannot extrapolate our results, our conclusions above the age of 35. And that is important to distinguish the standardized mortality ratio we use for our mortality study from other metrics, such as absolute risk and the number of needed to harm. Finally, I would like to thank all of you for the attention. Of course, I have to acknowledge all the colleagues involved in the SAGE project from the 8 countries involved in this so big effort to try to clarify the real long-term safety of GH treatment started in childhood. Thank you.
Thank you, sir. Thank you, Mrs. Stefano. It is a very great lecture. And you have rightly pointed out the various safety aspects as far as growth hormone treatment are concerned. I think you have some questions in the chat box. Do you see them, sir? Professor Stefano? Do you see the questions in the chat box?
I can see now. Okay, sir, yes.
Yes, please. Please.
Okay. So questions, any particular reason for increased mortality in
those patients, congenital?
CKD, what does it mean, CKD?
Chronic kidney disease, sir.
Yes.
Chronic kidney disease.
Chronic kidney disease.
Kidney disease, sir.
Chronic kidney disease.
Okay. Okay, of course, I mean, this all-cause mortality we think actually that the risk group 2, which is the intermediate risk group involved, I mean, was a very heterogeneous group in Turner syndrome, Noonan syndrome, and chronic renal failure. But I think that the mortality, the causes of mortality is different according to different diagnoses. I mean, we subdivided in a quite, would say, rough way, just to have a significant number of patients for each group. But of course, the causes of mortality for example, a patient with Noonan syndrome or Turner syndrome is certainly different from the cause of mortality in a patient with a chronic renal failure. So I think for this particular group, the group 2, we should apply a more specific analysis to look at the specific cause of mortality according to the different diagnoses. So there is not univoc answer to this question, because we have to dissect this group in the different diagnoses.
So there are 2 more questions, sir. Sir, regarding Dr. Bansali, sir is asking, why more cerebral vascular events following GH therapy?
Well, that's interesting. I mean, there are some papers, experimental papers, showing an effect of GH and IGF-1 on endothelial cells. So One of the hypotheses is that the exposure to high levels of IGF-1 particularly can induce a change in endothelial cell number and function. And this can lead in the long term to a higher cerebrovascular or cardiovascular mortality.
Professor Laron, Professor Laron is asking in the chat, does cancer in the family influence the effect of human growth hormone?
I mean, of course, yes, because many cancer actually recognize a genetic background, but we didn't analyze this genetic background, as well as we didn't analyze the, say, the regional cancer incidence in the different 8 countries. That would be another very interesting analysis to perform, but it's very difficult, I would say possible, at least for the data we are in our hands at the moment.
Another question. Yes, sir.
Would you consider giving growth hormone in non-growth hormone deficient children if there is cancer in the family?
Very good question. I mean, if I should, I mean, for example, let's take as a sample a girl with Turner syndrome. I think that at the moment we don't have any robust data or robust evidence showing that in that case the GH therapy increases the risk of cancer even in the long term. So at the moment, I think we should treat a girl with Turner syndrome even if she has his familial history of cancer.
No, but I mean idiopathic short stature, where you have to give where you give higher doses than in growth hormone deficiency.
My personal point of view about idiopathic short stature, you know that we perform a meta-analysis of all data about the adult height achieved after long-term therapy with growth hormone. There are just 2 or 3, I think 3 different studies. And the main difference in adult height between treated and untreated patients is about 4 centimeters. So I think in this case, the therapy for idiopathic short stature with high dose of GH, especially in those children with a familial history of cancer, I mean, in my point of view, is that we should avoid to treat this region, because the outcome in terms of growth and the risk on the other part of the of the scale is in favor of the risk and not of the benefit. That's my personal answer.
Sir, there are 2 more questions, sir. Dr. Rajneesh Mittal is asking, what is the consensus of use of growth hormone in craniopharyngioma post-operative cases with no or minimal residual tumor?
Well, the data about we didn't analyze in such court we did not analyze the craniopharyngioma patients in particular, but the data from literature say that actually there is no increased risk of recurrence of craniopharyngioma if you start therapy at least after 6-12 months after diagnosis of removal of the primary lesion in the brain. So I think the craniopharyngioma, the data about craniopharyngioma are quite reassuring in terms of safety, at least so far.
Yeah. So I think there are 2 more. Many questions are there. I think you can choose among those questions, sir. Dr. Ganesh Javalikar is asking, was there any data on incidence of SCFE, that is skipped capital epiphysis, in the SAGE cohort?
No. We don't have those data. No.
And again, continuing further, how do you counsel a patient? I think they have already mentioned that one. I think the last question from here, when do you initiate human growth hormone in a post-operative case of craniopharyngioma with DHD and residual tumor? I think these are all part of the same.
Yes, I wait for 12 months. Many colleagues around the world actually just start after 3 or 6 months. But personally, I prefer to wait for at least 12 months.
Okay. Sir, in the panelists, we have got 3 people. Yeah. So any questions from the people who are in the knowledgeable doyens? You can unmute and ask questions if you have any.
So we are very happy with a wonderful lecture. We have heard a lot. So I think we should proceed further now because we have rest of the session packed up back-to-back lectures.
Thanks, Rajesh. I think we can invite and welcome the panel members, esteemed panel members, Professor Anil Bansali, Professor
Can we thank Professor?
And we can include Professor Stefano and Professor Laren also in the panel. Definitely. And continue with it. I think that would be okay.
Sure,
please,
sir. Why not, sir?
I welcome the esteemed panelists from our own India, Professor Anil Bansali, Professor Shobhankar Chaudhary, and Professor Tushar to join. Are they on the line? Please.
Yes.
Yes, sir. They are there, sir.
Please, sir. Please, sir. Please, sir.
Good evening, sir.
Dr. Shubhankar is here. Dr. Tushar is also here. And yet to see Dr. Bansali. Dr. Bansali has asked questions, so must be here only.
I'm very much here.
So,
please.
Yes, sir. Very good evening.
Welcome, sir.
Very good evening. Very good evening.
Very good evening, sir.
Yes, sir. Yes, sir. So, should we start our panel discussion, sir?
Yes, yes.
So, we have seen wonderful lectures on first on Laron syndrome, and then we had a wonderful lecture on long-term data on the growth hormone deficiency, especially those who have received growth hormone. Diagnosis of growth hormone deficiency is one of the most difficult area after so many years of research. Still not straightforward diagnosis like we have a diagnosis of hypothyroidism or other endocrine condition. And one of the most important thing is who should be investigated for growth hormone deficiency and who should not be. Still, we are finding a lot of studies showing it differently. But before starting evaluation for growth hormone deficiency, it must be that we should have ruled out malnutrition, any systemic disease, hypothyroidism, and once we have ruled out these diseases and bone age is delayed now and childhood is significantly short, yes, we have sufficient ground to go ahead with GH stimulation test. One of the most difficult area of the workup of growth hormone deficiency, and as per international regulations and society guidelines, 2 dynamic GH tests are required, which is again a very difficult part of GSD work, especially in kids who are very, very small in size. Many centers do with 1 test only, but this is general consensus that most of the tests, they do 2 tests on separate days for a GH stimulation test and for make a diagnosis of growth hormone deficiency. I would request Dr. Bansali to share his experience with the growth hormone stimulation test and his views on diagnosis of growth hormone deficiency by use of growth hormone stimulation test. Professor Bansali.
Yeah. So I think very rightly said that we still struggle for having a growth hormone stimulation test for making a diagnosis of growth hormone deficiency. At our center, the 2 tests which we prefer for the patients with suspected growth hormone deficiency includes insulin-induced hypoglycemia and clonidine stimulation test. So there are 2 tests which we are doing, and we are reasonably having a sufficient experience. We would have published data for that, and we have not seen any untoward consequences following the insulin hypoglycemia test as it is usually feared. However, those who have a really contraindication for doing a insulin hypoglycemia, we prefer to do a glucagon stimulation test. So the glucagon and clonidine remains in choice in those who are having some relative or absolute contraindications for that. Otherwise, we prefer to do a IIH, insulin-induced hypoglycemia and clonidine. I think the same experience should be with the other centers. They can also share.
Sir, here can I Sir, Rajesh, whether doing ITT in all the centers may not be possible. See, whether we can go with the clonidine stimulation test and some other physiological test like
I think
or something else. Because see,
why physiological? We have 2 tests available. We have clonidine and glucagon. Dr. Chaudhary, what's your opinion?
Yeah, I was just going to say that in our center, we do still do insulin tolerance test, but we are increasingly tending to move to clonidine and glucagon. However, glucagon is more costly, more difficult to procure. Those are issues, but and we are trying to match and see how the two perform, but we haven't published that data yet, but we are trying to do both clonidine and in a significant number and to come up with it. So, but we don't have the published data.
So in that area, we can assure you 100% that we have, in last 15 years, we have not done a single insulin hypoglycemia test. And this was based simply on our previous experiment. Many years back, there was a untoward incident during this test. So, and with the availability of glucagon, which is easily available in Delhi, cost is little bit, yes, I agree, cost is little bit around 1,000 Indian rupees, but it's available, convince with family. So we do go for glucagon stimulation test in place of hypoglycemia test. And similar data is coming from all over world where insulin hypoglycemia test is least favored test. The people who are doing insulin hypoglycemia test, and number is going down and down every year, and hardly few centers are comfortable with, but it's a potent stimulation test, also have some other advantages.
Yes, Rajesh, I will just make one comment here. Is that yes, that's very true that you might be having some untoward or 1 or 2, like 1 in 1,000 incident with that. I think that may be very rare, but I think the insulin hypoglycemia has got a certain advantages. Like it's one of the very potent stimulus and has got a specificity around 80%, which is a very highest specificity. Secondly, it has also got a very good reproducibility. That's another point with that, and you can also assess simultaneously cortisol. So I think there are major other advantages. Yes, I do agree. If you screen out, if there's a contraindication for that, certainly don't do. Go for a glucagon and clonidine. But I think we should not be scared of that we should not do this test. This is a good test. I think we can have an opinion from our Professor Laren and Professor
Stefano, sir.
Yeah.
Sir Stefano.
Yeah. So what is their opinion regarding the dynamic test?
Professor Leron. Professor Leron, please. Your opinion regarding the growth hormone dynamic test. Sir is online.
Yeah, he's muted actually. Can he unmute himself?
Yes.
Meanwhile, we can ask Professor Stefano also.
Yeah, he's
we can ask Tushar.
Please, sir.
Yeah, hi everyone. So, with
Tushar, what's your opinion?
Yes. So at KM, we have almost given up doing IIH, and we have shifted to clonidine stimulation test, and we use glucagon stimulation test also quite often. But I have to make a point here to say that most of the time we get severe GHD patients where the diagnosis is not really a question. We have a lot of them with MRI abnormalities. There are family histories which are positive, and they're really severe GHDs with -4, -5 SDS. So making a clinical diagnosis itself is quite strong there. And we have a data of genotyping these patients where almost 50% of our patients have been shown to be genetic mutation positive. So these are real GHD patients where we are catering to.
I think, Tushar, I would like to make a comment. You very rightly pointed out, those who have got a multiple pituitary hormone deficiencies or structural abnormality or like genetic confirmations, in that scenario, even a one single dynamic test along with IGFN is good enough. So there's even if you do a clonidine or a glucagon, it's good enough. So I think ITT, what we are doing, because we are practicing it for last many years, fortunately, we have not seen any untoward incident. If you are doing a 2 dynamic test, I think we will prefer that. And yes, if the glucagon is available, then I think it's a good choice. But insulin is definitely more potent, very high specificity of 80%. I think that makes a point.
Definitely, sir.
Yes, sir. Yes, sir.
Yeah, so that's your point is well taken. It's a good test, but at the same time, problem is because of these issues we have discussed. Fine. So next issue with the GH stimulation test is there is a controversial area of sex priming. Sex steroid priming, whether we should go with sex steroid priming or not. It was there mentioned in previous editions of the Williams and other textbooks, then disappeared and now again appeared. So still it's a controversial issue. None of the societies pragmatically says that yes, it should be done. Everybody says that it has to be decided on case-to-case basis. So may I request Professor Chaudhary to just to give his impression about sex steroid priming and what's their experience, and then we can share request all panelists to give their ideas whether to go for sex steroid priming or not. Dr. Shubhankar Chaudhary.
Yeah, quickly, I would say that in practice, for children around age 10, 11 years and who are pre-pubertal, where we're doing a growth hormone stimulation test, we do priming, but that's pragmatically to do it so that we don't have to repeat the test. Once we have done the test and we see a subnormal response, and then we think if we had primed, then we would have got a correct, better response. But in my mind, I personally am not in favor. Actually, I don't think that it does help significantly, because if you show someone a response better by sex steroid priming, that child who is not growing, then do you treat that child with sex steroids in order to get him or her to grow better? We don't do that. So that will give us, I feel, relatively sort of false sense that everything is normal. So practically no, we do. That's what I said. In practice, we do, but I feel possibly there is no special need of it.
I think I'll just
Dr. Subramaniam, what's your opinion?
Here we practice priming.
Yes.
Okay, so you do in all patients in which age group?
Priming. We practice priming, as Dr. Professor Shubhankar told. We all practice when the person is pre-pubertal or the child is nearing puberty. Usually we practice. In our institute also, we practice it.
Yes.
But of course, different opinions. Professor Bansali is saying something.
Yes.
Dr. Bansali is saying something. Please, sir.
First, the answer to the Shubhankar. That what the Shubhankar felt that this priming may not be of so use because we don't treat with sex steroids. But I think remember one thing is that even in children with isolated growth hormone deficiency, the puberty is delayed by 2 years plus. So meaning by that, the growth hormone dynamics are altered if the puberty is delayed. So priming with the sex steroids unnecessarily will make your false negative cases will not be diagnosed. Otherwise, they will be unnecessarily diagnosed as a growth hormone deficiency. And the guideline also recommends, like the pediatric guideline from our Pediatric Society of India, they recommend any child who is above 8 years of age and tenor stage below 2 should have a priming. So at least there will be no point in repeating that. Suppose you find that there is no response, then you will say the priming has not been done, so you will do again priming. So if you find a normal response, it's fine. But if you find an abnormal response, you will do priming and you will repeat it again. So the best is that those who are above 8 years of age and tenor stage below 2, you prime them because the growth hormone dynamics are altered, because we know that all in a peripubertal period, the growth hormone surges are more than what you have in prepubertal period.
Tushar.
I completely agree with that. And I would say that priming is quite important in our management because we want to prevent false positives. We want to correctly label the patients. We want to say that patient is growth hormone deficient or not growth hormone deficiency. We are not saying that we don't want to treat with growth hormone, but we need to label it properly to make it ISS versus growth hormone deficiency, because the dosage is going to be different, the response is going to be different, and the management is going to be different.
Prognosis is entirely different. Prognosis is entirely different in ISS versus growth hormone deficiency. Yes. I'll just share our experience at our center. We more agree with Dr. Shubhankar Chaudhary that we are not very much convinced with the available data, published data with the sex steroid priming. So till now we are not doing, only if they have crossed chronological years of 12 years. In that case, we can consider, but not doing in all cases. So this is our center's experience. Next thing, we have been asked to wind up within next few minutes because we are running late of time and there is back-to-back lectures now. So would like to request Dr. Subramaniam for what's his view on follow-up of once we have started. Now we have gone ahead with the growth hormone stimulation test. We have done or not done priming. Now we have diagnosed growth hormone deficiency and we have started growth hormone treatment. So how would he would like to follow up these patients? How frequently would like to use IGF-1? What is the standard deviation of IGF-1 he would like to keep, and when he would like to repeat IGF-1 levels, or not to repeat IGF-1 level, only would like to go with the clinical and anthropometric parameters with that. Dr. Subramaniam?
Rajesh, as far as what we see, the main and most important is that clinical parameters are the most important. Anthropometric parameters is the most important. First, whenever we start growth hormone treatment, we call the patient back after 1 month to look for the side effects of growth hormone, the injection technique, as far as injection abscess or anything. That is the first and foremost. And we then call him after 3 months, then to measure the height and ask about. But usually we don't ask IGF-1 before 6 months. So we look at all these things at 6 months. We don't look at all other things. But of course, all other parameters we measure. But most important as far as I see is anthropometric measurements. Of course, IGF-1, yes, we do, but not before 6 months. Once it is normal, then we can continue the same dose. If the response is not good, yes, then I go with IGF-1 to know whether we have to increase the dose of growth hormone. That again I do. I think I can ask other panelists also their opinion of Professor Bansali and Professor Shabankar also regarding this. Sir, please.
One of the practical issues for many of our patients is compliance. You advise something, but the patient's not taking. So IGF-1 sometimes that way helps us to check on the compliance. And it does not, and then of course we have to take the history properly, because it does not automatically mean if the IGF-1 is not sufficiently raised, then we increase the dose. So many a time we find that the patient just had stopped the treatment mostly because of cost issues. So that's one of the reasons where we are treating with, in growth hormone deficient people. In those who are non-growth hormone deficient, for example, in Turner's, which forms a significant bulk of patients who are on growth hormone, there, of course, our concern is whether we are pushing IGF-1 to very high levels. So there we possibly would check more often, rather than if we have a good growth response in growth hormone deficient, probably we won't do an IGF-1. That's our sort of experience.
Dr. Bansali.
Yes, I'll just like to make 2 comments. One is that the IGF monitoring, that it should not exceed more than 2 SDs for the age and gender matched children. That's one we should keep in mind. We should also look for 2 important. One is a thyroid. If there's a multiple pituitary hormone deficiency, we should look for a thyroid function test as well as look for a cortisol deficiency, because both can be exacerbated or both can be unmasked after HGH therapy. And thirdly, if your doses are exceeding more than an IGF-1 was raised more than that, the probability of a future malignancy is more. So what I will say, look for adverse events which are associated with growth hormone deficiency. Particularly in children, we usually see as either papilledema or gynecomastia, or sometimes like over-treated, we had some acromegaly-like features also. So the doses should be adjusted according to the your IGF-1 level 1. And secondly, the oxological parameter becomes very important.
Can I just come in quickly and say that about this thyroid and cortisol, we also do that. But I must admit that in idiopathic growth hormone deficiency, I have not come across these changes actually happening. That's my personal experience.
Shubhankar, very right. It is unlikely to occur in a patient with isolated growth hormone deficiency. It is basically recommended for MPHD. So
yeah, but MPHD, that's a different issue altogether. It's not related to the growth hormone, actually.
No, it
yes, sir.
Growth hormone also. It has got some.
To precipitate to manifest.
Yeah. So just to share our experience, we are regularly now from last couple of years, we are regularly doing IGF-1. And we are trying to maintain a IGF-1 SDS not based on the Indian population, but whatever IGF-1 SDS data available, we try to maintain either 0 SDS or maybe between 0 to 1 plus 1 SDS, not more than that. Anybody goes more than 1 SDS, we try to reduce those, because that gives us advantage of reducing cost at the same time also. And we have seen in many of these patients that we have to cut down on costs also. So,
Thank you,
Dr.
Rajesh.
Tushar?
Now, I think, Rajesh, I think it is a wonderful discussion. Actually, we are exceeding the time.
Okay.
I wanted to ask regarding genetics of growth hormone deficiency, sir. Because I
Yeah,
think
that was the next question we are asking to Dr. Tushar, because Tushar has a lot of experience on genetics of growth hormone, especially isolated growth hormone deficiency. Dr. Tushar, can you enlighten us on genetics of isolated growth hormone deficiency?
Sure, sir, sure. So we just would like to add that we have added the spectrum of growth hormone genetics to already work done by Dr. Meena Desai, Dr. Khadilkar, Dr. Rajesh Kadgawat, who's there with us. And we have looked at the 4 genes, GH1, GHRHR, PIT1 and PROP1 in a cohort of 100 GHD patients, of which 80 people were IGHD and 20 were CPHD. And in IGHD group, our data shows that GHRHR mutation is the most common mutation, more than GH1, which is in variance with the Western literature, but it goes hand in hand with the publications of from Indian side. And in CPHD, we have PIT1, which is more prominent than the PROP1, which is again against the Western literature. And we have one of the largest cohort of PIT1 patients which are positive. And I think AIMS also has another good cohort there. The idea is that we got some predictive factors there, as I was saying, that these patients who are genetically positive will have severe kind of presentation with severe GHD, GH level, peak stimulated GH level less than 4 nanogram per ml. They have MRI abnormalities in case of CPHDs. They have a very SDS on the lower side. And that's one of the markers, along with family history and consanguinity, which is a major factor in our Asian cohort. I think rest all parameters are almost same, but I think we've added genetics to that part. We suggest that since GHRHR is such a common mutation in GHD patient, we could devise a simple test like RFLPA to look for a person who comes with only isolated GHD with severe short stature, and you could spend save a lot of money. It can be done in 1,000 rupees maximum with any of those genetic laboratories, and if that is, and that will save 50% of our expense as far as a research constraint situation is there. And if it's not coming negative, then we can go for NGS panel.
A quick word from Dr. Bansali and Dr. Shubhankar about their experience of genetics of GHD.
Okay, we have also very limited because some collaboration with the UK with Professor Mata. So we had an analysis of 38 patients with multiple pituitary hormone deficiencies. So we had both PROP1 and PIT1, but only these mutations were seen in 30% of patients. The rest 70% we could not find any mutation. So that's a one. But all these patients had a structural abnormalities on MRI. So either they fulfilled a MRI criteria of triad or tetrad, and all had a abnormal GS dynamics. But we could not find, because we looked for a very limited number of genes. So that's why that may be the reason for that. Why. But I think that Tushar made a one point is that those who had an isolated GS deficiency and they had a GHRH receptor defect, I think that was a one unusual finding which I just like to learn more.
Yeah, a few comments from Dr. Shubhankar.
Yeah, it'll be quick because we do not have a good enough experience to talk about. We have planned one, but I haven't been able to execute it because of lack of funds. But maybe in future we'll have more data.
Yeah, sir. Yeah, it's really understand, really very difficult part to carry out. Dr. Subramaniam, any experience?
No, we don't have a genetic lab in the institute, so we don't perform these genetic tests on these patients.
Yeah, so our experience, we have published a few papers on that, and experience is more or less what Dr. Tushar is saying. So it's 30 to 40% of these patients harbor mutation. Now we are trying to capture more and more genes, so we may be able to find out more defects in these patients. I think catecholamine secretions of organizers is going very high, because we are running quite late. So we want allow them to increase more and more, because catecholamine is not good so much for health. So I thank all panelist members for wonderful discussion. And thank you very much, Dr. Bansali, Dr. Shubhankar, Dr. Subramaniam, Dr. Tushar, all and organizers for giving us opportunity. So hand over back to organizers. Thank you.
Thank you very much. Thank you. Thank you, sir.
Yes, sir. Thank you, sir.
Thank you. Thank you.
So we had a good panel discussion, and that is bringing end to the panels, the session 1. We had a great session. That the speakers were very good, and we had a lot of interesting points brought out in the panel discussion. I would thank from my side and from all of us that we have enjoyed this session thoroughly. So the gist of this session would be to measure the growth properly, to take proper clinical history and plot them in a charts, because the age-specific charts are there, gender-specific charts are there, even disease-specific charts are there. So even Turner syndrome has got Turner syndrome charts. So use them in your institution, in your practice, encourage your practitioners to refer more patients to you and manage them better and give a good, healthy results to the future. So I thank one and everyone for listening to us. So I would like to request them to host the next session. The rapporteur for this session would be Dr. Rajneesh Mittal. Are you there, Rajneesh?
Yeah. Hi, Dr. Chennai.
Rajneesh is my friend. So the session would be on diabetes in the young. Over to you.
Yeah. Yeah. Am I audible?
Yes.
Yeah. Yes. Good evening, everybody. It was really a very nice session today that we heard the national and international experts on growth. So to start our next session is on, it's another interesting session that is on diabetes in young. To this chair, we have two legends as chairpersons. First, Professor Nehal Thomas, sir. He is professor and head of the Department of Endocrinology in Christian Medical College, Vellore. He has more than 250 index publications and several chapters and 2 books, which has reached its 8th edition. His areas of interest involve the pathogenesis of diabetes in India. He has delivered more than 20 orations, including MS Ahuja and Subhash Mukherjee orations. He has completed more than 65 multinational and in-house clinical trials in diabetic mellitus. And he has also received Lord Yadanapalli Award for Outstanding Research in 2009. And of course, the department was recognized by BMJ for Diabetology Team of the year 2015 and Royal College of Physicians Award for Excellence in Teaching and Training in 2017. And then we have a second chairperson, again, Dr. Professor P.K. Jabbar, sir. He is Professor of Endocrinology from Government Medical College, Trivandrum. He is Director of Indian Institute of Diabetes in Trivandrum. He has around 50 publications in national and international journals. He is an eminent speaker at various CMEs, conferences, and sir has vast experiences and presented around 200 papers in national and regional conferences in diabetes and internal medicine conferences. He has also contributed to the textbook of thyroid, and he's also a principal investigator for a lot of ICMR trials. So with that introduction of both the chairpersons, I would like to hand over this session to our respected chairpersons. Over to sir, please.
Nihal sir, you are muted.
Yeah, thanks Rajneesh for that lovely welcome.
Thank you.
I'd like to thank the organizers for organizing this wonderful meeting. Could I have the slide kit please on the screen? So it's my proud privilege to introduce Professor Linda DiMiglio. She is Professor, Department of Pediatrics at the Indiana University, and she's also the Associate Division Chief at the same university. She has had extensive work in clinical research with a focus on prevention, beta cell preservation, and new technologies. And she has also been the medical director of the American Diabetes Association camp, John Bible, since 1998, and was president of the ADA Indiana Affiliate Community Leadership Board from 2006 to 2009. Professor Linda is an active clinician and is actively involved in the research of diabetes and endocrine patients. And Professor Linda will be talking to us today on a very important topic, essentially insulin and glucagon therapies, and an update on these areas and future directions. Over to you, Professor Linda.
Thank you. Thanks for that kind introduction. And I am very glad to be speaking today. I'd like to thank the organizers for inviting me. I was in Hyderabad in fall of 2018 for the ISPAD meetings, and I hope to be able to come back next year to do some speaking in person and also to meet some of you in person. The topic that I'm going to start with today is on insulin and glucagon therapies, and I'm going to focus on updates and current directions. These are my disclosures. So whenever I start a talk on diabetes, I always show a version of the slide that I update every year. And so this is the 2020 version of the slide. And as you know, we are now coming up on the 100th anniversary of the discovery of insulin in the hot summer of 1922 in Toronto by Banting and Best, shown here with one of their dogs on the left-hand side. And then we go through my childhood in the 1970s, which many of you have experienced these times when kids were finally able to clinitest their urine to determine if there was urinary excretion of glucose. We were first able to measure glycohemoglobin. We had concentrated insulin, so U80 lente, and the first, although very primitive, insulin pumps. And now, at least here in the US, in the settings I practice in, we have a wide variety of insulins and technologies and pumps and a lot of software and a lot of data downloads. So with that, where are we in type 1 diabetes management in 2020? So we're in multidisciplinary technology-driven care. We use insulin analogs and continuous delivery systems, and I'll talk more about the analogs and potential for delivery systems as we move forward. We have glucose monitoring, including flash glucose monitoring and continuous glucose monitoring. We have enhanced education with intensive insulin management. And we recognize now, even for our children, the need to do intensive cardiovascular risk factor modification with management of lipids and following of blood pressure, even in the pediatric ages, because we know that although we've made improvements as far as complications for persons with type 1, earlier mortality, if present, is due to cardiovascular disease usually. So, hang on. So our goal with all of these things is to reach glycemic targets. And as a pediatric endocrinologist, I'm focusing on the pediatric targets as we're in a pediatric session. And I was fortunate to lead the ISPAD consensus guidelines statement on glycemic control targets that was published in 2018. And ISPAD at that time went to a goal A1C of less than 53 millimoles per mole for all children, with the targets below that you can see for pre-meal, post-meal, and pre-bed blood sugars. I'm very also glad that the American Diabetes Association in 2020 basically endorsed this guideline and dropped the pediatric targets to 7. As far as I know, every international society now has a target that is at 7. Potentially with the exception of the NICE group in England, which endorses a target of less than 6.5%, and so which is slightly lower than the ISPAD and other goals. So how are we doing with this target? Well, here I show you data from the US, from the Type 1 Diabetes Exchange, and I was part of that registry and a co-chair of that registry for several years. And we had the idea several years ago to look at A1C over time in that registry. Now this shows the prevailing ADA targets at the time, which was 7.5 for children and 7 for adults. And what you can see here is that the pediatric group from 2010 to 2012 was well above this. The adults did not look much better. And actually the peak hemoglobin A1C in that group was close to that of the that was present in the diabetes control and complications trial. So then we went back and we looked at data again from the registry in published that in 2019. So when we looked at data from the registry from 2016 to 2018, we were dismayed that actually A1Cs had gone up, despite the fact that there was a much greater use of technology, particularly continuous glucose monitoring, from the 2010 to 2012 cohort to the 2016 to 2018 cohort. So why are we not doing well? Well, I would hold that it's because we have a very narrow glycemic range. So we're trying to target a very normal range. This is giving you glucose in milligrams per deciliter, but shows the range of 70 to 130 here. And there's only insulin to get you there. So food and illness are pushing your glucoses up, and insulin and exercise are going to push your glucoses down. And basically, it's like we're trying to drive a car with only a brake and no accelerator. So what are the barriers to using currently available insulins to achieve glycemic goals? Well, the first is that there's a non-physiologic PK profile, and I'll show you that in subsequent slides. The second is non-adherence. So insulin is, it requires a lot to take your injections or bolus all the time. And a lot of our children, particularly adolescents, are not interested in doing that. It's not their top priority. Actually, their top priority is in general to avoid conflict with their parents. There also can be erratic drug absorption, so that even if you give the dose and you give it correctly and you give it the same way as you did it the day before, it may not be absorbed in the same way and may not function in the same way. There's also complex regimens now. When I started, everybody was on a sliding scale and or a fixed dosing. Now we're asking people to do math, and there's a human error calculating doses. So we're doing a study now of closed loop therapy at children close to diagnosis, and I had a child just give herself 10 units of insulin twice over 2 hours, as opposed to bolusing for 10 grams of carbohydrate twice over 2 hours. There's also an inability to adjust basal once given. So once you've got it, you're stuck with it. And so if you decide you want to exercise, or conversely, you decide that you want to just sit around all day, you can't really fix that. There's weight gain with therapy, and particularly this is something that our adolescents don't like, but nobody likes to gain weight because of their medication. And then cost can be tremendous for insulin and for the other therapies. And so we are finding here in the States that there are a fair number of kids who are omitting doses just to reduce costs to their families. So where do we go with this? So I'm going to spend the rest of my time talking about where we're headed and places I think that there's real promise. So I'll talk about promising new insulins, some that are available and some that are just envisioned. Glucagon therapy advances over the last couple of years, and then some considerations for care. So for the promising new insulins, I'll start with faster acting rapid insulins that are designed to more mimic physiologic insulin production, and then some better basals. So when we look at ultra rapid insulins, what we're trying to do is approach a physiologic insulin profile even further. So the ultra rapid insulin should better approach physiologic insulin secretion, replace the early insulin secretion, especially in the case of type 2 diabetes, and then mimic the profile for pumps. So regular human insulin, which is where I started as a fellow using regular human insulin, had a profile that, as you all know, requires time to start. So people are supposed to take it at least 30 to 45 minutes before eating, and then has a peak and then a very long tail. So when I was a house staff, we would give regular insulin every 6 hours as a way to manage kids on the floor. We went to rapid acting insulins. So actually Lysopro became available here in the States in 1996, and I know you have it available for you in India. And that had pushed the envelope back. So now you still needed to take the insulin a few minutes before eating, but you had a better peak to cover the meal and a shorter offset. Ultra rapid insulins, which I'll talk about, like Fiasp, push it a little bit to the left, and we're getting closer, but not quite mimicking this blue line that shows insulin from the normal pancreas. So how are we changing this? What's the principle that we're using here? So whenever you give insulin, whether by infusion as shown here or by injection, the insulin enters the body as hexamers. It naturally likes to form hexamers, and it comes into the body as hexamers. The hexamers then dimerize, so each hexamer becomes 3 dimers, and those dimers become monomers, and that's those monomers that then go into the circulation and are picked up and then eventually find insulin receptors. One insulin that is trying to get closer to that physiologic insulin secretion is Fiasp. Fiasp does it by taking insulin aspart and then adding GRAS, or generally regarded as safe excipients, to it. And so all it is insulin aspart, so NovoRapid in a new formulation. Insulin aspart is they add to it nicotinamide, which is vitamin B3, which modifies the absorption, and then arginine, which is added for stability. What does it do when you add those two excipients to basically to Novolog or NovoRapid? Well, you shift the time profile shown here on the right to the left, just like this, again, mimicking more closely, as I showed you up front, that physiologic insulin secretion. The circulation appearance then is a little bit earlier, so it comes in about 5 to 7 minutes earlier than NovoRapid. And the time to 50% maximum concentration is about 6 to 11 minutes faster. So there's a faster onset, faster max concentration, and a little quicker offset. There are other ways that people have tried to make faster insulins. One is to add hyaluronidase. Hyaluronidase improves tissue permeability, and it's being tried under Halozyme. You can also add EDTA or citrate. Those modify hexamer formation so that it's less likely that the insulin will stay in hexamers and causes them to more rapidly dissociate. Another thing is to add a vasodilator, so that'll just increase the rate at which those monomers are absorbed. And this is the way that the ultra-rapid insulin Lispro, being studied right now by Lilly, is taking that approach using two excipients, which are citrate and treprostinil, designed to be a vasodilating insulin. I just want to talk a little bit, since we're talking about theoreticals, what about nasal insulin? I'm going to be spending some time talking about successes in nasal glucagon. Well, I wanted to say that nasal glucagon has theoretical advantages over injectable insulin. Firstly, there's no injections, so there would be potentially improved compliance. There's a large surface area in the nasal mucosa for rapid absorption of the insulin. And the PK, because of the fact that it you have a large surface area, it will be absorbed rapidly, could be very similar to injection. So people have tried nasal insulins, and there was an early trial in 1988. So this will be comparing it against insulin, against regular insulin. These are during the study, there was a period of injection optimization, and then once they felt like they had optimized the insulin by injection, which you can show got to a mean A1C or so of about 9%. So this is where things were in the late 80s prior to the DCCT. Then they switched to nasal, and you can see that in general, the A1Cs went up rather than down. There was the second study in 1995 comparing this time to Actorapid, so to a faster acting insulin, but looked at nasal versus injection. And again, this is mean glucose over the course of a day. But again, the nasal glucagon was inferior to the injectable. Nasal insulin was inferior to injectable insulin. So where were these failures? Well, firstly, insulin has a large molecular weight compared to glucagon, as I'll show you. So therefore the absorption was very limited, and there is a system in our noses with nasociliary clearance, which is going to try to push out anything we put into the nose. And also it's possible that just the dosing of the insulin is insufficient. And I'll talk a little bit about inhaled insulin in that case. We know now with inhaled insulin, we have to get a lot higher doses. People have also used nasal insulin to try to induce immune tolerance in studies of persons at risk. There have been oral insulin trials with potentially some modest successes that have shown some effect on delaying the onset of diabetes. But overall, those studies have largely been negative. But so people have tried giving insulin nasally to induce immune tolerance. That there are no current trials as a therapy for type 1 diabetes for nasal insulin. And in the future, if you were going to pursue this route, you need to control, in order to control blood sugars, you need absorption enhancers, just like I've talked about for the ultra-rapid injectable insulins and or bioadhesive systems for different delivery. I'm just going to spend a few minutes now talking about Afrezza. Afrezza there was an article in the Buffalo News in May of 2017 with this guy who's a school teacher who loves his Afrezza. So it's got some good pictures of what the device looks like and how it's dispensed. And the title of the article was "A Breath of Fresh Insulin." Afrezza, I've shown you some PK curves now for insulin, so you'll recognize that this is insulin Lispro, rapid acting short insulin here, and you can see that there is a peak and then an offset with Lispro, and overall like a little bit of a wider curve. When you give Afrezza, which is here on the left, Again, at increased doses, you have a change in the PK, which I'll talk a little bit more when I talk about U300 insulin. So it's important to recognize, especially for any trainees or early faculty people in the audience, that when you increase the dose of insulin, you not only increase the effect of the insulin, but you also change the PK of the insulin in such a way that you extend the time that the insulin is active. And so with Lispro, you can see this kind of wider curve for PK. This is the insulin concentrations, and with Afrezza, you see that it's again left shifted with pretty high circulating insulin levels for a very short period of time with higher doses. And so overall, Afrezza right now is the fastest insulin action available compared to any other insulins that are there. And with that, what you see is when you give Afrezza and you give it around a meal, shown here at time 0, you see that glucoses actually can drop a little bit after the meal and then come up later, commensurate with that quick effect and then the quick offset of Afrezza. And if you look at Humalog, then you have that gradual increase until the insulin kicks in, and then it comes down. So in general, Afrezza can be very good for rapid acting carb in persons with type 1 diabetes. The downsides of Afrezza, especially for as a pediatrician, is a relatively fixed dosing. So there's only certain cartridge sizes. So you can't titrate like we are often giving, as I'm sure you are, half units, even quarter units. And even though Afrezza is at least 1/2 as potent, if not less potent than injectable insulin, you have to use fixed doses. And the other issue is if you need large doses, you need to use multiple of those cartridges that I showed you in that picture of that patient. It also requires spirometry because of concerns about Afrezza and lung function before starting therapy, although data were presented this year at the American Diabetes Association showing that the decrease in FEV1, which you see in people on Afrezza, is modest and does not progress over time. And it's also very expensive currently, and so it's not endorsed within our standards of care in the US because of the cost. But there are it's labeled and available in the US. I was looking at it, seemed like you would know better than I, but it seems like it was near coming to India, but did not make it there. But there are pediatric trials underway in the US with the attempt of getting pediatric labeling for the drug. Some other ways you can make insulin work faster theoretically are some other insulin delivery advances include warming the infusion site. And this is like my favorite paper that I'm going to present you in either of my talks today, where they put people into a sauna as a way to accelerate insulin absorption from sub-Q injection. This was published in the British Medical Journal in 1980. So you can see that there, in 1980, it would be regular insulin. And what they did here on the right-hand side was that they put people into either a control situation or put them into a sauna. That's the bottom curve. The sauna time is shown here. And they gave them a meal and their insulin. In this case, it was regular insulin. And the blood glucoses rose by about 5 millimoles. And then they gave them a snack. But you can see that in the group that went into the sauna, as soon as they went in the sauna and they vasodilated, presumably, the rate of blood glucose, the rise turned around, and actually their blood glucoses were lower 6 hours after than when they had started this meal, breakfast, snack. And so overall, the insulin disappearance increased and the blood glucose excursions were lower. They actually radio labeled the insulin so they could follow the rate of insulin change. There is this Insupad, which is made by Insulin Medical, is another way to warm the site without warming the whole person in a sauna. It's designed to sit over your infusion set or over your injection site. You plug it in, you warm it up, and it can sit there. And this also can increase the rate of insulin absorption. Other ways to make insulin work faster include using novel delivery methods. So you can give it through microneedles, which I'll show you, and also through intraperitoneal delivery. So here's the microneedles. This is a standard Teflon catheter that we'd use in an infusion set. It's a 6 millimeter catheter, and you can see here it goes into the subcutaneous space. With microneedles, they're small steel catheters that they're intradermal, so they go into a space where there's more rapid circulation, and you can infuse insulin. And by using microneedles, again, here you're going to see this similar curve. This is circulating insulin concentrations over time, but this is sub-Q Humalog given traditional way, and this is intradermal Humalog. And again, you see the same principle. You shift to the left with a higher peak. You can also give insulin intraperitoneally. I do not know if people are using this at all in pediatrics. I know that some places are using it. I have not seen it used myself, where you give insulin through a pump into an infusion set that then is fixated on the abdomen. And then there's a port that goes in and a long catheter that will actually infuse insulin into the intraperitoneal space. And with this, you bypass the whole need to absorb through the skin and hexamerize and monomerize and do all of that, and you can give very good insulin delivery. This is a different graph. I'm looking at insulin delivery using a Diaport device. This is CGM glucose values that are in certain ranges, and the blue here is the group that is using intraperitoneal delivery, and the gray is the group that's using standard sub-Q delivery. And basically what you see is a different kind of left shift in that you're lowering the mean glucose values, giving insulin through an intraperitoneal device. All right, I'm going to switch now from rapid-acting insulins to basal insulins, and talk first about what you'd want from an ideal basal insulin. So if you were designing a basal insulin, you would want an insulin with a long duration of action. This way you can control fasting blood glucose with minimal injections. So that allows flexibility in dosing, and it can improve your compliance. You want a very flat time action profile. So, when we went, at least here in the States, from NPH to an ultra lente to Basaglar, Lantus, now Detamir, those things, you flatten the time action profile, and then you'd have less hypoglycemia. And you want very low day-to-day variability. So you want to lower the risk of hypoglycemia, and also permit titration to lower fasting glucose. So if you knew you took the same insulin the same way every day, you would get the same result. You could have tighter control. So one of the insulins that is working toward this, that is now available, is Degludec or Tresiba. Insulin Degludec does this. This is the same kind of principle I showed you earlier. The insulin goes under the skin and it immediately hexamerizes. And Degludec, in order to be a longer acting basal, promotes that hexamerization. So you actually not only have hexamers, but you have multi-hexamers under the skin when you give Degludec. Eventually those hexamers break down and they monomerize, but when the monomers happen, they actually bind to albumin in the blood. So that increases the circulating half-life in the blood. And so both by producing multi-hexamers and also by binding to albumin, you really slow the rate of delivery to the insulin receptors. And this is done by changing the amino acids, but also by binding a fatty acid to the Degludec, which gives it a half-life of over 24 hours. So very stable insulin over time. Another way, as I alluded to, change PK of insulin and flatten the curve is by using U300 insulin. When you use U300 insulin, you take the same amount of units. So here you see U100 glargine, and you change it to U300 glargine. So you have the same number of units in here, but in a third of the volume. And what happens then is you have these like sets of molecules, these balls that are smaller. And when you have a concentrated insulin like this, then you have a slower and more consistent rate of absorption just because you have less surface area of the insulin once it associates. And indeed, if you look at the curves here, this is a different, so here we're not looking for a left shift, we're looking for a flattening. And here, if you give Lantus at 0.4 units per kilo, and you look at the 24-hour profile, you get a little bit of a peak and a little bit of an offset. If you give the same dose as U300, you get a much flatter PK profile. And here's the glucose. This is the insulin concentrations, and this is the glucose infusion rate. And you can see that this is a much flatter glucose infusion rate. In fact, pretty much steady out to 24 hours. There are now companies looking at doing once weekly insulin. This is data from the American Diabetes Association meetings this summer, looking at insulin icodec. And icodec, again, has amino acid substitutions and is bound to a fatty acid, and has, the data are not yet public from this, but basically the initial studies are starting to look good. And Novo is looking at having potentially once weekly insulin, which is going to look a lot like Degludec, but even a slower PK profile. So another way you can make basal insulin slower and more even is by putting it into nanoparticles. So these nanoparticles would extend basal insulin to over days or a week. Some might even prefer oral delivery. Some of you may remember Oralin, the oral inhaled insulin that was available for a little while in Central America, but did not get much traction. It was not very good. There's also different systems for nanoparticles. The insulin into a biodegradable nanoparticle, so like in matrix or depot. You could put in aquasomes that control the release, excuse me, and you could have injectable microgels or microspheres. And overall, kind of the holy grail of this all is to try to come up with a glucose responsive insulin, so a smart insulin. A smart insulin would sense the glucose concentration, and then the insulin would be released based upon the glucose. And the way it would work is there'd be a glucose activated switch attached to the insulin. And when there's glucose present, that switch changes. And so there's it would then be released from the particle. One way to give these smart insulins might be on these microneedle patches where the insulin would adhere to these small patch and could dissociate from there. We're probably not near having smart insulin. So I gave a talk like this back in 2017, again in 2018, and at the time, the projections were that smart insulin was at least a decade away. When I was looking to give this talk today, I found an article on glucose responsive insulin patches for regulation of glucose, which is exciting in mice and mini pigs. So at least in animal, is moving forward. I'm going to spend the rest of my time talking briefly about glucagons, so nasal glucagons and stable liquid glucagons. So glucagon is moving quickly from this kit that you are all familiar with to now in the States we have nasal insulin and we have soluble liquid glucagons, and this has been a huge advance for our patients. We were fortunate to be part of both the pediatric and adult studies of nasal glucagon. This formulation was developed by a group in Canada that started a company called Leucemia Solutions and then was bought by Eli Lilly. And there, this just shows the plasma glucose concentrations after giving glucagon for both the nasal insulin in the black bars and the intramuscular glucagon in the clear bars, and you can see a complete overlap, so that we had the same glucose rescue with both nasal and IM glucose. In this case, this was the adult trial where we made adults hypoglycemic and then gave the glucagon. In the pediatric trial, we just brought their glucose less than 80, but had a similar response. Why does this work when insulin doesn't work? Well, I told you insulin is a large molecule, and it's not only a larger molecule, but it creates these hexamers. Glucagon does not like to hang out with its friends in glucagon, and so is a single molecule in smaller size, so it can work nasally. And I think the advanced nasal glucagon was really important. This was a simulation study that was done as part of the background to convince the FDA here in the States that this was a needed product. And what they did here was that they gave people with diabetes a glucagon kit, and they taught them how to use it, and then they sent them home to train either a family member or a friend on how to give the glucagon. And then that family member or friend came back a couple weeks later and they did a simulation. So they gave the family member or friend a kit with a meter and a pump and glucagon and insulin, and they set a timer and they created a simulated stress environment. And they looked at how quickly that caregiver, who had just been trained within the last 2 weeks by the person with diabetes who themselves were trained, could give the glucagon. And they found that indeed, some of the caregivers, about 40%, were able to give glucagon within 1 to 2 minutes. About 10% of the acquaintances could do that, but by far the majority gave no glucagon. Some people got insulin rather than glucagon. Some people gave just the diluent. Some people just couldn't figure it out altogether after they had been trained. They then went back and they did the similar study with caregivers and acquaintances of people, and they gave them the nasal glucagon. So the nasal glucagon kit, and the vast over 90% of both caregivers and acquaintances were able to deliver glucagon within less than 1 minute. And there were a few people who, again, couldn't figure it out, but almost everybody could. So this is a huge difference. And when they asked the caregivers how did they understand it? Did they think it was easy to give? What was their overall satisfaction? They loved it. And I can tell you now, having been here on call and having had parents give nasal glucagon, it's been so much better than trying to deal with the kit. Xeris is another company that has now made a glucagon pen that does not require reconstitution. They also have a syringe for presumably for smaller dosing of glucagon. These things are available right now in the US. And the plan is to eventually have glucagon in a mini dose pen where you would give glucagon as a way to increase your blood sugar just a touch around the time of exercise, or be able to treat, some lows which are not emergent lows. And I think that this will be a huge advance. A second company called Zealand Pharmaceuticals is also working on getting an injectable liquid glucagon, and they have approvals that are pending, but they've compared the dasiglucagon, this is the glucose profiles, after giving it to glucagen. We were part of the pediatric trials to look at increasing glucose after induced hypoglycemia. And this is overall looking like it will also be a good product. And very importantly, Zealand is partnering in the efforts to have a bihormonal pancreas. So when I've been showing this slide for a long time, it's available online. It's not one of my patients, showing what a bihormonal pancreas might look like. So this kid's got on a glucose sensor, and then an insulin infusion set, a glucose infusion set. And he's actually wearing 2 animus pumps to try to get the insulin and glucagon. This is very bulky. He doesn't have a lot of real estate to wear all these devices. And so Beta Bionics is working with Zealand now, and they have a single pump, at least, so you wouldn't wear it. You still would require 2 infusion sets, but a single pump, a much smaller sensor. And they're in trials right now with the bihormonal pancreas, which would allow you to get not only the accelerator part of insulin, but also. So I just want to close with a couple considerations. Firstly, insulin is not a cure for diabetes. It just keeps people alive until we find one. This is one of my personal mottos. I want to say the advances in therapy, even over the 20 years that I've been taking care of kids with diabetes, have been significant. Yet there's an inherent narrow therapeutic index with a need to control hyperglycemia and a risk of hypoglycemia. I think we need to continue to evaluate and have better availability of insulin analogs that have glucose-sensitive elements within the structure. So that would be the smart insulins. New glucagons, we need to get them out there. We need to train people how to use them. We have to have them be more available. From what I could tell, you do not have access to those yet where you are, but I'll love to hear about it in the discussions. Closed loop systems, particularly ones with glucagon. Stem cell tissue engineering technologies to try to really have a cure. Beta cell preservation and restoration. I spent a lot of my time on beta cell preservation. And then most importantly, I think of everything is patient-centered strategies to improve compliance and outcomes. And so with that, I just wanted to mention quickly that we published a commentary. I was glad to be invited to do this. It's available now in Diabetes Care, talking about COVID in kids with diabetes. And if we have time during the discussion, I'm happy to talk about what we had here. I want to just say that overall, the data on COVID and children with type 1 diabetes at least are reassuring. Type 2, we really don't have much data yet, but this paper talks about some of the data suggesting there's more DKA in kids with type 1 diabetes who have in areas where there's a lot of COVID, but there's no increase in incidence of diabetes. And also gives some guidance to families about safe at school and things they should do to protect their kids during this time. And with that, I just wanted to show my team, and I will turn this over to the organizers. Thanks for your attention.
Thank you, Professor Linda, for that lucid talk. Really a fantastic overview over the last half hour, looking at several aspects of therapy of type 1 diabetes and amazing insights into the glucagon concept. I shall just focus on a couple of points which you had mentioned. And I was also intrigued to look at the more recent studies as far as inhaled insulin is concerned. I would actually like to go back to the initial inhaled insulin studies done in type 2 diabetes way back during the first decade of this millennium, around 2007, 2008. And interestingly, how they seem to have made an impact. In fact, for type 2 diabetes, went on to the phase of phase 3 trials and was actually used in the market. And then there came this published data with a slightly increased relative risk of lung cancer, as well as that of decline in FEV1 in these patients. And it disappeared from the market. I thought it was more, I believe, from reliable sources due to commercial reasons at that point of time. Yeah. With that in the background, what is your thinking of inhaled insulin in children for type 1 diabetes? Professor
Yeah.
DiMiglio, would you gather what I'm trying to ask you?
Yeah, no, I think I do. You're referring to the Exubera that was on the market briefly, the Pfizer product that did, I think, as I know, it vanished, like you said, for commercial reasons. It also had a much larger device that I didn't show that, but it was a long device. It was very clunky to carry around. The Mankind is a lot smaller. I think I don't think that that's worked out, and I think that that's a concern for parents, at least, of kids with diabetes. When we've done some of the inhaled insulin trials, and we mentioned the risk of malignancy, and we mentioned the risk on FEV1. I think the FEV1 data that I saw at ADA were very reassuring that people using inhaled insulin, although I think it was more for type 1, so maybe lower doses than type 2, had a bit of a decrease in FEV1, but it wasn't a clinically significant decrease, and it didn't change over. It was either 1 or 2 years of therapy, so that was reassuring. The cancer risk, I think at least the group now that's working from Mankind does not feel like there are any data currently that they are concerned about that would lead them to think there'd be an increased risk of cancer. And I don't know if in Exubera, my impression was that was a group of people that may have had potentially other risks, but I think that's something that's need to be watched post-marketing. Right now, inhaled insulin has a very small market share here in the US. And so they are collecting surveillance data, and they're doing some more post-marketing work. And I think we'll get those data. I think for kids, I think where inhaled insulin really has a use is around that ultra fast insulin action right at the time of a meal. So I think if I were to use it, and where I've seen it used successfully, just like anecdotally with peers with diabetes, less than in my patients, is that you can take a small dose in conjunction with your long-acting insulin, or your short-acting insulin by injection at the start of a meal, and you get that peak, but then you also have that second insulin kicking in. So it's really adding a third insulin rather than as a standalone insulin. That's been my impression.
Thank you, Dr. DiMiglio. There's one question from the flow from the chat box, which I shall read out. I think it's there on your profile as well. If the same excipients, that is nicotinamide and arginine of fast-acting ASP, are added to regular insulin, will it become rapid-acting insulin?
Yeah, I don't know.
What are your thoughts on?
I would think it would help it. I mean, certainly some of what it would probably add to it a little bit, but I don't know if people, I guess there's probably not a commercial drive to do that. So I don't think people have tried that, but it would, if you're going to make it hexamerize less, then it would help, and it would potentially become a shorter acting insulin, like what the PK would look like compared to something that's a short acting insulin. I don't know. But that's a good thought. I don't know that people have tried that.
I think we have time for a couple of more questions before we go on to the next speaker. And if there's anyone on the screen who would like to ask a question.
Just one comment on that.
Yes, Dr. Bansali.
Yeah, that comment on that, someone asked that if you add a nicotinamide and arginine to regular insulin, what will happen? This was a question which you
that's
mentioned. Right. Yes. So I think that will behave more like a SPART, because it will be faster absorbed, but it will not be monomeric. So I think it depends upon how hexamer to monomer is converted. So I think that will be the reason for that. It only fastens the absorption, but not changes the tendency from hexamer to monomer. So that's why the SPART was used along with arginine and nicotinamide.
Yeah.
Thank you, Anil.
Yeah.
Yes, Dr. DiMiglio, would you like to mention anything in connection with the statement that Dr. Bansali
I was going to say thank you. If that makes sense. It would be interesting to think about which excipients would accelerate regular insulin and how that could work, and what the cost would be to add them as excipients as opposed to using the analog insulins.
I'd just like to allude to one of the important aspects of treating type 1, and particularly the young and adolescent type 1s. And I'm sure it's true right across the world, and the psychosocial issues that we encounter in these patients. And of course, they may vary from country to country, but I'd just like to allude to one of a study which is spearheaded by my own colleague, Professor Asha. One of the most important things that actually helped in bringing down the A1Cs from levels of 9+ to 7.5 to 8.2, etc., were that of peer support groups, which really helped a lot in terms of improving their overall glycemic control. So that was really dramatic and consistent. The other thing, of course, is as they did grow up and as they got, in fact, married, their A1C levels tended to become much more steady as well. I guess you'd have similar experiences from the US in addition.
Yeah, no, definitely. So the I think peer support and for families of young children, caregiver support is critical. We published some data in the last couple of years looking at target ranges. I focus a lot of my research not only on new technology and therapeutics, but on care of the youngest kids with diabetes. And so we published a paper a couple of years ago where we asked caregivers as part of a qualitative study what blood sugars they were comfortable with their children being in, so young children with diabetes. And they actively said, one, that the blood sugars that they were trying to keep their range that they wanted their children in was a little higher than what the physician wanted, but that actually it was even higher when the child was not with them and when they would be at school or with a babysitter or something like that, because they were nervous about hypoglycemia in that age range. So so that the need for education for the peers and education for other family members and education for caregivers is very apparent. And then with the older children, absolutely peer support is essential. I mean, because one of the things that teens with diabetes, they don't want to have conflict with their parents and they don't want to go low in front of their peers. It's much easier to run a little high because there's no bad effects in the short term of running a little bit higher. So yeah, peer groups are really critical. And that's part of why I've been so passionate and involved with diabetes camps, because through diabetes camps, we can create those peer groups for kids, which is really helpful.
Thank you once again, Prof. DiMiglio, for that wonderful session. And don't go as yet, because we'll have you in for the panel discussion at the end of all this.
Yeah.
I have a question.
Thanks for the enlightening talk. Oh, Professor Laren, do you have some question?
Yes, I have a question. Dr. DiMiglio, what do you think of the possible relationship between the new insulins, long-acting insulins, and cancer? We found in vitro that glargine activates IGF-1 and also cancer cells.
Yeah, I know that that was a major concern when those insulins first came out, and I think that there has been active surveillance, and I think that there's not been any real-world data. I think like the data was presented earlier on growth hormone and cancers. I think that there are surveillance around insulin and cancer, and I think it has not been it's not materialized as a real-life concern, but it is something we talked a lot about when glargine first came to market, and I know that there's been active surveillance.
There may be a risk group that it's cancer in the family, or that the follow-up is not long enough in order to express a clear opinion.
Yeah, I think it's considered I think it's something that is monitored, and I have not heard any signals that there has been a problem, but I remember that being a theoretical concern, and so I know it's been watched for, but I have not changed my prescribing practice, nor have I heard of any of my peers changing prescribing practice based upon family history or anything like that. We use the best insulin that we have available.
I think we've got pretty much enough data for the last 2 decades showing that glargine is reasonably safe. And this, I think, is overwhelming in terms of what response we have seen, and malignancies don't seem to be so much of an issue. And Anil, I think you're nodding in assent
I think
to what I was going to say.
Just 2 comments on that. One is the origin study by glargine. I think that also itself mentioned it was a follow-up of 5 years, and there was no increase in incidence of cancer. And later on further exploration, they found there were 2 metabolites, M1 and M2, and none was found to be carcinogenic. But it is true that it has got a more affinity for IGF-1 receptor binding as compared to your diluted. But no, in the real world data, no increase in cancer.
Yeah, nothing.
Thank you for that. And we'll go on to our next speaker.
Sir, we have last
I would
question, sir.
request my colleague, Professor Jabbar, to actually give an introduction as well. Over to you, Dr. Jabbar.
Thank you, Dr. Nihal. First of all, I should thank Dr. Rajesh Sahai and the team for the wonderful opportunity given to me. Next topic is very, very wonderful topic, and we have a wonderful speaker also. Professor Francisco is a Secretary General of European Society of Pediatric Endocrine and President, European Society of Pediatric Endocrinology, Secretary General, Italian Society for Pediatric Endocrinology, President, Italian Society of Pediatric Research, is a consultant for WHO for non-communicable disease in children. More than lot of papers in his credit, both in international and index journals. I think his CV is marvelous, very fascinating one. Over to Dr. Francisco, please.
Thank you very much. Can you see my slides?
No, we can't.
First of all, I would like to thank the organizers for giving me the opportunity to lecture.
Sir, your slides are not seen, sir. Yes, you should share your slides.
Yeah, I'm trying.
Yeah, please take your time.
Yeah. I share my desktop, but something is wrong.
There's an icon, it's a share screen.
Oh, no, I know that.
And can we see in de novo diabetes?
So I saw the question, and I actually have not needed to treat neuropathy in my children. So we certainly saw some of it when I was a fellow, but we don't see it anymore in our pediatric patients here. So I'm hoping some of the people here with peds and adult expertise can tell me what they do. There is rarely people can have neuropathic pain at the onset of diabetes. And that has been reported, but again, I don't have any particular therapeutic modality, so I'm guessing there's more expertise in the audience than what I have in that area.
Right, sir. Right, ma'am.
Dr. Nagesh, can you show me?
Professor Francisco, can you retry, sir? Professor Francisco?
Yes.
Meanwhile, Dr. Nagesh is trying. Can you just give a retry from your laptop?
I tried again, but
sir, one more try, sir. One more try. Meanwhile,
I tried again, but I don't. This is my disclosure. Next, please. This is where I come from. Next. Next, please. And this is next. This is my hospital. Next, please. And this is, next, please. The beautiful country that you live on. I've been to India many times. It's one of my favorite country, really. Go ahead, please. Ahead, please. Thank you. So this is the outline of my presentation. Next, please. And if we look at the type 1 diabetes, we listened to the excellent presentation by Professor Di Meglio, and you know that about 500,000 children live with type 1 diabetes, and every year 90,000 children are newly diagnosed with diabetes. And the incidence is increasing, not only in Finland, as you know, as you see on the left panel, but also elsewhere in the world, including Italy. Next, please. And the point is that, next, please. The point is that diabetes, we know, as we heard, is a nasty disease for several reasons. First of all, because children may have severe acute complications, namely ketoacidosis and hypoglycemia. And as we heard, it's quite difficult to reach good HbA1c, good metabolic control. And therefore, consequently, children have a Damocles sword on their heads with long-term complications, next please, namely retinopathy, nephropathy, and neuropathy. Next, please. So we do know that diabetes is due to the destruction of the beta cells. And next, please. And this is related to many factors, namely viruses, maybe the immune systems, toxins, some genes, of course. And actually, we really do not exactly the cause of type 1 diabetes in children. Next, please. There are several environmental factors which may be associated with initiation of protection from islet autoimmunity and progression to type 1 diabetes. This is a recent overview by Maria Craig, and you can read yourself. There are several prenatal, postnatal initiations and progressors of type 1 diabetes in children. As well, we do know that there are possibly some prenatal protective and postnatal protective factors of islet autoimmunity. But despite that, so far, we have been unable to fully understand why children do develop diabetes. Next, please. Maybe, as I said, some viruses, interestingly, Coxsackie B4, for instance, could enhance the destruction of the beta cells. But interestingly, some strains of Coxsackie viruses can also protect the children from type 1 diabetes. We know that there are several cytokines involved in the beta cell destructions. And as well, we know that there is a complex immunological mechanism which lead to the beta cell destruction. Next, please. In fact, we know that actually a reduction of the T regulatory cells may in fact enhance the powerful of the CD8 lymphocytes, T lymphocytes, which in turn may induce the production of antibodies against the beta cells. Next, please. My good friend Gianfranco Bottazzo, they described this immunostraining on the beta cells of a child that died because of ketoacidosis back 40 years ago almost. Next, please. More than 40 years ago. And we do know that there are several immunological markers of autoimmunity against the beta cells, namely, next please, the glutamic acid decarboxylase autoantibodies, as well tyrosine phosphatase related islet antigen 2, and insulin autoantibodies, which are particularly important in small children, in very young children. And more recently, the zinc transporter 8 antibodies have been described. Namely, when we refer to the ICA, the islet cell, the old islet cell antibodies actually we actually are not using anymore the ICA, because the ICA at the beginning were actually related to several autoantigens of the beta cells. Next, please. Go ahead. Thank you. To make a long story short, obviously, what we do know now from the immunopathogenesis of type 1 diabetes in children, one of the main defects are related to a reduction of the T regulatory cells, which you can see on the left-hand side in orange, which losing their ability to inhibit the T helper cells and the cytotoxic T lymphocytes may determine a progressive production of autoantibodies against the beta cells. Obviously, this is a very long story, which is not coming in a week or a month. It begins probably in intrautero, and then in some children, because of the environmental factors, determine the onset of the disease. Next, please. What we actually, that because we do know that some of the children with 2 or more autoantibodies may actually develop type 1 diabetes, the Juvenile Diabetes Foundation have actually go ahead in determining several stages of type 1 diabetes in children. Next, stage 1 should be the stage when, next please, when you have the beta cell autoimmunity with normoglycemia in children and no symptoms. This is actually, in some of these children, we come back to this, could also be already a disease, because we know that majority of these children with 2 or more autoantibodies, but still with normoglycemia and without symptoms, may eventually go to stage 2, please, when you have, next please, when you have still beta cell autoimmunity, but glycemia starts to increase and the child is still as asymptomatic or pre-symptomatic. And finally, you reach the stage 3, next please, when you have beta cell autoimmunity, hyperglycemia, sometimes severe hyperglycemia and ketoacidosis, and the symptoms starts and the child can develop the diabetes ketoacidosis. As you can easily appreciate in this slide, when the child comes to the hospital or has symptoms, is actually too late, because the more than 80% of the beta cell mass has gone. So we actually have to make an early diagnosis of this phase. And therefore, next please, we want to possibly predict type 1 diabetes. Next please. Do we have possibility of having prediction markers for diabetes? In these slides, you can see that there are, I will discuss briefly on genetic markers, namely HLA genes and non-HLA genes, the autoantibody markers, and how the type of antibodies and the titer of antibodies may help in evaluating the risk for developing type 1 diabetes in children. And then more recently, there have been some risk score quantification based not only on genetic markers and the autoantibody markers, but also on cellular immunity markers, and more recently on systems biology markers, which may actually help to identify children at major risk of developing type 1 diabetes. Next, please. If we start from genetics, we do know that majority of the risk of developing type 1 diabetes, next please, is related to the HLA, class 2 HLA, which accounts, next please, for around 40 to 50% of the risk of type 1 diabetes. Namely, we know, we'll come back in a minute, that HLA DR3, DQ2, and DR4, DQ8 genotypes are correlated to a 20-fold, up to 20 or even more fold increased risk for type 1 diabetes compared to the general population. Next, please. In fact, this is not only DR3, DR4, next please, which confers 17%, 70 to 20-fold increase of the risk, but also you can see here DR3, DR3, and DR4, DR4 increased by 6 times the risk of developing type 1 diabetes. Next, please. Sorry, back please. Yeah, there are also some non-HLA genes which confers an increased risk. You can appreciate in this slide how the PTPN22 gene gives a 74% more risk of developing type 1 diabetes. Next, please. There are also other genes which have been related to predict diabetes. I can't go into details, but for instance, the interleukin-2 receptor genes, the interleukin-27 genes, and other genes are related to possibly risk of developing type 1 diabetes. You can also may appreciate how there are some monogenic forms of autoimmune diabetes, namely FOXP3 or STAT1 or STAT5. These genes confers the risk of developing type 1 diabetes, but inevitably we can get mad with all these genes. And in fact, my good friend Emily Pochot, next please, wrote a very nice next please, a very nice paper on type 1 diabetes genome-wide association studies, because we are speaking about a multi-gene related disease. Next please. More interestingly, recently, the group of Andrew Attersley have shown that we have to think about monogenic autoimmunity, particularly in children younger than 1 year. You can see on your left-hand side how some monogenic autoimmunity is related to some some single genes, like for instance, FOXP3, or the iron gene, or as I said, the interleukin-2 receptor gene, and the other gene of the STAT1, STAT3, STAT5. So these are children with very early onset diabetes. Why on your right-hand side, you can see the polygenic autoimmunity that I just described. So this is quite an important point, because we could select children with a genetic risk score very high and possibly concentrate on these children which have a major risk of developing type 1 diabetes. Next, please. We also knew from several years, in fact, that having a parent with type 1 diabetes may substantially increase the risk of getting the disease, obviously, and the sibling as well. But also in twins, the studies of twins have shown that there is obviously a major risk. But interestingly enough, there are some monozygotic twins in which not all the 2 twins develop type 1 diabetes, but some of them may not, which means that independently by the genetic predisposition or to type 1 diabetes, the environmental factors play also an important role. Next, please. In fact, this is quite a complicated slide, but to make short, you can see here the risk of developing type 1 diabetes and the proportion of cases, and you can see that obviously the higher risk of developing type 1 diabetes is, as I said, in identical twins, which may have a risk up to 70 to 80% of the risk. But you can see here, if you have a first-degree relative, so a family history of type 1 diabetes and a first-degree relative, one first-degree relative, if you share a high-risk HLA, the risk of developing type 1 diabetes in yellow may reach the same percentage of the identical twins. which make also sense if you have more than one relative with first degree relatives with type 1 diabetes, where you can see on the bottom on blue that if you have a multiple type 1 first degree relatives and an HLA at very high risk, the risk of developing type 1 diabetes can reach 80 to 90%. So, which makes our job to develop a prediction way to actually understand which children may eventually develop type 1 diabetes. I think that these factors are important in this everyday practice. Next, please. Next, please. And also, most importantly, when we probably will discuss about when to start screening, of course, we have a window of opportunity, which mainly is in the first, in preschool children and the early school children. This is quite important if you want to make a screening, and we will discuss about that in a minute, a screening for detecting children at major risk of developing type 1 diabetes. Next, please. Next, please. Next, please. If we move to the autoantibody markers, next, please. You can see here, as I said, that we have several humoral beta cell autoimmunity. Next, please. Go ahead, please. GADA, IA2. And there was a study several years ago coming from Bavaria in Germany, next please, showing that children without autoantibodies, they were followed up for almost 20 years. And Annette Ziegler showed that if children have no autoantibodies, the risk to develop type 1 diabetes, next please, is similar to the general population, 0.4%. But if a child has one autoantibodies against the islet, next please, the risk increases to 12.7. If there are two autoantibodies, next please, the risk of developing diabetes goes up to 62%. And if the child has three autoantibodies, the risk goes up to 80%, which means that having more than two autoantibodies, particularly if the titer of the autoantibodies, we can discuss about that, is very high, then the risk of developing type 1 diabetes in 10 to 15 years is very high. So I think this is an important point, and I guess we want to discuss quite a recent paper, which was published in January 2020, on the yield, next please, on the yield of a public health screening of children for islet autoantibodies among the general population. This is one of the few studies available in which a large sample of normal children in the general population through the primary care pediatricians in Germany were selected. You can go ahead, Nagesh, go ahead until you see all the points of this slide. And you can see here that they were able to show that the risk of developing type 1 diabetes was very high in those children where the more than two autoantibodies were present, and the risk was up to 34%, which means that of course, this study is one of the few studies available in the general population, not in the relatives. So we can, I guess, could be interesting to discuss if it is worthwhile to spend a lot of money to detect children at risk in the general population, with the aim of understanding the risk for developing type 1 diabetes, What we can do if we select children with 2 or more autoantibodies with high titer? Can we intervene? Do we have means to reduce the risk of developing type 1 diabetes? I'm available to discuss with you during the discussion. Next, please. And as I said, there are several other markers which I don't have the time, go ahead please, which I don't have the time to discuss with you. But for instance, recent studies have shown that interleukin 32, for instance, may be a marker for later development of type 1 diabetes. Next, please. Next, please. So let's say like this, that probably for prediction of type 1 diabetes, we have several means to understand children with risk of developing type 1 diabetes, and possibly to prevent type 1 diabetes, particularly to prevent diabetic ketoacidosis at onset. So if we screen either for relatives of children with type 1 diabetes or with parents with type 1 diabetes or population at risk, or as was done in Germany, to screen for in the general population, one of the major points is that we can prevent diabetic ketoacidosis. Diabetic ketoacidosis puts the child in a very high risk of developing cerebral edema and complications by DKA. So preventing DKA is anyway important. We recently had a child with 2 years old coming to the hospital in a severe DKA with 6.9 pH and 4 of bicarbonate. So still diabetic ketoacidosis is a threat for children with diabetes. But actually, do we have means for prevention of type 1 diabetes, which is our dream, more or less, from many, many years? Next, please. So possibly we could act in early life to early life interventions. Unfortunately, I have to say, all the trials, for instance, the Finnish trial avoiding beta-lactoglobulin failed to show that they could prevent type 1 diabetes in children starting from the very beginning of life. We don't have so far diabetes vaccines to prevent autoimmunity from starting. I will show you some of the some data on prevention with the GAD autoantigen, or arrest or reverse the autoimmune process. Next, please. As you may know, we speak about primary prevention. Next, please, when we can prevent autoimmunity. As I said, one example was the study, the trigger study, which gave hydrolysate of the milk, or to stop autoimmunity and preserve beta cells when the child has already autoantibodies, or making a tertiary prevention by giving some drugs to prevent at onset of the disease, to stop the autoimmunity, to induce an immune regulation, and possibly restore the beta cells and preserve the beta cell, the residual beta cells. Next, please. So we are speaking about, next please, to genetics, to prevent in those with genetic susceptibility. Click please, next please. Or to prevent when the child has already, sorry, go back. When the child has already islet autoimmunity, or when the child has dysglycemia, hyperglycemia at the beginning, or at onset of diabetes, in order to induce diabetes remission. Next, please. Why we have failed actually for primary prevention of type 1 diabetes? Because we don't understand exactly the pathogenesis and the heterogeneity of type 1 diabetes in children, as I said, that we have to evaluate the cost-effective diagnostics for risk screening, also in the relatives, to have validated prognostic biomarkers of the disease progression, which unfortunately we don't have completely right now. In other words, we know that more than two autoantibodies may predict later development of type 1 diabetes, but actually we do not have validated prognostic biomarkers so far, prognostic and predictive biomarkers, and also we do not know exactly those agents which can modify the disease and to arrest the progression to type 1 diabetes. And actually, go ahead, please. And actually, we do not know the optimal use of combination therapies for prevention of type 1 diabetes in children. Can you go ahead, please? Thank you. When we speak about immunotherapy, we have actually two main issues. Either we go toward a non-specific immunotherapy, which, for instance, is the case of anti-CD3 autoantibodies. Teplizumab has shown to prolong the remission phase in children with newly diagnosed diabetes. So it could be interesting, and the FDA has approved to go ahead with new studies, phase 3 studies, both in newly diagnosed diabetic children, or in those with 2 or more autoantibodies. On the other hand, we could have an antigen-specific immunotherapy, namely giving the autoantigen administration, which could be the case, for instance, for insulin or for GAD65 or other peptide, which could mimic some autoantigens or the beta cells, and therefore try to prevent the production of further autoantibodies and the destruction of the beta cells. Next, please. As Jay Schuyler have said several times, next, please. The reason why we probably have failed is that actually every child with diabetes is different from another child. And therefore, when we speak about possible prevention strategies, we could think about a combination therapy. In other words, there are children where, in those children with mainly an activation of the destruction of the beta cells, we should enhance the production of insulin, and other children may have mainly the need of a regulation of the immune system. Next, please. We have tried with Johnny Ludwigson several years ago now to have a GAD65 antigen treatment in recently diagnosed type 1 diabetes. And as you can see in these figures, the results of this trial was disappointing. In other words, very few children had the possibility to increase the stimulated C-peptide, but as you can see from this slide, the administration of GAD65 antigen therapy in these children did not preserve the residual beta cell function. Next slide, please. Then Johnny tried to give an intralymphatic injection of the autoantigen, presuming that the intralymphatic injection could increase the immune tolerance. And in fact, if we want to see something positive today, you can see that the C-peptide stimulating tests lasted in those treated with the autoantigen a little bit longer, up to 18 months or up to 24 months. So probably in some children, the administration of the autoantigen could help in preserving the beta cell function. Next, please. Just I want to reiterate here, next, please, that actually, if we want in the future to have a better outcome of our studies in the immune modulation and possibly prevention of type 1 diabetes, we could understand that we have several possibilities, as you can see in this slide. For instance, stimulating the T regulatory cells, I will show you in a minute, either with sirolimus or with interleukin 10, or also with the interleukin 2 in low doses, or other possibility also to stimulate, as I said, the beta cells to produce more insulin, either with exenatide or liraglutide. Next, please. In other words, we should differentiate children with therapeutic strategies targeting beta cell function. So we should better characterize these children from the molecular point of view. And on the other hand, next please, to concentrate on the therapeutic strategies targeting the immune system in a more precise way. Next, please. For instance, quite an important issue, as I said, is that to try to stimulate the T regulatory cells in order to increase the immune tolerance of these children. And this is one of the studies, next please, that has been supported by the Wellcome Trust in the UK, next please, in which the interleukin-2 therapy has been, in low doses, has been proposed in order to assess the effects of ultra-low dose aldesleukin, which is interleukin 2 analog, on endogenous beta cell function by measuring weekly the C-peptide, both fasting and postprandial in children and adolescents with newly diagnosed, in order to assess the efficacy of regular dosing of low dose interleukin 2 in increasing the TREG levels. So in this case, the action is to increase the weight, the TREG levels, to increase the immune tolerance, to confirm the clinical safety and tolerability of ultra-low dose of interleukin 2, to assess the changes induced by the interleukin 2 on the immune system, and possibly to preserve the beta cells on a long time in order to avoid decay and possibly to preserve the beta cell function, which is very important, I think, because there are some evidences showing that if we preserve beta cell function for a longer time, both glycemic control and probably long-term complications the risk of long-term complications may be reduced. So, ladies and gentlemen, next please. In conclusion, I would like to summarize with you and to reiterate, next please, that there is an increasing incidence of type 1 diabetes in children. Next, please. We do know that because of our experience, even recent experience, we know that we need a strategy for primary and secondary prevention of type 1 diabetes. Next, please. And the reason why we must be humble, because so far we have actually failed to prevent type 1 diabetes in children. And the reason is, next please, an incomplete understanding of disease pathogenesis and the heterogeneity, which is, I think, is one of the main issues. Every child has his own diabetes, his or her own diabetes, and we have to understand better which are the main issue related to the beta cell destruction. Go back, please. Yes. The lack of cost-effective rescreening and validated biomarkers for precise staging of the disease. I think that systems biology probably could help in the future to understand, to have biomarkers available in order to to better predict the disease in children. We do need to optimize the design of prevention clinical trials, and this is exactly what many centers, both in the United States with the TrialNet and in Europe with the Inodia network, are doing, and we do hope to have better outcomes in the future. And also, we have to understand the impact and the burden of type 1 diabetes and the potential for its prevention. Well, I didn't have the time to speak about the possible psychological problems related to when the parents know, when the parents have a child with diabetes and the other child have 2 or more autoantibodies against the beta cells. What can we do? And we have to be honest and to inform the parents on the trials that are available so far. And this is exactly what we do in our clinic. Next, please. Next, please. So the way to go is to improve the knowledge on the pathogenesis and natural history of type 1 diabetes in children. We do need improved biomarkers in order to understand and to predict better those children who eventually will develop the disease. And we do need better trial designs and more rapid testing of potential therapies. I told you teplizumab, for instance, is very promising, and we are part of a trial with the teplizumab in newly diagnosed children. Is something which is convincing. There are other options, but there is no room for therapies outside the controlled trial. This is very important. Everybody should know about this. Next, please. And I think is my last slide. And with this one, I thank you for next, please. Thank you very much for your attention.
Thank you very much, Professor Francisco. It was a very exhaustive and very informative talk. Unfortunately, we don't have much time for a discussion. At least, we can entertain only one question. It's very difficult to choose the question also. Probably I will choose one question from the chat box. What is the consensus regarding the time frame to differentiate between LADA and type 1? That is one of the questions. We'll restrict to one question only for the time being. Yes, Professor Francisco. Time factor, time to or age to differentiate between LADA versus type 1.
LADA is not that frequent in children. I mean, we have some adolescents with LADA. Of course, you can have in LADA, as we know, there is a reduction of the insulin need. The remission is very long, and therefore potentially we could intervene. But actually, I am not aware of trials using prevention strategies for LADA. If you allow me, what is I can read here in the chat about the genetic pursuit of prediction tools in solving the high incidence of type 1 diabetes in Finland. That's something very interesting. I don't have the answer to this question. What I can tell you is interesting to know that Estonia, for instance, which is just in front of Finland, has 1/3 of incidence of Finland, and there are the same populations, similar HLA, similar genes, so which means that there must be an environmental factor. You may remember that there were several publications on the role of vitamin D, and so the sunshine. You may know that we have Sardinia, in which the incidence in Italy, in which the incidence of type 1 diabetes in children is very close to that of Finland, and we have a lot of sunshine in Sardinia. So this latitude issue related to diabetes has been abandoned actually.
That's good. I think, say we are forced to stop this session temporarily. I would say temporarily because, see, now you can join for this discussion, panel discussion. I invite my co-chair, Dr. Nihal, to start the panel discussion. Over to Dr. Nihal, please.
Thank you, Dr. Jabbar, and we'll have the introductory slides on. And of course, the two people who are joining us are no strangers and extremely senior endocrinologists in this country and have contributed massively towards several areas of clinical development and research. And I have the proud privilege to introduce my colleague, Professor Nikhil Tandon. He has a broad interest in several areas of non-communicable disease, including young onset diabetes. He leads the technical coordinating unit for the Young Onset Diabetes Registry, and he's conducted several interventional studies in terms of both public health as well as interventional studies in clinical trials. He has been conferred the B.C. Roy Award as Eminent Medical Teacher, one of the highest awards in India in terms of medical science, and the Padma Shri by the Government of India. So that's Dr. Nikhil Tandon, and I would also like to introduce Professor Ish Bhatia, Professor and Head of the Department of Endocrinology at Sanjay Gandhi Postgraduate Institute at Lucknow. He has done a lot of dedicated work in the area of childhood and adult onset diabetes, both type 1 as well as pancreatic onset diabetes. He has a number of publications in indexed journals and has several ongoing projects in several areas. So with this, we shall proceed to the panel discussion. I would also request Professor Francisco as well as Professor Linda DiMiglio to join us as well. So we'll start with a few questions as well. We have a few general questions and we shall focus on some of these areas. Perhaps, Dr. Nikhil, we would like to tell us about your work in the area of the Young Diabetes Registry and how it might have contributed towards the development of research in the country.
May I make a comment?
Please.
May I make a comment, Mr. Chair?
Yes. Go ahead, sir. Go ahead.
I would like to refer to you that we published last month a study in the Journal of Infectious Diseases showing that since the universal vaccination of rotavirus in Israel, we registered a 22% decrease in the incidence of type 1 diabetes in children aged 0 to 4. And this proved our previous studies, as well as those from Australia, that rotavirus plays an important role in the etiology of diabetes. And we think that rotavirus vaccination and possibly Coxsackie B for vaccination could be used in the future in early age, maybe during pregnancy too, to prevent early onset type diabetes.
Thank you, Prof. Darren. That really is interesting news to us, and I'm sure these will open up new avenues towards the prevention of type 1 diabetes as well. Thank you.
I comment.
Nikhil, over to you.
I comment briefly. Yeah. I agree with Professor Laron, obviously. When we go to Coxsackie vaccination, the issue with Coxsackie, as several studies have shown, that you have to produce a vaccine which is toward the strain of Coxsackie, which are actually dangerous for the beta cells. Because some of the Coxsackie before and some strains are could protect against the beta cell destruction, and therefore, while I fully agree with the rotavirus issue, and therefore we should vaccine our children for rotavirus, with the Coxsackie, the issue is the strain that we have to use to produce the vaccine. Thank you very much, Zvi, for your interesting comment.
Over to Nikhil, sir. Over to Nikhil, sir.
Thank you, Chairpersons. I will just do a very brief mention of the Youth Onset Diabetes Registry so that more to apprise the audience about the work which is going on. This is something which was established in 2006 by the Indian Council of Medical Research. It's an ambispective registry, and we were allowed to go back in time till 2000. And essentially the inclusion criteria for the registry, which was initially in 5 cities and now is in several more cities, was that you needed to be registered in a reporting center on or after the 1st of January of 2000, that your age at diagnosis was less than 25 years, and you were living in a defined geographical area. And the model, of course, was a hub and spoke model. For example, there were identified reporting centers based on their annual sort of intake of people with type 1 diabetes. And so each city would have 30, 40, or 50 such centers, which would then be coordinated by a collaborating center. Very briefly, the data, it's about, so in this age group, about 70% to 75%, depending on different centers, were people with type 1 diabetes. Surprisingly, overall, and about 25% came out to be people with type 2 diabetes, and then the rest were various other contributors. The significant regional variation was observed, and especially in the collaborating center from Chennai, the center from two centers from Northeast actually ended up showing a higher proportion of contribution by type 2 diabetes compared to type 1 diabetes. This could be artifactual, depending on the sort of centers who are participating, but still it's worth looking at in some more severity. I will just speak very briefly on the type 2 part, which has not been mentioned at all, and correctly so, because that's not, but what we realized was that it is becoming increasingly difficult on occasion to differentiate type 2 from type 1 in that age group. It's starting to occur earlier and earlier. And why it becomes critical also is that, like other registries, for example, the search registry, we're finding at a significantly higher prevalence and incidence of microvascular complications and cardiovascular risk factors in these individuals with type 2 diabetes after making adjustments for age, duration of disease, et cetera, et cetera, et cetera. So I think this is it's a bloodless registry, but several centers have actually done local evaluations. We have now data of nearly 20,000 people from all these centers, and I think this would be a very useful platform to investigate other nuances of type 1 diabetes and type 2 diabetes in the country. I'll come to other stuff later, but I think I'll stop in response to this question now. Thank you.
Thank you, Nikhil. And we'll go over to Professor Ish Bhatia. I have a question for you in connection with islet autoimmunity in Indian type 1 diabetes. Is it different? And based on your experience and work in relationship to HLA and other markers, do you think when it comes to preventive and therapeutic aspects, would there be a difference in terms of response? Also, in the light of some of the very interesting studies that Professor Francesco Sheriali has mentioned. Over to you, Ish.
So I think that certainly we find some differences in the frequency of, so first of all the studies are on antibodies, the islet antibodies. There are the other aspect, which is T cell responses. There's no data in India, and even abroad, I think less data is there. And as far as the antibodies are concerned, I would say that we can just make a few general statements. First, that the frequency of GAD antibodies appears to be similar to that we see in European children with type 1 diabetes. But the frequency of IA2 antibodies and possibly zinc transporter 8 antibodies are lower. Now, especially IA2 has been studied in at least 7 or 8 different studies, including Indian children who are based in UK, and of course in different parts of India. And we find that basically their prevalence ranges somewhere around 25-30% compared to somewhere like 70 to 80% in in other racial groups. So this may be related to the fact that the major association, HLA association in India, is with DR3 DQ2 rather than with DR4 and DQ8. And we know that IA2 antibodies are strongly associated with DR4 antigen. And so I think there are differences whether India is a very vast country, genetically speaking, different populations, and whether this holds true for all of India, it's difficult to say. Most of the studies have been small, 70, 80, 100 patients. And some of the studies have some flaws in the sense that they're not necessarily patients who are taken at onset of their illness. So, so having some of these flaws in the studies, that's a general statement I can make about the antibodies. And regarding regarding interventions, I think doing intervention studies in India would be very difficult. You require, especially the primary prevention and secondary prevention studies. You require lots of individuals to be tested. Only some of them actually turn out to have antibodies. Your quality of antibodies should be uniform and very good. And then you have to have them followed up for a length of time, sometimes 2, 3, 4 years before you can get an answer. So, so I think that would be difficult. There would be difficult studies. There'd be interesting studies to do, but they would be difficult to do. It would be, I suppose it could be feasible to do studies in children at onset of type 1 diabetes, different types of studies, and they too would be useful. And I think that would be feasible and something interesting to do.
Yes, sir. Now,
Thank
sir,
you.
Thank you.
And I'd just like to make one more comment, and that is that all studies have to be done as part of a protocol, and they cannot just be done in, by a clinician without having a study protocol in which they are involved.
Yeah, good message, sir. Say, over to Nikhil, sir. Say, Nikhil, sir, see, as a physician, what are the salient clinical features, or how do you approach this case of young diabetes mellitus in our clinical practice? How to approach?
I think you asked a very pertinent question. When I was a trainee, and if you had a young onset person who was in the first or second decades of life, it was virtually 100% that there would be type 1 diabetes, right? And as you know, increasingly over a period of time, we're getting type 2 diabetes who are younger and younger. There's clearly coming into the latter half of the second decade, and now there are a few reports of even first decade type 2. I'm not saying it's common, but it's now becoming, the presence is enough for us to be concerned. Now, if you look at a lot of work which has been done in different parts of the world, and I think to some extent is applicable in India also, if you look at a whole basket of youth onset diabetes, you will get two very clear extreme phenotypes which are actually not difficult to figure out. The extreme lean, ketosis prone, insulin requiring and insulin dependent type 1 diabetes on the extreme left. And then, of course, you have people with clearly strong family history of type 2 diabetes, obese, features of insulin resistance, and clearly manageable, at least initially, on oral agents, which is the type 2 diabetes. But then there's a central couple of baskets which require concern. Number one, that you are also getting type 1 diabetes with obesity, which virtually never happened before, because either because of the general population nutritional status and or insulinization. And then there's a small part which with different parts of the country report in differential proportions of the various syndromic forms of diabetes, especially the maturity onset diabetes of young. So these are the four big baskets. As you can see, the point I'd like to raise is in certain instances, and I'm sort of for clinical purposes, while we've had a lot of interesting discussion on antibodies and HLA, and let me just also add a little point on the HLA, which Dr. Ish Bhatia made. In India, and in North India at least, the association with DR4 is not independent of DR3. So you're usually either DR3, or DR3 with DR4, but you're very, very rare to get a DR4, DR4 sort of haplotype. So that's just putting that aside for a moment. But if you see a person who's lean, who's ketosis prone, and is sort of starting the first couple of decades of life, and that invariably, unless there's a doubt in your mind, you may or may not necessarily require antibodies to support your clinical decision making. It may be good to have them to make you feel more secure, but I'm saying this because a lot of centers in India, a lot of cities do not have easy access to doing antibodies. So you should use your clinical judgment out there very clearly. The issue, however, which I want to point out is that in type 2, going to the other extreme, unlike adult onset type 2, we're finding the need for relatively early insulinization, and a much larger proportion of youth onset type 2 require insulin at relatively shorter duration of disease than you'd find in adult type 2. And we were worried whether this was something peculiar to us. And then we saw data from other registries, including SEARCH, which clearly demonstrated that this particular population seems to be more likely to progress to beta cell failure earlier on than adult type 2 diabetes. So I think these are some of the clinically relevant features which we need to keep in mind while making a clinical judgment for providing service to these patients. I'm not talking of research at this point in time. Thank you.
I think so. So what do you think about the role of antibodies for categorizing this patient? Either Nihal sir or Bhatia sir can answer. Antibodies.
You're asking me, Dr. Jabbar?
Hand that question over to you.
Yeah. Yes, sir.
The role of antibodies in whether you should do antibodies in all these patients?
Yeah, you can start like that. Categorizing or to make or clinching the diagnosis here.
So, Dr. Jabbar, in my clinic, we do antibodies very sparsely. We don't do them in, like Nikhil has also said, many of the patients who are classical and this thing, we don't do the antibodies. They probably don't help us in our clinical management. The patients we might want to do antibodies are those who are atypical, like, those who have, don't present with ketosis, maybe have a family member with type 2 diabetes or early onset type 2 diabetes, in whom then we actively think whether the patient may have MODY. Or sometimes you have obese children who present, with diabetes. They may actually have quite severe diabetes and even ketones, but still we'd like to rule out that, antibodies would be would be useful in these patients. So those are the groups of patients in whom we really do the antibodies. And I'd just like to make one comment about the different antibodies, and that is that of the commercial antibodies against insulin are really not very good. They are, the commercial antibodies are not having a good, when they're tested in various proficiency workshops, they don't fare very well. So if you're looking for insulin antibodies, you should really send it to a reliable, lab which does these, research lab actually, which is doing these antibodies. And the antibodies against GAD, IA2, and zinc transporter 8, they are the ELISAs which are done, they are usually quite good, as long as you check up whether they took part in a proficiency program and what was those labs, whether they were, what was their results, and that those data they should be able to give you. So we do find a lot of our patients who have no antibodies and present classically with type 1 diabetes, maybe around more than 20%. It's more than what we see in actually 20 to 25%. That's more than, considerably more than what is seen in the European population and American population of patients with type 1 diabetes. The two groups really don't differ very much clinically. we studied them for 1 year, we followed them for 1 year, looked at the C-peptide, insulin requirement, BMI, how much ketosis they had, all sorts of things, but they didn't, whether they had pancreatitis, whether the amylase was raised, lipase was raised, and there was really not much difference. So we do have this group, which is a quite intriguing group, which we are planning to study further now because we have a large multicentric study. One of the problems with the older studies is that they are very small number of patients. So now we have about 6 centers which are going to pool their patient samples so that we could probably do a better study.
I think a very interesting question by one of our friend. Question goes to Professor Francisco. It's the era of vaccines, right? So any promise for BCG vaccination for preventing or reducing beta cell destruction type 1? Over to Professor Francisco.
To the best of my knowledge, there is no controlled trial on this to show robust scientific data to recommend the BCG vaccination to the best of my knowledge.
Nihal, sir.
Yeah, I have a question, in fact, to both our international faculty, as in terms of the overlap between type 1 and other disorders. What are your thoughts on other forms of diabetes like lipodystrophies and maturity onset diabetes of the young in the differential diagnosis, and the role of other diagnostic markers which you might use in your setting, both in the US as well as in Europe?
So I can take it first. So we would base that differential based upon clinical presentation and family history predominantly. There are differences in practice here in the States as to whether people will get antibodies, and everybody, as was alluded to earlier, our antibody rates, positive antibody rates in our kids with present with type 1 are higher than it sounds like what you see in India. So we're going to find about 90% of people will have a autoantibody. We do measure GAD, insulin, IA2, and zinc transporter 8 here. But we look for family history of type 1 and the type of presentation for monogenic, and we would base the lipodystrophies and those sorts of things based upon clinical presentation as well.
From my side, in Europe, I agree with Professor Di Meglio. I want to comment about the type of antibodies. We also make a screening for all of our patients with diabetes with 2 autoantibodies, because there was a question on this, how to screen. And so we do GAD and IA2. And the reason is because I agree that insulin autoantibodies are difficult. They are mainly present in younger children, preschool children. Regarding the zinc transporter 8, I had the opportunity to review a dissertation in the University of Helsinki recently, and they showed that for screening, is not worthwhile to use the zinc transporter 8. In other words, there are some children who may have zinc transporter 8 antibodies and not other autoantibodies. But in order to screen, I do think that if we have a lack of resources, financial resources, the 2 autoantibodies, GAD and the IA2, should those which we should use for screening. Different is if you are part of a trial, of course, there are also other new autoantibodies which better characterize the way for beta cell destruction, and there are many more studies on the pipeline regarding the signature for risking the later development of type 1 diabetes. I'm referring to interleukin 32 and other biomarkers which we may need in the future in order to characterize better. But for screening at onset, I think I do feel that GAD antibodies and the IA2 should suffice. Of course, because there was a question on that, obviously, let me say MODI3, for instance, has a similar presentation with DKA sometimes. So if you don't make autoantibodies, you can't distinguish between MODI3 and autoimmune related diabetes. So therefore, a screening of newly onset diabetes sometimes may be useful for understanding. In addition, I should say that because we have in Italy around 40% of children either overweight or obese, sometimes this is confusing, of course, and therefore having the autoantibodies may actually help to understand if there is a procedure of humoral beta cell autoimmunity and immune-mediated beta cell destruction.
Thank you so much for that, Professor Chiarelli. And thank you so much, Professor De Miglio, for your fantastic inputs. I've had a friendly nudge from the organizers, and I think we need to end this session because we have really extended our time. So with this, I'd like to thank my both the international faculty, my co-chair, Dr. Jabbar, Professor Nikhil Tandon, and Professor Each Bhatia for your wonderful inputs. And of course, above all, I should not forget our wonderful rapporteurship of Dr. Rajneesh Mittal. Thank you so much once again for coordinating the session. And good evening to all of you, and enjoy the rest of this evening. Thank you.
Thank you so much, sir. Thank you, sir. Thank you, all the faculty. It was really a nice session, and we really enjoyed and learned a lot. So with this, we end our session on diabetes in young, and I hand over next battle to the Dr. Om Lakhani, who is a very young endocrinologist, to take the lead forward. Over to Dr. Lakhani. He is a consultant endocrinologist from Ahmedabad, and he's a winner of ESI, TISA, and AV Gandhi Award, and he has expertise in endocrine oncology, metabolic bone disease, pediatric endocrinology, and he's a only Indian to be selected by European Neuroendocrine Tumor Society for training in neuroendocrine tumors in Europe, and he's revered in national and international journals. Over to Dr. Om Lakhani, please.
Thank you, Dr. Rajneesh, for this wonderful introduction. Today, in this session, we have an added bonus. We have a fourth talk, which was to be scheduled tomorrow, which is going to be taken up in this session on endocrine disruptors. The chairperson today, it's my privilege to introduce them. They are not only fantastic, clinicians and academicians, but they are fantastic human beings. Dr. Sriram Madhavan, he is a DM in endocrinology. He is a consultant endocrinologist at Sundaram Medical Foundation and has his own private clinic as well. He's involved as an investigator in many global trials, including that of type 2 diabetes, growth hormones, and osteoporosis. He's awarded the honorary national professor by the Indian Medical Association. He has, given more than 100 talks in various CMEs and conferences, and has several publications in both national and international journals. So, Dr. Sriram, I welcome you. Can we have the next slide? We are greatly privileged to have Dr. Thomas V. Paul, who is a DNB in endocrinology from CMC Vellore. He's a principal investigator for multicenter trials in osteoporosis. His area of interest include metabolic bone disease and epidemiological studies in bone in various clinical cohorts. He's a reviewer for many journals, including various prestigious journals of the country, and he has more than 148 publications in both national and international journals. He's also the winner of the P.N. Shah, very prestigious P.N. Shah oration at SECon 2017 and the Natarajan oration at Jericon in 2019. So I welcome the chairpersons for this session, and I request them to take over the session from here. Can we have the speaker introduction slide, please? Yeah.
Dr. Sriram. Okay.
I will.
Good evening, everybody. Thank you, Dr. Om Lakhani, and thanks to the Hyderabad team, Dr. Rakesh Sahai and everybody for inviting us today. Profuse thanks to them. And it's my proud privilege and pleasure to introduce Professor Khalid Hussain. People interested in pediatric endocrinology and hypoglycemia in neonates, you'll never miss him. And I think it's a shining torchlight to the sun saying about him. And it's my privilege to read few words about him. Division of Chief of Pediatric Endocrinology Program and Director of Research at the Children's Clinical Management Group, Sidra Hospital, Qatar currently, but previously was associated with the Gosh Children's Charity Hospital, where he was the Professor of Pediatric Endocrinology, and he has done exceptional work in the field of hypoglycemia and genetics of congenital hyperinsulinism. Needless to say, excellent, too many articles, and I think it will run into pages, 300 peer-reviewed articles, including many in NEJM. And I won't waste much time, and already we are shortage of time. Over to you, sir, for your lecture on congenital hyperinsulinism. Hello?
Yes, can you see my screen? Firstly, thank everybody for involving me in this fantastic meeting. Basically, I want to thank Shri for his kind invitation. He's been very, very kind. I've known him for quite a long time, and I'm really very pleased to be part of this program. So about 5-6 days ago, last week, we did the clinical session on hyperinsulinic hypoglycemia, where we looked at the sort of diagnosis and management of these patients. And then I was asked to do a more molecular biology talk. So this particular talk is going to focus more on molecular biology. And I'm going to take you through very simple aspects of how beta cells release insulin, what goes wrong in this condition of hyperinsulinic hypoglycemia. So the aim will be to give you an overview of how the beta cell releases insulin, to discuss the normal physiology of insulin secretion. I'm then going to show you the mechanisms of what goes wrong in terms of unregulated insulin secretion. I'm going to show you some of the genetic mechanisms that lead to severe forms of hyperinsulinic hypoglycemia. And then just overview some of the molecular basis of these genetic disorders. So this is an outline of a pancreatic beta cell. And beta cells receive signals from nutrients, neurotransmitters, and gut hormones. And beta cells have to release the right amount of insulin to keep the blood glucose concentration here between 3.5 and 5.5 millimoles per liter. So beta cells act like the fuel sensors. They sense glucose metabolism, plus sense metabolism from some of the other fuels here, such as amino acids and fatty acids. But glucose is the prime regulator of insulin secretion. And I'm going to now show you in the next few slides how the beta cell actually uses the metabolism of glucose to release insulin. So how do these beta cells metabolize glucose to release the right amount of insulin to keep the blood glucose concentration within the range that I just explained? So one of the key players in this is these things called the KATP channels. And I'm going to show you what KATP channels do and what their role is in the beta cell. So again, this is an outline of a beta cell here. This particular channel is called a KATP channel. And this channel is made up of two proteins. On the outside, you have this protein called a SER protein. here. And on the inside, you have this protein called the KAR 6.2 protein. So these proteins have 4 subunits and they form a very complicated structure on the surface of the beta cell. Now just keep this in mind, what this channel is sitting there and how it's going to regulate insulin secretion. So just imagine if you've just had a meal, blood glucose gets into the beta cell, gets metabolized, and you make these energy-rich nucleotides in the form of ATP and ADP. Now this channel is very sensitive to the concentration of these nucleotides, and these nucleotides actually influence the function of the channel. So when the concentration of these nucleotides goes up, this channel will close. So once the channel closes, you get depolarization of the beta cell membrane, and that allows calcium to come in and insulin exocytosis. So you can see this channel is a key regulator of insulin secretion. And this channel controls one of the most important aspects of how the beta cell releases insulin. And the mechanism is by which this channel does this is called the triggering pathway, or the KTP channel dependent mechanism of insulin secretion. So this is normal physiology. It's very important to understand the normal, because I'm going to explain what goes wrong in the more severe forms of hyperinsulinic hypoglycemia. Superimposed upon this is other signals coming from the mitochondria, and we call this the amplification pathway. But no human disorder has yet been described due to this defect, but I'm going to show you the defects due to the KTP channel mechanisms of hyperinsulinism. So in terms of the genetics of hyperinsulinism, so far mutations in 14 different genes have been identified that lead to different forms of hyperinsulinic hypoglycemia. So this is a table taken from one of our publications, just summarizing the different genes. And I'm trying to classify these to help people understand. So the genes can either be due to a channel or a transporter defect. And you saw those 2 proteins here, the proteins that I showed you on the KTP channel, and they're encoded by these 2 genes. So the ABCC8 encodes the SUR1 protein, and the KCNJ11 gene encodes the KR6.2 protein. And these mutations in these genes cause the most severe forms of hyperinsulinic hypoglycemia that usually does not respond to any medical therapy at all. And these patients either need a limited pancreatectomy or a total pancreatectomy. So we discussed the mechanisms of these last week. I'm going to go a bit more detail today. There are some other rare forms. There's this channel, this calcium channel, and there's been 2 case reports so far. This causes a very mild form of hyperinsulinism that is responsive to medical therapy. And one of your colleagues in India here has been communicating with me about a child with possible exercise-induced hyperinsulinism, which we'll discuss later. And that's due to a defect in this transporter. These genes, I've called them the metabolic pathways, because you'll see in a minute, these genes regulate key enzymes that are involved in the metabolism inside the beta cell, and they control insulin secretion. I will touch briefly on some of those just to show you the molecular mechanisms. One very important clinical point of view is all of these respond to diazoxide. Now, last week, again, I explained to you certain diseases, certain forms of hyperinsulinism that don't respond and the ones that do respond. For practical purposes, all of these are responsive, including these 2 here, are responsive to diazoxide. And then there's this subgroup here called transcription factor defects. These are very, very interesting genes because some of these cause not only just hyperinsulinism, but later on they cause a MODY form of diabetes. And some of you will recognize the HNF1 alpha and HNF4 alpha. And I'm going to be touching on this later. Another very interesting one recently described is a gene which causes not just hyperinsulinism, but also hyperpituitism. I think only 3 patients have been described so far. And again, somebody asked me last week, because sometimes cortisol levels tend to be low in some of these patients at the time of hypoglycemia. So you just have to be careful that there are no other features of pan-hyperpituitism in some of these patients. If there is, this is your candidate gene. So I'm now going to take you through the molecular defects in some of these genes just to illustrate what goes wrong in the beta cell in terms of regulation of insulin secretion. So like I said, the 2 most important genes which make up the channel are called the channelopathies, and these 2 genes are here. Channelopathies because they make up the channel. Mutations in these 2 genes cause recessive form of hyperinsulinism, and like I said, these a vast majority are medically unresponsive. And these children will need a near total pancreatectomy or a partial pancreatectomy. There are now also dominant forms have been described as well. Some of these are medically responsive, but some are unresponsive. Now I'll take you through the mechanisms of how mutations in these 2 genes lead to severe forms of hyperinsulinism. If you remember this cartoon model that I showed you, so this is a normal beta cell here. Look at the channel here. The channel is regulating insulin secretion and channel is fully functioning. Now, this is one particular mechanism where the channel is stuck inside the endoplasmic reticulum. It cannot get to the surface here. So this beta cell is continuously being unregulated in terms of electrical depolarization. And here you have unregulated insulin secretion. So we call this a trafficking defect. And trafficking defects are very common in molecular biology. That's where the channel protein cannot get to the particular area where it works. In this case, the channel protein is stuck inside the endoplasmic reticulum. And that's one major mechanism of severe form of hyperinsulinism. The other mechanism is the channel gets to the surface. So here the channel is up to the surface, but it doesn't respond to changes in the concentration of the nucleotide. You can see there's loss of complete dysenergy between the changes in the concentration of nucleotides and channel function. And this beta cell is also continuously depolarized. And again, you're seeing unregulated insulin secretion. And we call this a channel regulation defect. So mutations in those two genes can either cause a channel trafficking defect or a channel dysregulation defect. And last week we discussed how diazoxide works, and just wanted to, for some of the junior members in the audience, diazoxide works by binding to this channel. So if this channel is non-functional, then diazoxide will not control the hypoglycemia. So for practical purposes in your patient, if there's no response to diazoxide, 95 to 99% of the time, there's going to be a mutation in the channel genes, the ABCC8 or the KCNJ1. So diazoxide can only bind to the channel if this channel is fully functional and located on the surface of the membrane. So just bear that in mind. If you have a patient who's diazoxide unresponsive, then you can bet your bottom dollar that there'll be a mutation in the channel gene of the ABCC8 or the KCNJ11. Now going on to the metabolopathies, and I call them metabolopathies like because they involve the metabolic pathways, and some of these pathways are quite complicated. I'm going to try and keep them simple. So just for practical purposes, defects in this gene and this gene lead to a condition where there's protein-induced hypoglycemia. So when you take a history, ask the patient, when does the hypoglycemia occur? If there's an association with protein feeds, then it's either this gene or this gene. And I'm going to show you how to differentiate these. So in the hypoglycemia workup, if your serum ammonia is high, then the defect will be here. If you have a consanguineous family and your serum ammonia is normal, you may have a few other metabolite defects I'm going to show you, then the defect will be this gene here. So what is GLUD1? So this is an intramitochondrial enzyme that plays a very important role in converting glutamate into alpha-ketoglutarate. If I just show you this cartoon model here. So here we have glutamate, and the key enzyme is the GDH, is converting it into alpha-ketoglutarate, which gets into the TCA cycle and generates ATP, and the ATP then regulates the channel. The byproduct here is ammonia. Just remember that ammonia. I'm going to show you why these patients have a high ammonia level. And this enzyme is regulated by complex factors. One of the key regulators is leucine. As you know, leucine is an amino acid present in protein. And the other regulator is GTP. GTP inhibits this enzyme. So if there are mutations in certain areas, GTP cannot inhibit it. So therefore, there's hyperactivation by leucine. So regulatory mutations cause loss of inhibition by GTP. So when you have a protein meal, leucine comes along, activates the enzyme, more glutamate gets converted into alpha-ketoglutarate with a byproduct of ammonia. So we call this hyperinsulinemic hyperammonemia because of the hyperinsulinism and the high ammonia, or for short, HIHA syndrome. So this is the mechanism here. So this glutamate in the mitochondria getting converted into alpha-ketoglutarate, which gets into the TCA cycle, makes ATP and ADP. And if you remember what it does to the channel, increased concentration of these nucleotides will close the channel, and the channel then causes depolarization, and you get insulin exocytosis. These patients respond to diazoxide because the channel is intact. The vast majority do not need changes in the diet, but some patients may need a low protein diet. Now, some people will wonder what's the mechanism of the ammonia. This has been debated for the last 15 years. We don't quite understand, but this was the original concept here, that this enzyme also plays a very important role in the liver. And you may, by increased activity, you may deplete this particular compound here, which actually scavenges ammonia here. But more recent evidence suggests that the production of the ammonia is actually in the kidney. So we're not quite sure why ammonia occurs, but for practical purposes, a high ammonia level with hyperinsulinism, the defect will be in the GLUT1 gene. And these are usually dominant mutations in this gene. And here's just showing you what happens when these patients have protein meals. So this is a patient with the GLUT1 who's fasting. So if you fast them long enough, they'll become hypoglycemic. But if you give them a protein meal, look what happens. They become severely hypoglycemic. So that's one of the tests you can do if you suspect that the protein is precipitating hypoglycemia. You can actually give these patients a protein meal and see what happens in response to the protein. So they're fasting and protein-induced hypoglycemia with a high ammonia. This is pathognomic of mutations in GLUT1 gene. The second gene of interest is another gene where protein induces hypoglycemia. And again, for a long time, we didn't know what the mechanism was. But I'm now going to take you through some of the patients we've studied and some other colleagues have studied, and how observations of certain patients actually led us to the mechanism of how protein, again, can induce hypoglycemia in these patients. Some of you will know from your sort of biochemistry that this is a very important enzyme that plays a role in the way you break down fatty acids. Let me just show you this. So this is an enzyme that's involved in the penultimate reaction of beta oxidation in the beta mitochondrial fatty oxidation pathway. And this is the enzyme, this is the process, this is the pathway that's involved in. So it converts 3-hydroxy-acyl-CoA, acetyl-CoA to 3-keto-acyl-CoA. And it's got highest activity in the beta cells, which has been known for some time, but until recently, people don't know what the mechanism is, what it's actually doing there. And this is just going to show you the pathway for beta oxidation. So as you know, this is the pathway how fatty acids get into the mitochondria and get metabolized. And I'll just put up the last enzyme. So fatty acid has to combine with carnitine here. It's transported by these transporters. And then each fatty acid has to be broken down until here you get acetyl-CoA, which is one of the byproducts. But this is the enzyme we're looking at, the head edge. So this is the penultimate enzyme involved in beta oxidation pathway. And just showing you here, look at the expression in the beta cell. So it's got a very high expression in the beta cell, and there's co-localization with insulin and with the glucagon, suggesting that this particular enzyme has got a very, very important role in insulin secretion. Now, this was our first patient when I used to work in London. So this patient came along with unexplained episodes of hypoglycemia. And when we investigated her, we found that in the urine organic acids, there were these metabolites, so 3-beta-hydroxybutyrate, 3-hydroxyglutarate, and 3,4-dihydroxybutyrate. And when we did the acyl carnitine profile, we found a raised hydroxybutyl carnitine. And this patient had responded to diazoxide, but the dose we had to use was a good dose. At first, this is just showing you the hydroxybutyl carnitine here. So we noticed that in this particular patient, the level of hydroxybutyl carnitine was about 1.8. In some of the patients with ketotic hypoglycemia was around 0.2, and some of the control fasting patients was 1.2. In some of the other patients with hyperinsulinism, this is not this particular one, but for example, the KTB channel, this particular marker was only 0.8. So we at first thought, because this is elevated, this has got something to do with insulin secretion. But as you'll see, this wasn't the answer. Then this paper was published. So in this particular patient, the hypoglycemia started from birth. In our patient, she presented at 3 years of age. But in this patient, there's severe neonatal hypoglycemia. And these two siblings died. We don't know what, but possibly neonatal hypoglycemia. And then the question emerged, so how does a defect in a fat oxidation enzyme control insulin secretion? And like I said, the mechanism was unknown until recently. And I just want some of the junior doctors to focus on this, because looking at particular patients will give you a powerful clue as to the mechanism of disease. So at first, like I said, we thought that the hydroxybutyl carnitine, which was present in our patient, was acting on this amplification pathway. This was our original thought. But then this paper was published showing that, at least in the mouse, this particular enzyme is a negative regulator of insulin secretion. And then this patient was published from Italy, I think she's from Italy, where they found, again, the same sort of clinical scenario, but this time the organic acids and acyl carnitines were completely normal, the homozygous mutation in this gene. This suggested that the raised acyl carnitine may not be the underlying mechanism that precipitates hypoglycemia in these patients. This was the Italian patient. Interestingly, some of these patients responded to diazoxide, but if you take the detailed history, when the patients had a protein meal, they used to become hypoglycemic. The ammonia level in all the patients was absolutely normal. In our patient from Italy, and the other patient, I think from Norway, that was reported. Then what we did, so given the observation that some of the parents said the hypoglycemia occurs after a meal, we actually brought our patients in and we gave them a protein meal. And as you can see, each of these patients developed hypoglycemia in response to a protein meal. So all patients became hypoglycemic. Whereas controls, most of them didn't develop hypoglycemia. So this gave us a clue that somehow there's something in the protein, possibly leucine, possibly another amino acid, that may be triggering hypoglycemia in these patients. And then this particular paper came out showing that this particular protein has an interaction with another protein, and that protein was GLUD1. So here you have a very powerful clue that this head-H enzyme, it's somehow interacting with the other enzymes I showed you, GLUD1. And then the mouse work further showed that if you remove the islets from these head-H mice, they show a very good response to a mixture of amino acids. And eventually was shown that leucine was the amino acid. They were leucine-stimulated hyperinsulinism. And they were able to show that there's an interaction between the head-H protein and the GLUT enzyme that I showed you earlier on. And this is just tying everything together. So if you remember, I showed you the GDH. I showed you that GDH converts glutamate into alpha-ketoglutarate. And I showed you that GDH is regulated by leucine and by GTP. Now here, what's happening, this is your fatty acid oxidation pathway. So if you have a defect here, head-H cannot regulate the function of GDH. It's a negative regulator. And therefore, if you take that negative regulation away, leucine in your protein metabolism stimulates insulin secretion. As you know, ammonia will be normal here because this enzyme has got nothing to do with ammonia. It's not present in, for example, the kidney. So very, very powerful clue from, I think, roughly 4 patients in deciphering a molecular mechanism of how a defect in fat oxidation can actually lead to hyperinsulinism. And again, for the young doctors in the conference, working on individual patients can be extremely, very, very powerful, looking at some of the clues that I showed you in the biochemistry and taking a very careful history. Then moving on to the transcription factors. Oops. You all know that some of these transcription factors, for example, HNF4 alpha, are known causes of MODY. For example, this one causes MODY1. Here, I'm just showing you the role of these transcription factors. Here, for example, in the nucleus, you can see you've got HNF1 beta, HNF3 beta, HNF1 alpha, and 4 alpha. So they orchestrate information from various signals, and then they regulate multiple genes in terms of how the beta cell will release insulin. So just remember the role of these here, as I'll show you how they're involved in hyperinsulinism. So this was the first paper showing the role of the HNF4 alpha gene in causing hyperinsulinic hypoglycemia. And then we published something similar on our patients. So these were some of the families that we studied. So these are the actual patients here. So if you focus on the actual patients shown here, so all of these patients had severe form of hyperinsulinism. They all responded to diazoxide therapy. I'll show you the biochemistry in a minute. But the key message I want to give some of the junior doctors in the audience is look at the family history. If you take a very detailed family history, you will see there's a history of MODY. So all of these have MODY. So in each family, there's a MODY history. And we were able to go back and look at the gene defect in the baby and then trace the exact same defect in the families here. So we have a baby with hyperinsulinism, but the same gene defect causing MODY in the adult family members. And this is just summarizing all the biochemistry. So most of the babies were macrosomic. So generally HNF1 alpha, HNF4 alpha babies tend to be macrosomic. Gestation term, age of presentation very early. Look at the glucose infusion rate here, up to 25 milligrams per kilo per minute. your normals up to 6 to 8 milligrams per kilo per minute. Some of them responded to glucagon, so another marker of hyperinsulinism, and they all responded to diazoxide. So again, remember the channel is intact, so they should respond to diazoxide. And the key thing was here, I showed you on the earlier slide, was a family history of MODY. And what's fascinating is that we were able to stop the diazoxide in some of these patients. So this patient came off. This patient came off after I left, and this patient also came off after I left. So the vast majority of patients with the HNF4 alpha will come off diazoxide, but they'll need follow-up because they'll develop MODY. And then subsequently, the other transcription factors were also reported to cause exactly the same phenotype of hyperinsulinism and MODY. So HNF1 alpha has been implicated. And this is just showing you again what I showed you earlier, that there's an orchestrated signal of how these transcription factors may regulate the function of the channel, but also some of the other genes that I showed you that lead to unregulated insulin secretion. Some of you will ask me, so what's the mechanism? How does a defect in HNF4 alpha lead to hyperinsulinism and MODY? And the answer is we still don't know what's going on in some of these patients. And this is an area, very interesting area of research that's still ongoing. But we're now going to touch on, there's a patient in India, one of your colleagues has been communicating with me about a possible patient with exercise-induced hyperinsulinism. So this is due to a defect, and this is another transporter, SLC116A1. This plays a very important role in moving lactate and pyruvate into the beta cell. And we know that lactate and pyruvate are very potent insulin secretagogues. Now, one very important message to remember, normally, this gene is not allowed to be expressed in the beta cell. So we say that this gene is silenced. Silencing means you don't want it to work. Whereas you'll see in these patients, this gene is overexpressed. So it's sucking lactate and pyruvate into the beta cell to release insulin. So again, key message from the clinical point of view, these patients develop hyperinsulinism after strenuous exercise. So far, only 2 families from Finland have been reported with this condition, and mostly above, I think, 15 or 16 years of age. I've never seen it below that age. And typically, these patients, if you take a history sort of half an hour to an hour after strenuous exercise, they become hypoglycemic. I'll show you in a minute. This is because of hyperinsulinism. And I showed you earlier on that it's due to failed silencing of this particular transporter. And this is work done by Dr. Timo Tonsky from Finland, where they first reported these patients. So here you have blood glucose over time. And you can see that after exercise, these patients become hypoglycemic. These are controls. These are your patients. And look at the insulin secretion. So here, so insulin levels go up here compared to controls. The interesting thing is the concentration of lactate and pyruvate, it's not affected. It's the transportation that's important. It's not the actual difference in the concentration of lactate and pyruvate. And here what he did, Timo actually devised a very nice test where he gave them intravenous pyruvate to see if that will trigger hyperinsulinism. As you can see, here the blood glucose level tends to go down in patients, cognitive controls. But look here, insulin level shoots up here. And of course, because he gave pyruvate, the pyruvate level goes up here. Lactate went up slightly here as well. So he called this the pyruvate stimulation test. I've never done it before. I personally would not recommend it, but it's in the protocol given in that particular article below. And this was the families, 2 families they reported. It's an autosomal dominant condition. And as you can see, multiple family members are affected. The gene, they used genetic linkage studies and mapped the gene to chromosome 1. And I'll just show you some of the molecular work of, oops. So what's going on here is this transporter is expressed on the surface of the beta cell here. Normally, remember it's silenced, it's not there normally, it's present in very, very low concentrations. But here in these patients, it's overexpressed. The promoter mutations cause increased expression and increased movement of lactate into the beta cell. And lactate, we know, is a powerful stimulator of insulin secretion. So normally in a normal beta cell, lactate is not allowed to enter because it causes insulin secretion. And here he's just showing you the increased expression of the MCT in the patients compared to controls. So these were promoter mutations in the MCT1 causing increased expression. And again, here, just showing you that here in the pancreatic islets, it's virtually undetectable. It's really silent. It's not there at all. Whereas this particular transporter is expressed in a lot of the other tissues. For example, you might need this in the heart or the muscle, etc. So in summary, I want to just show you this particular cartoon model of a beta cell and just show you the molecular defects. They're not all on here, but some of the important ones that I showed you. The key defect we discussed that leads to severe hyperinsulinism are mutations in the two channel genes. And just remember, like I said, if there's no response to diazoxide, then the defect has to be here. Whereas if if the patient respond to diazoxide, then the defect could be in any of these. Remember that GDH1 and HESCHAD or HEDH lead to protein-induced hypoglycemia. Remember these two transcription factors, family history is very, very important of MODY. And I showed you a transporter of lactate and pyruvate that gets into the beta cell. Thank you very much for your attention. And thank you once again for inviting me to this wonderful meeting.
Thank you so much, Professor Hussain. It was a wonderful lecture on, and I'm really thankful that you took back to our biochemistry days and touched very basically, and I'm sure the junior training doctors from in endocrinology and pediatric endocrinology will be benefited. And I think I'll give it over to my colleague, Dr. Thomas Paul, for introducing the next speaker. And I think you must join us at the end of this session for panel discussion. Over to you, Dr. Paul.
Yes. Can you share the? Yeah. So back to the second talk. Of course, Professor Linda DiMiglio has been introduced with the previous talk, insulin and glucagon. And brief introduction, I'm going to do a brief introduction again. She's a professor, Department of Pediatrics, Indiana University, and Director of Career Development and co-chair of Pediatric Protocol. And she is into Clinical and Translation Science Institute and clinical research in type 1 beta cell preservation and new technologies. She has been medical director of ADA Association CAM, and she was also president of ADA Indiana Affiliate Community Leadership Board. She's active clinician. That's the reason she's going to talk on the approach to a child with the fractures. Over to you, Professor DiMiglio.
There it goes. Okay, thank you for the introduction. And I need to explain, I guess, that the background that we provided was primarily in my diabetes area, which is where most of my funded research is, but I have been running a metabolic bone clinic at Indiana University for over 20 years and actually started my career with career development awards in bone and in diabetes, and so I've kept up both, and I do some research in bone. And I really am very excited that you've invited me to speak about both parts of my brain, so to speak. So the diabetes part and also the bone part. And what I decided to do with this talk was, knowing that there would be a fair number of adult endocrinologists in the audience and also some peds endos, was develop a talk that hopefully will tell you a little bit that will be helpful to everybody around how to approach kids with fracture. This is my disclosure. So I'm going to start with the skeleton, and this is one of my favorite figures from the Mutter Museum in Philadelphia in the States, which shows a skeleton of a child with, or a person with adult with dwarfism and an adult with acromegaly. So you have somebody who has achondroplasia and somebody who has a very large skeleton. And so when I talk about skeleton and accrual, I'm always amazed by the diversity in skeletal size. So your skeleton is made approximately 70% of mineral. The majority of that is calcium, which is then coupled with phosphorus. And calcium in the skeleton increases from 25 grams at birth to over 900 grams in females, about 1,200 grams in males at the time of peak bone mass. The skeleton also has phosphorus, which goes along with the calcium that's seen as phosphate. And about 30% of the skeleton is organic material, which is primarily type 1 collagen. So the bone mineral is accrued throughout childhood And for those of you that are not pediatric endocrinologists, you would at least know that this looks like a growth chart. And you can see here that mineral is accrued gradually over time. This is age in years, total bone mineral content in grams. The pink line here is the girls, and the blue line here is the boys. And you can see that the rate of bone mineral accrual parallels that of linear growth, although there's continues to be some bone accrual after linear growth is done with consolidation up into your early 20s. At about 26% of adult bone mineral is accrued in the 2 years around peak height velocity. So this is as much bone as most people will lose in their entire adult lives with osteoporosis. And so this is adolescence is a critical period for bone mass. Adolescence is also a high period of fracture because your skeleton is growing faster than your bone can accrue, plus your brain is still maturing, so you may do things that are more risky behaviors as well. And the bone mass acquired during childhood and adolescence is the natural protection against osteoporosis. So how do we figure how much mineral is in the skeleton? I'm sure you are all are familiar with these various ways of doing bone mineral assessments, ranging from bone biopsies, which I've only, I don't do personally, and I've only had done in a couple patients. Usually I have relied upon some of these things. I would say that heel ultrasound, although it's used still in the adult world, is not something that's useful in children because of the way that you need to place the heel into the device and variability in positioning, making it not very useful. So the main thing that is useful is DEXA, and that's what I will focus on. Although I think we're moving more to doing more peripheral QCT assessments like you see in the figure here. So when you assess bone mineral density by DEXA, DEXA is so-called as a dual energy X-ray because it uses 2 radiation beams to distinguish bone from soft tissue. It's a very low radiation scan. I think that that's important when you're asking families to do it because they're worried often about whole body X-rays. And I always say you get more radiation in the car driving to your DEXA or coming by train to your DEXA than you probably do from the assessment itself. Certainly, had I flown to India to give this talk, I would have gotten a lot more radiation from those flights. The scan time is about 3 to 15 minutes, depending on the sites assessed and the size of the children. And it's the most appropriate test to be used in children. And per consensus guidelines, total body less head and the lumbar spine are the preferred sites. That's related to positioning and accuracy of those assessments. DEXA, as you all know, generates a T-score and a Z-score. These are both standard deviation scores, with the T-score comparing the bone density to a mean value in a young adult population matched for sex and race, and a Z-score being the value that compares bone density to mean value for people of the same age and sex. So the Z-score is your age match score, and therefore it's the only useful value in pediatrics. But yet, we see a lot of children coming to us that have had bone densities done on machines where they have had T-scores reported. In fact, one of my colleagues, Rachel Gaffney, published a paper where she was looking for kids with idiopathic juvenile osteoporosis and found that the children referred to the NIH here in the States for her study usually just had bad DEXA reporting. So it's really important, no matter where you are, that you know who's doing your DEXAs and you know that they're reporting them properly. So this brings me to my principle of mind your T's and Z's. So it's kind of like you're minding your P's and Q's, but these are T's and Z's. And the reason is because if you take a 12-year-old boy and you compare him to young adults, which is what a T-score does, his bone density will look quite low, despite his age match score being normal. And whereas you take his older brother, and who's a 25-year-old man, and the T-score and Z-score should be about the same. You'll often find that they're not exactly the same because the software that is used to generate the T-score and the Z-score I often use different databases. But I always tell my patients that saying that you're short or you have a low bone density based on a T-score is like saying your child is short just because they're not yet at adult height. So it's really critical that the scanner has the software for image acquisition and interpretation appropriate for your patient's age. And whenever I get outside bone densities, I always have to look at the pictures to make sure it was done properly. So why are we doing bone densities? Well, we're looking for osteoporosis. And osteoporosis is defined as low bone mass and microarchitectural deterioration of bone tissue, leading to bone fragility and consequent fracture. I like the definition of too little bone in bone. And this shows a normal vertebra and an osteoporotic vertebra. It's important to recognize that there's a high, there's a high rate of osteoporosis with women having a 40% risk and men having a 13% lifetime risk of developing osteoporosis. Adult osteoporosis is then defined based upon that T-score, with normal being higher than 0.1 or -1, osteopenia between -1 and -2.5, and osteoporosis being less than 2.5. For children, there are a different set of criteria, and interestingly, these have not changed over the last 7 years. They were updated from a prior position statement in 2013, but the diagnosis in children, unlike in adults, cannot be made using bone mineral density criteria alone. You can make a diagnosis of osteoporosis if you find one or more vertebral compression fractures, unless there's local disease in the vertebra or high energy trauma. So I always talk about, I had a child that jumped off a cliff and broke his vertebra when he hit the ground rather than the water. I have another kid who was pushed into a dresser. The kid pushed in a dresser had osteoporosis. The other one just had high trauma. And if there's no vertebral compression fractures, osteoporosis requires both a clinically significant fracture history, which I'll talk about on the next slide, and a low bone density Z-score. Oops. So here is a clinically significant fracture history. This is per the ISCD, the International Society of Clinical Densitometry Pediatric Position Statement. You have to have had 2 or more long bone fractures by the age of 10 or 3 or more long bone fractures before the age of 19. Note, however, that a bone density Z-score, this is in the position statement, greater than -2 does not preclude the possibility of skeletal fragility and increased fracture risk. So just because your bone density looks normal by Z-score does not mean you may not fracture and you may not have fragility. And I think this makes sense, but it's different, I think, living most of my life with adult endocrinologists and the way that they handle osteoporosis. We would not automatically treat somebody with a low Z-score in pediatrics, nor would we treat somebody now would we say somebody with a normal Z-score would not have a higher risk of fracture. So I'm just going to use a clinical case to illustrate kind of the approach to fractures. I'll call this a major fumble. This is an 11-year-old boy who has a history of 4 fractures. At the age of 10, he had right leg pain and a femoral fracture a few days later. He was playing American football, and the family said he did not have a hard hit when this happened. And at age 11, he had a left femoral fracture while playing American football again. And then he was actually casted for the femoral fracture, and he was walking with crutches and fell down the steps and broke a wrist. Here is the bone density report I received on him. What was focused on here was his age-matched Z-score, which was -2.1, and he also had a total hip bone density. I told you that was, here's lumbar spine. He had total hip bone density that was -2.5. And based upon these data, the report that I received said this is abnormally low bone density, this 11-year-old male. In the lumbar spine, it's in the osteoporotic range, and in the femoral neck is in the osteopenic range, and that they wanted a clinical workup and 1,300 milligrams of calcium intake per day, which is the RDA in the US, and he was sent to see me. So does he have low bone mass for age, and what can we do about it if he does? So when you do an evaluation for fracture in children, there's 3 steps. First is the history. Depending on the history, I will do then a tailored metabolic evaluation, and then I will assess bone density generally by DEXA. The evaluation history, I'm asking about the number and mechanism of fractures. I gave that to you for this patient, so I always want to know how many times have they fractured, how did they fracture, and what was the story. I ask them if they have hypermobility, and I'll ask if they can do any tricks with their joints. This is a way to have people know if they can do funny things with their fingers or elbows. Diet, particularly calcium intake. In the US, that reflects milk intake. I recognize that in India, there's often lower cow's milk intake. So this may reflect chickpea intake, ragi intake, and almond intake as sources of dietary calcium. Physical activity level is really important. I'm not only looking for the kid I told you was a football player, but also looking for the child that had a fracture or 2 and then stopped doing all physical activity and is still fracturing, because that will be different. And then family history, looking for things like osteogenesis imperfecta, fracture, hypermobility. So can you do any tricks? This is a child of mine that I followed. He's now a young adult with osteogenesis imperfecta, and he knew that he could bend his fingers in this way, which I cannot duplicate. He also has slightly gray sclera in this picture. And then the history often tells you the etiology. So, and there's endocrine diseases here is in purple because this is where we fall and why they come to see us. But there may also be inadequate physical activity leading to risk of fracture in kids with cerebral palsy or things like that, inadequate nutrition, genetics, genetic disorders, chronic disease, or use of medication. So you have to look at all of these things and think about these as you're doing the history. And this is x-rays from an 11-year-old, not that 10-year-old rather, not the kid I showed you in the case, but a different child who had fracture. This is one of his femur fractures. He had had a series of femur fractures. He actually has really like osteopenic looking bones. So osteopenia is not a DEXA diagnosis, but can still be a radiologic diagnosis. He had very thin fibula here. And actually this all happened because of the fact that he had very low calcium intake. He was a child with autism who only ate 3 foods and none of them contained calcium. And actually once we put him on adequate dietary calcium, he did not fracture again for another 6 years. So knowing and taking that history around diet was what led me to figure out this case. Once you've done the history, then you would tailor the metabolic evaluation based upon what you've learned in the history. In general, I will measure serum calcium, phosphorus, creatinine. I'll measure alkaline phosphatase or bone-specific alkaline phosphatase as a bone formation marker. I'll measure PTH and I'll measure 25-hydroxy vitamin D. And then often I do a spot urine for calcium and creatinine just to make sure that there's enough adequate calcium intake, that there's some calcium coming out in the urine and it's not all like being sucked up by bone because there's not enough dietary calcium. Similarly, I sometimes have found kids with hypercalciuria. So when you want to measure vitamin D, you always just want to measure 25 vitamin D. The reason is that 25 vitamin D has a very long half-life. 125 we measure sometimes as endocrinologists, but I would not measure it in the case of fracture. It has a very short half-life, is not helpful. And you'll know if you've measured vitamin D well, if you've got an HPLC or mass spec measure, if you see results for both D2 and D3. And I was part of the a consensus panel on rickets, and this paper was co-published in the Journal of Clinical Endocrinology, Metabolism, and Hormone Research in Pediatrics in 2015. But we looked at the classification of vitamin D status based upon serum 25-hydroxy vitamin D, showing that deficiency being less than 30 nanomoles per liter and sufficiency being greater than 50 nanomoles per liter. For my kids that are coming in with bone disorders, I'm always trying to get their vitamin Ds to be greater than 50 and often greater than 75 nanomoles per liter. So who would you do these things on? Well, kids with fracture, and then you would also, you're looking for bone disease in kids that have rickets, osteoporosis, other bone disease. You're also looking for anti-seizure, kids in anti-seizure medications, particularly topiramate is one that can decrease bone mass. Steroid use and some antifungals, some antiretrovirals can affect bone density, particularly potentially tenofovir, although the data on tenofovir is a little mixed. And then kids with other chronic diseases, chronic kidney disease, malabsorption syndromes, liver failure, things like that. Once you've done your labs, then you want to assess bone density. So the first thing I do is I look at all the available x-rays that I have. I have the families bring them in. I look at them. I assess them like I showed you that assessment on the 10-year-old boy. And then also measure the X on a machine with appropriate pediatric software. And there are good guidelines from the ISCD, but also this nice paper on bone density in children and adolescents, which is a paper that came out of the section of endocrinology from the American Academy of Pediatrics that I thought you might find a useful reference. So children with low bone density Z-scores do have an increased relative risk of fracture. These data come up from Alyssa Golding's work in New Zealand, where she looked at fractures in teenage girls, but she found that a 1 standard deviation reduction, so a 6.4% difference in total body bone density, nearly doubled the risk for new fractures with a highly significant hazard ratio. And although some of the higher prevalence was attributable to low bone density, some is probably related to other mechanical or structural musculoskeletal properties. So I told you that type 1 collagen is in bone, and I certainly see kids that have musculoskeletal issues, so with lower lean body mass that also have lower bone density, which is not all related. It causes low bone density, but it's not the primary etiology. So back to our case, his history, he was a full-term baby and he was healthy. He had been hit by a car at the age of 2 and had no fractures, so that was a major trauma. He'd been playing football hard since the age of 7, but didn't start fracturing until the age of 10, no family history of fracture. He had labs obtained by his primary doctor, which I did not repeat, so his calcium was normal, phosphorus was normal. It's important to recognize, at least here in the States, phosphorus is not part of our metabolic panel, so you have to remember to order it separately, and you have to remember to look at normal ranges for phosphorus that are appropriate for age, because sometimes it's just an adult range, but that was normal for him. He had an alk phos that was normal, and they also measured PTH, and I told you not to measure 125 vitamin D in this context, but they had measured that, and that was normal. So what's the possible reasons for this kid's low bone density? So could somebody have abused him? It's always something to think about in younger children with fracture. An 11-year-old would be less likely that the child would not tell you the story. Could it just have been bad luck? Certainly I see kids that have multiple fractures that have no great reason. Could it be idiopathic juvenile osteoporosis, which is a disorder where kids fracture during their teenage years, but then it gets better, although a lot of them have lower bone density even as young adults. Could it be an undiagnosed chronic disease? That's why I do some of the screening. Could he have osteogenesis imperfecta, which is by far the most common inherited disorder that I see, which causes fracture? But going back to his bone density, there are a few things I didn't highlight before that some of you may have caught. So I told you he was 11, but his DEXA was read as if he was 21 years of age. And if you look here at the comparison to reference range, you can see that that's not that uptick that I showed you earlier, which looks like a pediatric growth chart. And in fact, this is an adult range with a decrease in bone density appropriate seen in adults. And so these data are useless data, because what they had done is they knew that they needed a Z-score for it to report out. And in order to do that, they changed his age, but they didn't actually have the pediatric software. So these data are useless. We repeated his bone density on our machine at IU. By this point, he was 12 years of age. We plotted him on a reference data set that looks like a pediatric reference data set. And in fact, his age-matched Z-score was above average at plus 1.8. So does this child have osteoporosis? No. But does he have bone fragility? Well, maybe. And this is, again, data from the Goulding group that suggests a history of fracture and low bone density are independent risk factors for future fracture in both children and adults. So this is a group of children, 601 children from a birth cohort, where there were questionnaires about growth about fracture at different ages. And what they found was that some kids had no fractures, but those who had a single fracture obviously had a single fracture, but those who had multiple fractures had by far the majority of fractures. And so having once you've had one fracture, you're at increased risk of future fracture, even if you, with everything else being equal, even if your bone density looks normal. So 1 year follow-up on my patient, no new fractures, and good increases in bone density for age. So I'm going to just spend the last few minutes talking about therapies for children with osteoporosis. And I have to start with calcium, which is not a very sexy therapy, but is what is really critical that we remember calcium. I showed you that case, which really illustrates that point. It's critical in puberty, yet calcium consumptions by teens is declining, as at least in the US, as milk consumption is being replaced by water and flavored waters and soda. And it's important to recognize that if you eat high sodium foods, which is something that's very prevalent in current diet, it affects mineral accrual, since urinary sodium makes you pee out more urinary calcium. Adequate intake of calcium is shown here. I know that in India, you have lower average intake of calcium, and certainly if you're on a lower calcium diet chronically, you do better to absorb your calcium. But I think that these recommendations hold across different populations, and that the recommended intake for calcium is about 1,300 milligrams a day during the adolescent period when there's a growth spurt, but it's tiered for younger kids and into adulthood. And these are Indian data looking at the sources of calcium intakes from adolescent boys and girls. This highlighted, firstly, if you added all these up, the medium calcium intake was well below 1,300 for these adolescents. But also this highlighted that those children of higher socioeconomic status had greater calcium intake, and that boys had greater calcium intake than girls. So higher socioeconomic status, better calcium intake than lower socioeconomic status, and boys greater than girls. So something just to keep track of as you're seeing these children there. Vitamin D is also critical for bone mineralization. It increases calcium absorption in the gut, increases phosphate absorption in the gut, and at the bone, it increases bone resorption and facilitates bone formation, so works on bone turnover. You can become vitamin D deficient if you don't have enough sunlight, because you can make vitamin D as a hormone. We think of it as a vitamin, it's actually a hormone. And you also have dietary deficiency if you don't get enough vitamin D3 or vitamin D2 in your diet. Vitamin D intake is recommended. This is again from the consensus statement of at least 400 international units per day as being adequate to prevent rickets. So all children, they should be getting at least 400 international units per day. And then older children through adulthood is 600 international units per day is what's recommended, or 15 micrograms per day as recommended by the Institute of Medicine. So in addition to calcium and vitamin D, what else do we have in our toolbox? Well, there's a few pharmacologic therapies that have been used for low bone density in children. This includes calcitonin, which I'll mention briefly, but then primarily bisphosphonates, both IV and oral. Calcitonin does increase bone density, and particularly in kids with high bone turnover, but this use is limited by tachyphylaxis and allergic reactions. It's generally safe and well tolerated, but the effect on fracture rate is not certain, and there's very few pediatric data. And it's not something I use clinically anymore. We used to use it clinically for hypercalcemia, but now we switched over to using it using bisphosphonates in that realm as well. Bisphosphonates are synthetic stable pyrophosphate analogs. They bind to hydroxyapatite crystals in the bone and inhibit osteoclast-mediated bone resorption. They work by inhibiting osteoclasts, causing the osteoclasts to become apoptotic, and then the osteoblasts continue to do their job. This I just had to show because it's my favorite. It's a German diagram, but it basically shows a very happy osteoclast working its way along the bone and then hits this bisphosphonate labeled bone and becomes unhappy and eventually becomes apoptotic. So this is the visual I use to remember how bisphosphonates work. But there's a whole bunch of pediatric uses of bisphosphonates. I won't read through this whole list, but I will tell you that there's a lot of places where we use it. I mentioned for hypercalcemia, OI is by far the most common use. And then the next most common in my clinic is immobilization osteoporosis. So for some of the children who are immobilized for some reason or have cerebral palsy. I would say that I will point out that fibrous dysplasia is on this list, but it's only for pain relief. It does not work to improve the bone mass. And then cancer-related osteoporosis is something that you could invite Leanne Ward here at some point to give her a talk on this. She does a really nice job with looking at cancer and osteoporosis in the group in Canada. They have a large registry of those kids. Doses and types. IV pamidronate is the primary one that's used worldwide, followed by zoledronic acid. There's a variety of different dosing regimens that can be given. There's also various oral forms. Risidronate is the only one that has a randomized control trial showing effect in osteogenesis imperfecta. I added pamidronate to the list. I do not have that available here, so I've not used it orally. I've only used it IV, but you have it in India. Side effects of bisphosphonates are that initial acute phase reaction with fever, musculoskeletal aches, and emesis. In kids that start taking it orally, this usually happens about 2 weeks into the dosing if they get it. In kids IV, it happens usually within 24 hours of the dose. Just note that kids with OI often are dosed lower. There's a nice paper by Craig Munns talking about respiratory distress with the first dose in kids with OI. You could have hypocalcemia, so I make sure that they have adequate calcium intake and they've got good calcium status prior to coming in. Iritis is reported as being rare, but I have seen a couple kids get it, so I don't know if that's just my luck or whether it's more common than reported. And then atypical femoral fractures are more of a concern in adults, but a couple pediatric cases have been described as having this. There are very limited long-term data, which is a concern with using bisphosphonates in kids. Reports of jaw osteonecrosis and esophageal cancer in adult patients. Osteopetrosis, so rock-like bone that is brittle with zealous use. And there's questions about release during pregnancy and fracture healing effects over time. When do you think about using bisphosphonates? Well, if you have a fragility fracture with a low bone density or vertebral compression fracture, particularly long bone fractures, vertebral fractures, femur fractures. If you know that they don't have a vitamin D problem or calcium problem, or it's not something where they're on steroids and will stop, we actually reported kids who had been getting Neocate as a formula that before it was reformulated a few years ago was causing hypophosphatemia, and some of those kids were having fracture. And then if they have evidence of high bone resorption, I put a question mark here. I don't know that I necessarily require high bone resorption before I start a bisphosphonate, but I certainly don't want them to have suppressed bone turnover, that they're not accruing bone density normally, and or they have a clinical context consistent with benefit from bisphosphonate. There's little general consensus on criteria to start treatment, including if they should be used prophylactically, and really no consensus on treatment regimens, although there's this nice paper from the APEG group that basically talks about consensus guidelines and takes a lot of actually what I've told you and lays it out and assesses the evidence around it, which is variable, but their approach is very similar to the one that I have been using. And there's no general consensus on how to monitor kids once you put them on therapy. What I do once I have them on therapy is I do a bone density once a year. I monitor those same metabolic markers I talked about annually. I monitor dietary calcium, urine calcium, creatinine, and I monitor bone turnover, and I just watch. And if it goes down, I use that plus the bone density to titrate the dosing. And there's questions about optimal duration and long-term effects of therapy. But I think overall it works well, and the children get good pain relief and fracture rates go down. There's a potential for other pharmacologic therapies for low bone density. IGF-1, which we talked about earlier. I don't know anyone using it clinically in that way, but it has a potential to increase bone mass. The sclerostin inhibitors are getting a lot of press on the adult endocrine side, and I'm glad we have adult endocrinologists here, because if people ask questions about them, I have not used these at all because they're not yet approved here for use in children. And there are very few pediatric data. Denosumab is now being used in children as a rank ligand inhibitor, and we are part of a large multi-center study of denosumab for kids with OI. And parathyroid hormone has a black box warning on it for children here, but I leave it on the list because it's a potential therapy. I think if we're going to use it in kids, we'll use it for hypoparathyroidism before we'll use it for osteoporosis. I want to just note that exercise is also critical. Exercise has a positive effect on bone mass. Children involved in high impact weight-bearing activities have higher bone mass than those who do not. There's been a school-based jumping program in British Columbia where every time the bell rang in school, kids had to jump on and off a small, like a box, and that improved hip and spine bone mass. And physical activity accounts for a fair amount of variance in bone density in persons at peak bone mass. But it's not clear how long the term benefits, the benefits from exercise may be retained, although Stuart Warden at our group has looked at side-by-side differences in bone size in people that were baseball pitchers during their childhood years and young adult years, and shows that into later adulthood that at least the bone size advantage, which gives you a mechanical advantage, is maintained. So I'll close with some unanswered questions. So one is how to optimize nutrition and physical activity in childhood for bone accrual. I think following the RDAs here is critical. How to best to assess bone mass longitudinally in view of the constantly changing skeleton. So if you're going to do a peripheral QCT of the wrist, and then the bones are longer the next time, like how you want to look at that and how you're going to assess bone that's not the same bone. How current methods of bone mineral assessment correlate with fracture rates is not as well determined as is in adulthood, where you have 1,000-person studies. We have very small amounts of data yet. And how to optimize and personalize pharmacologic osteoporosis management. It really is an art rather than a science. And so with that, I will close, and I'm happy to take questions now, or I think you're moving them to the end because we are behind in the session. But
okay, thank you very much for the very beautiful overview of the clinical approach to the fractures, especially in children. Of course, there are so many things which are like, we have whether which database to use, whether we should use an Indian ethnicity specific database to use, because we have the same problem in adults also. There's so many questions we have to find an answer. So we will take a discussion at the end. I will go to the next speaker. Dr. Sriram, can you take the next?
Thank you, Dr. Thomas Paul. And it's my pleasure again to, first of all, we had the pleasure of listening to Professor Francesco Chiarelli, and now it's my privilege to introduce him for the next talk. For people who have joined late, Professor Chiarelli from great endocrinologist from Italy, Department of Pediatrics, University of Chieti, and his list, even though it's been given in one slide, you can read for yourself. More than 600 publications with H index of 62, more than 5,000 citations, extensive work on diabetes in children and obesity. We saw his expertise in type 1 and his great insights, and we will now listen to his talk, and we are eager waiting for monogenic obesity, his insights into it.
Yeah, thank you very much. I've been told to shorten up my presentation because we are much behind of time. Unfortunately, I think I need Dr. Sri Nagesh help for my slides as well. Yeah, thank you. Yes, thank you very much. So you can skip the first 5 slides, please, which are the same of the previous presentation. Go ahead, ahead. Yeah, go ahead. Yes, go. Yes. Okay, okay. Here we are. This is the outline. Next slide, please. Why it is important to know about monogenic obesity. Next, please. First of all, monogenic obesity is quite a rare condition which can be identified amongst the high number of obesity or children with obesity that we see every day. Next, please. Is a very interesting endocrine disorders with a disturbance of an energy homeostasis due to a hormone or receptor defect. The diagnosis of monogenic obesity will help patients and parents tremendously because some form, next please, some form of monogenic obesity are treatable conditions nowadays. And therefore, it's quite important to understand the pathogenesis of these conditions in order to first understand better the endocrinology of body weight regulation in children and also to provide a timely treatment whenever possible. Next, please. The problem with monogenic obesity, as I said, is that because we face such an epidemic of obesity. In Italy, as I said, 40% of children are obese or overweight. Therefore, it's quite difficult to focus on those patients which potentially could have a monogenic form of obesity. So it is therefore very important to decide when molecular diagnostics procedures are indicated. And I will try to agree with you when we have to think about monogenic obesity. Next, please. I suggest, but of course I'm ready to discuss, that one of the indications could be to when you have a patient with extreme obesity and hypogonadism. I will come back to this. School children with exaggerated weight gain, a child with rapid weight gain directly after birth or after weaning with extreme food-seeking behavior, and an extremely obese child with normal weight parents when we know consanguinity, which can be the case in some circumstances. Obviously, we are speaking about quite complex physiopathology behind these forms. You can see here, if we focus on the leptin receptor mechanism, which may lead afterwards to the production of POMC and then on turn to the alpha MSH and beta MSH, and consequently to the activation of the receptor MC4R, which can be of importance in some forms of monogenic obesity, as we can see in a minute. The important thing, next please, the important thing is that we now know that because the MC4R pathway is a component, a very important component of a central melanocortic pathway, and plays a vital role in regulating appetite and the energy balance. You can see here, upstream of the receptor of the MC4R, you have the leptin receptor, which in turn determine the production of POMC, as I said, and the production of a CTH and alpha and beta and gamma MSH, which in turn activate the MC4R, and therefore, if something is wrong with this, next please, with this pathway, you can have obesity with marked increase of appetite, of body weight, and marked reduction of energy expenditure. Next, please. if we look at the rare monogenic form of obesity in man described so far, but we will see that other forms are now in the pipeline. You can see here described which leptin, which is an homozygous mutations, which determine an extreme weight gain in the first year of life, marked hyperphagia, congenital leptin deficiency, and hypogonadotropic hypogonadism. So therefore, the reason why we have to look at the hypogonadotropic hypogonadism is because the leptin and the leptin receptor we are involved in the determination of the hypogonadotropin hypogonadism and the production of gonadotropins. Next, you have POMC, in which, as I will show in a minute, you can get excessive weight gain in the first year of life, possibly hypoglycemia because of ACTH insufficiency, adrenal insufficiency, in many children, red-colored hair, and hyperphagia. Then you have the PC1 homozygosis mutation or heterozygous mutation. Again, you have a marked weight gain in the second year of life and a possible period of failure to thrive, neonatal diarrhea, hypoglycemia, and other endocrine disturbances. And finally, is the MC4R, which again can give weight gain starting at any time during childhood, also after the preschooler years. In homozygous mutations, the carrier mostly have symptoms in the first year of life, and the hyperphagia tends to improve during life, and they have an increased linear growth. And I will show now briefly a couple of cases, interesting cases. The first one is a patient which was described some years ago, is a patient described in Germany. This child had this anthropometry at 2 years and 7 months, and you can see here he was extremely fat, 33 kilos, 34 kilos at 2 years and a half, with a BMI of 38. Sorry, I lost the, yeah, thank you. And you can see the increase of the weight was really amazing. This child was the first child of 2 healthy, normal weight Turkish parents with no consanguinity. He was born at 40 weeks of gestation with normal birth weight. And he, as I said, had a rapid weight gain. Go ahead, next please. Weight gain starting in the postnatal period. He would cry inconsolably if refused the meals. Next please. As a toddler, he demonstrated constant food seeking, and the measurement of serum leptin, which is indicated in these very cases, showed that the leptin was very high. So because the leptin was very high, the leptin receptor mutation was suspected, but mutations and analysis of the receptor was unremarkable. Next please. The leptin gene was sequenced despite the fact that it was very high, and then similar to the growth hormone receptor deficiency that we listened by Professor Laron, the leptin gene was sequenced, and the novel homozygous transversion mutation in exon 3 revealed a form of leptin was not working on the receptor, giving a similar, next please, a similar picture of the leptin receptor deficiency. And you can see here that the mutation, this particular mutation of the leptin protein showed that the leptin couldn't bind to the receptor, and therefore giving this kind of lack of leptin action. Next, please. Interestingly, this was one of the first child treated with metrelleptin, synthetic leptin, and you can see here on your right-hand side an amazing reduction of the weight, including particularly the body fat mass with a reduction. You can see the pictures, the clinical results were really very important, very relevant for the child. Next, please. So we here describe this case in which leptin was produced and the leptin was not able to act on the receptor. Next, please. And you can see here how the leptin works on the receptor. Next, please. And you can see here that if the leptin works on the hypothalamic leptin receptor, there is a controlled food intake and a reduction of the adipocyte volume body fat mass. And you can have either a reduction of the effect of the leptin on the receptor or a defect in the receptor, which brings to uncontrolled food intake and adipocyte volume body mass, fat mass increased dramatically. Next, please. There are several known mutations in the human leptin gene nowadays, which gives proteins which are unable to act on the receptor, and therefore these children may benefit from methyl-leptin administration. Next, please. And we move to the second case, which was a boy that we saw in our outpatient clinic, and he was a 3-year-old boy, which was referred because of hypocortisolism and early onset severe obesity. We saw these children together with other colleagues from Naples. This child had a family history without obesity. He was born from a normal pregnancy from an apparently non-consanguineous family, and the parents reported that this child had hyperphagia from the first weeks of life, and he was searching food continuously. Next, please. At birth, the child had respiratory distress. He was intubated at birth and had hypoglycemia again. At 9 months of age, he was diagnosed with the ACTH deficiency based on the very low cortisol and low ACTH levels, and the MRI showed the normal pituitary gland. Next, please. The treatment with glucocorticoid was started with hydrocortisone at a dose of 10 milligrams for square meter per day, divided into 3 daily doses, and the child needed also LT4 treatment at 18 months of age. This is the child with the severe obesity phenotype developed in the first year of life. I will show you his growth chart, and rapidly worsening during the second and the third year of life. You can see here the growth chart, increasingly obese. The weight was 30 kilos at 33 months of age. And you can see, next please, sorry. And this is the growth chart, as you can see. And next, please. So this child had isolated ACTH deficiency, hyperphagia, and severe early onset obesity. Next, please. His sister was completely normal, and the genomic analysis showed a direct, next please, the direct sequencing of the coding sequence of the POMC gene. Next, please. With the homozygous single substitution determining a stop codon in GLN68X. So this was a normal, the generation of a premature stop codon determined an aberrant protein composed of the first 67 amino acids and prevents the production of any normal POMC-derived peptides. Next, please. And both parents were heterozygous for the mutation, while the substitution was absent in the unaffected sister, which had a normal weight. You could be interested to the patient hair color, and they were not either red or blonde. You can see here they had brown to black hair, and we can discuss why in some mutation you can have the red hair is not present. So next, please. So we are now discussing then another form, which you can see here, which is the POMC defect, which inevitably brings to a reduction of alpha MSH and beta MSH. And this is the reason why some of the patients, majority of the patients, have red hair. They are obviously unable to produce ACTH, and therefore they get very early obesity in life. You may be aware, next please, you may be aware that the first patient with the POMC mutation was described by Heiko Krude more than 20 years ago. And you can see here again, this child had red hair with a very, very high weight. You can see yourself for 7 years, the weight was very high, 52 kilos. And this was a mutation, again, in the POMC gene, leading to a lack of POMC and therefore a lack of production of ACTH and red hair. Next, please. The POMC mutation and of clinical features with homozygous null mutation have been published, and these features include an early onset of childhood obesity with massive hyperphagia, which is the case of majority of these children. In particular, the POMC defects have the ACTH deficiency, which sometimes, like in this case, lead to hypoglycemia. Normally, they have red hair or skin pigmentation problems because of the reduction of MSH. These are reported in the majority of patients, but was not the case in the patients that I presented to you. Next, please. The good news for these particular patients is that treatment is possible. We saw how metreleptin may be an efficient and efficacy treatment for children with the leptin mutation. And here you can see that setmelanotide is available. Setmelanotide is an agonist of the MC4R, and you can easily understand that if we can use setmelanotide in these particular forms, we can overcome a majority of the defects upstream of the receptor, namely including the leptin receptor alteration, including the POMC mutation and the MC4R mutation. So this is, and other possibility is also the Ostrom syndrome and other syndrome which may potentially benefit from setmelanotide. So this means that if we are able to detect these patients early in the course of their severe obesity, we could potentially treat them, and there is evidence for that. This is one of the papers published with the use of setmelanotide in 2 patients. You can see here published in New England Journal of Medicine, and you can see how the reduction of the weight in both patients and the reduction of the hunger score was really very important, very relevant after a few weeks, after 3 months of treatment. So which again gives an idea how is important to detect these patients early in the course of their severe obesity. So in conclusion, briefly, next please. Can I have my next slide, please? First of all, this is a fascinating group of patients because there are other genes involved in severe obesity. For instance, there is interest very much in this SIM1 gene and the KSR2 gene, which are now described and can be treated with, for instance, KSR2 2 may be treated with metformin, may benefit from metformin. So it's very important, again, to have a correct diagnosis. So I propose, next please, to screen for monogenic obesity, as I said, when you have a child, either a very small child, a toddler with a very high BMI and extreme hyperphagia, but also consider that some of these cases may be eligible for screening, for genetic screening, when they have a very high BMI, more than 30 kilogram per square meter, also after the toddler age. So if you have a particularly when the parents are consanguineous, we have to think to these forms of these conditions, because majority of them are recessive. The parents may be heterozygous. So in summary, next please. And can you click please? Energy homeostasis of the body, next please, is biologically closely regulated via endocrine feedback loops. The body weight, as we know, is regulated by individual genetic background, and obviously can be influenced by the living conditions. It is important not to stigmatize, we know that. So we have to be aware that some forms of obesity in children, next please, may be related to monogenetic forms of obesity. They are rare, and therefore a general screening for these particular conditions is not indicated. We have to worry about these children when we have extreme weight gain, early in infancy, and particularly when the parents are consanguineous. More specific symptoms may be missing puberty because of gonadotropin deficiency in the hypogonadotropin hypogonadism, absence of hypertension despite of severe obesity because of lack of cortisol, red hair because of lack of MSH, glucocorticoid deficiency, and neonatal diarrhea. So with this, I think, next please, I can show you a case of obesity coming from Germany, from Europe, 35,000 years ago. This was described in a cave in Germany. This lady, next please, which is called the Venus of Hohlefels, had extreme obesity, big fatty boobs, was short and very, very high weight, and she is now 35,000 years old. Thank you. Thank you very much.
Thank you, Professor Chiarelli. I mean, it was amazing giving some insights into the newer monogenic obesity and some clinical, definitely clinical clues to when to suspect and when to. That was the most important slide, I think, as a clinical pediatric endocrinologist. I will give it over to Dr. Thomas Paul for going ahead with the program.
Yeah.
Thank you.
Thank you very much. We'll continue with the last talk of this. Of course, is one of the very important aspect with relation to current scenario across the globe, like endocrine disruptors. It's my privilege to introduce Professor Stefano Cianferrani, full professor of pediatrics in Tor Vergata University, Rome. He's chief of diabetology and growth disorders unit at Bambino Children's Hospital, Rome, Italy. Visiting professor at Department of Women's and Children's Health, Karolinska Institute, Sweden. Editor-in-Chief of Hormone Research in Pediatrics. Over to you, Professor Cianferrani.
Thank you. Let me share the screen. Can you see the presentation?
Yes, we can see.
Yes, very good. Okay. So once again, I'd like to thank for this kind invitation And this second talk is about the what we know or what we presume to know about the impact of endocrine disruptors on the endocrine system in childhood. First of all, I think it's important to start from the definition of endocrine disruptor. This is the definition actually defined by WHO in 2013. And the definition is that an endocrine disruptor is an exogenous substance or a mixture that alters functions of the endocrine system and causes adverse health effects in an intact organism or its progeny or subpopulations. And as you can see on the right panel, on the right figure, there are so many different potential endocrine disruptors, which are, we are talking about that a little bit later. This is the overview of this talk, background, evidence in wildlife, evidence in humans. Three of them, I would say the most common in the environment, PBDE, bisphenol A, and phthalates. Some personal preliminary data from my group and conclusions. Background. This is just a partial list of the families of endocrine disruptors to which we are exposed, all of us, each day. You see how many of them, from pesticides to flame retardants, plastics, herbicides, industrial bioproducts, plasticizers, fungicides, heavy metals, pharmaceuticals, of course, personal care products. Each of these family actually includes many, many different compounds, many different substances. And if we want to summarize the main action of these endocrine disruptors on the endocrine system, we can say that there are four main actions: androgenic activity, anti-androgenic activity, estrogenic activity, and anti-estrogenic activity. Once again, each of us, each family is exposed to endocrine disruptors through food, soil, water, dust, and air. And particularly is important is the exposure of the fetus, because actually the mother during pregnancy can have this contamination through the skin, through the air, through the mouth. And some of these compounds, or some of these endocrine disruptors actually are lipophilic. So this means that they can accumulate in some tissues, especially in the adipose tissue, but also in other tissue, because, for example, the mother can transfer the endocrine disruptors to the babies through the breast milk. And she can also transmit the compounds like endocrine disruptors to the fetus through placenta during fetal life. Just to stress what I've just said, this is the compounds discovered in pregnant women in the NANES study in the United States. You see that in these 54 pregnant women, each bar corresponds to one single woman. You see the different percentage of different compounds, or different endocrine disruptors, including cotinine, which is a metabolite of nicotine, PBD, metals, polyaromatic hydrocarbons, pesticides in blue, and phthalates in gray. So if we look at the circulating levels of endocrine disruptors in pregnant women, we can find this kind of pattern. Of course, the impact is strictly dependent on the time windows in which the exposure happens during fetal life. And of course, the early prenatal and mid-late prenatal, some systems are much vulnerable to the effect of the endocrine disruptors, including central nervous system, ear, kidneys, immune system, lungs. And what is much more known at the moment is the impact on the reproductive system when the fetus is exposed after the seventh week of gestation. Even the manifestation, clinical manifestation of the consequence of the exposure can depend on the age of the baby or the child. You see that learning differences and asthma, as well as testicular dysgenesis syndrome, they can occur very early in life, in the first 2 or 3 years of life. Then we have the altered pubertal timing, obesity, infertility, the risk of developing premature menopause in females, breast cancer, the high risk of atherosclerosis, cardiovascular disease in adulthood, as well as prostate cancer, Alzheimer, Parkinson. All these conditions have been related in one way or another one to the developmental exposure during fetal life or early postnatal life, which means the first weeks after birth, to the different endocrine disruptors. They can act at different levels of the endocrine system. For example, they can directly alter the production of specific hormones. You see here the phthalates, for example, can inhibit the production of testosterone. They can also affect the bioavailability and the affecting the transport of the different hormones in the blood. They can affect the binding to the specific receptor in the cell surface, but at the same time, they can also affect the post-receptor signaling, which is summarized in this slide. So overall, the endocrine disruptors can interfere with the hormone production, the bioavailability, the binding to the receptor, and the post-receptor signaling. One last action is their ability to induce epigenetic change. This ability is quite important because in this case, the effect of endocrine disruptors on the organism can be transmitted into the next generation. So some key concerns: the speed with which the increases in disease incidence have occurred in recent decades rules out genetic factors as the sole plausible explanation. ADC, the endocrine disruptors, are everywhere. Environmental and other non-genetic factors, including nutrition, age of mother, viral diseases, chemical exposure, should be taken into account for explaining so rapid increase of specific diseases. Evidence in wildlife. I would say that most of the evidence we have in terms of relating the exposure to specific endocrine disruptors and the final effect on the organisms, they come from the wildlife, from animal models. These are just a few examples of them. The specific observation that, like many other mammals affected by endocrine disruptors, otters from the lower Columbia River are infertile because the male penises are too small to mate. Alligators affected by pesticides cannot reproduce. Male fish develop female hormones. And in birds, the exposure to specific endocrine disruptors induce the thinness of eggshells, so chicks cannot survive. This is another example. It is a fish contaminated in a specific lake. You see in the penis length in the control lake, the penis length of the alligators in the contaminated lake. And this is the exposure, the effect of the exposure to the testis. You see in the testis, there are also oocytes, so inducing the condition of ovotestis. This was found in a contaminated UK lake in fishes. Another example in zebrafish. Zebrafish exposed to specific chemicals from hatch to 60 days after birth, from after hatch, when the sexual differentiation is finished. You see that the exposure to estradiol induce increased female-male ratio quite significantly. The exposure to a potent androgen on the other side induce a male sex in this zebrafish, and the exposure to a potent inhibitor of aromatase induce a quite large proportion of undifferentiated intersex phenotype in these zebrafish. So once again, suggesting that the early exposure can change the sex outcome, at least in the animal field. I would say that all species exposed to endocrine disruptors have been found to change their sex in some way. You see the sex reversal, intersex gonads have been found in almost all species, and also in mammalia, the abnormal development of genitalia and gonads, as well as disruption of steroidogenesis, cryptorchidism, hypospadias, and semen quality alteration have been described in mammalia as well. But what about in humans? First of all, I have to say that what we know comes from association analysis. So it's very difficult in humans, it's quite tricky to demonstrate a cause-effect relationship. So what we know comes from case control study or from a large epidemiological investigation showing association is so a potential relationship between a specific exposure and a specific effect in terms of obesity or pubertal timing or thyroid disease. Certainly the most common recognized effect is on the reproduction system. You see that in this case, this is a figure reporting the prevalence of hypospadias among Danish boys. You see a steadily increase in hypospadia in the last decades. The same is true for the decline in human sperm count of spermatocytes. So there is a progressive decrease of sperm count, as well as a progressive disease of fertility rate. This is true not only for North European countries, but everywhere, including Japan, of course, in the United States. At the same time, these are data coming from, especially from Denmark. You see the continuous increasing of incidence of testicular cancer, especially you see in Denmark, in Norway, Israel, Sweden, and Finland. So there is, I would say, a pattern of incidence of specific alterations and disease, which cannot be explained by genetics, but it, of course, should come from a specific exposure to environmental cues, including, of course, infections, but of course, endocrine disruptors, so chemicals, specific chemicals. And actually, the best known condition which has been associated with specific exposure, in this case to pesticides, is the testis dysgenesis syndrome. This condition includes the risk of developing testicular cancer, the decline in sperm count, the risk of hypospadia, and the development of cryptorchidism. The pathogenesis of testis dysgenesis syndrome is summarized in this slide. And just to draw your attention on the effect of environmental factors, so chemicals, including endocrine disruptors, on testicular dysgenesis, I remind you that the testis development starts at the 7th week of gestation and completes actually at the end of gestation. And this exposure causes an alteration of Sertoli cell function, inducing impaired germ cell differentiation, which ultimately lead to reduced semen quality and exposing the testis to develop testicular cancer like carcinoma in situ. At the same time, there's also a decreased Leydig cell function, which leads to androgen insufficiency, which is the cause of hypospadia and testicular maldescendants, so cryptorchidism. Recently, last month, in the Lancet Diabetes Endocrinology, there is a very nice systematic review of what we know about the exposure and the possible effects on the organism. And you see here that probably one of the best known effect is on intellectual disability, especially the early exposure to pesticides, the relation with autism, as well as childhood obesity. Once again, we have a cryptorchidism. You see that the strength of human evidence, I have to say that the strength of evidence in animals is quite robust, but the strength of human evidence, apart from the probably the exposure to PBDAs and pesticides, is low to moderate in all cases. But the probability of causation, in spite of the low evidence, the probability, looking at what we know about the effect in animals, and what we know about the potential, the chemical effect of the endocrine disruptors in the different tissues, the probability of causation is quite high in almost all cases. So what about PBD, BPA, and phthalates? PBD are persistent organic pollutants. They are very diffuse in the environment. They are flame retardants, which bioaccumulate in human body fat, and they can be found in plastics, textiles, foams, electronic devices, but they can also be present in food due to the persistency, which is caused by the lipophilicity they have. This is the contamination of tuna, skipjack tuna from East Asia, North Pacific, India, and South Atlantic Oceans. So you see that fishes, in this case tuna, in their muscle have, in some cases, very high concentrations of PBDE. Bisphenol A is another industrial chemical which is very widely used as an additive for the manufacture of polycarbonate. So once again, in plastics. And this compound has a structure very similar to estrogens. And the actions so far hypothesized for the exposure to BPA include an effect on immune response, on adiposity, on brain sexual differentiation, on behavior, on cardiovascular disease, on glucose homeostasis, on risk of diabetes, brain development, reproductive effects in male and females, and the risk of developing cancer. Finally, phthalates. Phthalates, once another diffuse contaminant in the environment, and you see that many factories, many industrial products contain phthalates, including personal care products, cars, children's toys, construction tool, medical devices, and as well as food and drug packaging. And the phthalates have been related to the earlier pubertal onset, including telarchy. They have related to effect folliculogenesis, steroidogenesis. They also have been related to a decrease in the production of testosterone in males, and also related to the risk of obesity in childhood. Personal data. We have studied actually the PBD, and the question was whether the girls with a precocious puberty or idiopathic premature telarchy had a different PBD concentration in comparison with healthy children. So we studied these three groups. And what we found was that actually the concentration of PBDE was much higher in the girls with idiopathic premature telarchy. They had significantly increased levels of PBDs in comparison with control, and not significantly more than precocious puberty girls. But if we look at the distribution in quartiles, you see that actually, once again, girls with a premature telarchy had, most of them, actually, they had the excretion of PBDs in the high quartile of concentration in comparison with the girls with precocious puberty and healthy control girls. Then we have studied, we have just finished a study, not completely published yet, with another study funded by European Commission. The three main objectives of this study were, first of all, a biomonitoring of the exposure to phthalates and BPA in Italy. The second was a case control study in idiopathic precocious puberty and premature telarchy and obesity. The final one was an animal model, a rodent model of toxicity. First of all, it's interesting that when we studied all the children, the case control study, so it means control as well as obese children, premature telarchy girls, and girls with precocious puberty, BPA as well as phthalates in the urine, they were measurable in all individuals. So all individuals studied in this case control, but I can tell you that also the biomonitoring all over the country, north, center, south of Italy, in more than 4,000 children, actually this yielded the same results. So no one single child or even mother had unmeasurable BPA or phthalate in the urine. So this means that all of us, at least in Italy, are exposed daily, because it is not persistent, but it's a daily excretion of phthalates and bisphenol A. We are all exposed daily to these contaminants. This is actually the biomonitoring data, in particular the phthalate data. You see, another interesting thing is that the exposure to phthalates is higher in younger children than in older children. This is true for both males and females. Sorry. And what about the exposure in girls with precocious puberty, premature telarchy, and healthy control girls? We couldn't find any significant difference in the BPA and phthalate. These are three different metabolites of phthalates in these three different groups. Of course, you see that there are some outliers, but the final effect is not significant. Another way through which actually the exposure to these contaminants can induce alteration of pubertal timing is the induction of obesity. Here we have the increased incidence of obesity and the progressive reduction of the age of pubertal onset. It's a very nice figure in both USA and Europe. And this effect of chemicals on the development of obesity or adiposity can affect different phases of adipose tissue differentiation. First of all, they can increase the adipogenic commitment, so they change from mesenchymal stem cells to pre-adipocytes. Then they can increase the adipocyte differentiation from pre-adipocytes to normal adipocytes. Then also can increase the proliferation of adipocytes, so inducing hyperplastic adipocytes in terms of increase of adipose tissue. And finally, they can also increase the lipid uptake, leading to hypertrophic adipocytes. So I would say that all the phases of adipocyte differentiation can be affected by the exposure to specific endocrine disruptors. And this is what I've just said, saying that once again, the early life exposure is that much more related to the risk of obesity later on in childhood and in adulthood, as well as to the risk of developing even steatosis and NAFLD, leading also to non-alcoholic steatohepatitis in adulthood. This is the another NANES. These are other data from NANES study showing a relationship between the exposure to specific contaminants like DCP and bisphenol A and phthalates to the risk of obesity and BMI. And what we have found in our study, in our case control study in obese children, was that actually there was no significant difference between obese boys and normal weight boys. But what we found in obese girls was that obese girls had significant higher excretion of BPA in comparison with normal weight females. Not yet published study. So finally, the conclusion is that although systematic evaluation is needed of the probability and strength of the exposure outcome relations reported so far, the growing evidence supports urgent action to reduce the exposure to these chemicals, especially in early life. In the past decades, regulatory efforts and policies to decrease the human exposure have been insufficient to minimize the exposure to the vast majority of chemicals. It is confirmed by our biomonitoring study in our country. And finally, given the overwhelming scientific evidence of chemicals as a human health hazard and the economic cost of inaction, it is clear that improved regulations are needed. Finally, there are some problems in studying this issue because we have to consider that we are exposed not to one single contaminant, but a mixture of them. Then there is no dose effect in terms of a final effect in tissues and organisms. So even low doses can induce a potent effect. Then there are also transient adverse action at critical time windows of development. So that's another point to be taken into account. Then most of the action probably happen during embryogenesis or fetal life. Some of these chemicals may not be longer detectable at birth, so it's difficult to assess their real impact and the real, I would say, knowledge of the substance, the structure of the substance, which has caused a specific effect, for example, on hypospadia or cryptorchidism. And finally, there is a problem with the analysis because the analysis usually the tandem mass spectrometry is used, and an expert technician and physician should be trained for a careful analysis of these chemicals. And finally, I would like to, of course, acknowledge the collaboration of many colleagues from different institutions in Italy for the biomonitoring a case control study. Thank you for your attention.
Thank you very much, Professor, for in-depth covering. It was really very useful talk, and it was so informative, starting from impact of this disruptors from in utero at various stages of life. It was really very useful. Now, along with Dr. Sriram, we will just go through some aspect of discussion with all the speakers, and we have two panelists also there. Dr. Sriram, can you unmute? We can do, because the want of time, we can take.
I think Dr. Om will.
Yes, sir. I'll just introduce the panelists who are going to join Dr. Sriram and Dr. Thomas Paul in the panel discussion. We are privileged to have Dr. Professor Sanjay Kumar Barada, who is a DM in endocrinology. He's a professor of endocrinology at PGI Chandigarh. He's also the founder and the current secretary of Punjab and Chandigarh chapter of RSSDI. He's an excellent orator, I think an excellent speaker with the area of specialty of bone and mineral disorders. He's a regular speaker at various conferences. He has, of course, more than 250 publications and has received various prestigious awards like the MN Sen Oration Award by the ICMR, the prestigious P.N. Shah Oration by Endocrine Society of India, and Professor Survi Singh Visiting Professorship by the Association of Physicians of India in 2011. He is the founder of Aditi, which is basically a social support group for young diabetics, and I think that's a great social work that he does in his spare time. We also have the great privilege of having Dr. Professor M.S. Sheshadri, sir. He is MBBS, MD, PhD, and FRCP. He has more than 100 publications, and he has taken more than 200 lectures at various institutes. He is one of the founding fathers of the endocrinology department at CMC Vellore. He is, of course, a mentor to a large number of endocrinologists in the country. He has guided over more than 50 theses in the topics of internal medicine, pediatrics, and endocrinology, and also basic sciences. And he served as a member of the Human Resources Division of the Medical Division of the Council of Scientific and Industrial Research. So we are privileged to have these panelists and also the chairpersons who would be joining us in the panel. Sir, Dr. Thomas Paul, sir, can we take the discussion forward?
Yeah. So, this actually, for the want of time, we'll keep the discussion brief. And basically, I want to ask one question to Dr. Sanjay. You heard about the fractures approach to clinical approach to fracture. And what is your experience? What is your, you want to talk about how do you approach and where do you use, with relation to the pivotal status, BMD and bone turnover. So what is your take on that? Dr. Sanjay Badeda?
Yeah, thank you, Dr. Thomas. And very nice talk by Dr. Linda DiMiglio. And what in our clinical practice, the most common cause of fracture in adolescent age group is the osteogenesis imperfecta, basically in childhood. And probably we are seeing the second most common cause in our setting is the rickets, and especially the resistant rickets is the second most common cause in our setting. And then maybe osteopetrosis. So there is a two spectrum of fragility fracture in the childhood. One is the low bone mass and another is the associated increased bone mass. And OI is most common one. And then we use the jolineurin as a treatment for the osteogenesis imperfecta. And that is interesting that many people use high doses, but the recommended dose is 0.01 milligram per kg body weight. That is for 6 monthly. And as some of the question asked that how frequent to give the jolineurin injections, that is once in 6 months, and that should be continued throughout the at least they achieve the peak bone mass or they achieve the puberty, because they say that if you stop in between the jolineurin, that will cause a weak bone formation, and then once you give jolineurin again, this good bone formation. So they recommend that it should be a continuous process, 6 monthly. Of course, you have to monitor the bone markers, and though it is a difficult situation because the bone markers in adolescent groups keep growing because of their age and all these things, so that we need a strong data to support that. But what in our clinical practice we are using is the alkaline phosphatase as a marker, and comparing the alkaline phosphatase various stages with the treatment. So alkaline phosphate is coming down towards the lower limit, then we stop, and we may assess after 3 months and 6 months to give the repeat injection of the jolineurin. So that is about the, and osteogenesis imperfecta, again the most common cause, and the treatment after the availability of jolineurin is much better. And some of the patient, because of the high doses, they are developing the osteopetrosis. So we should be careful about that. And though there is not classically in adult life, they are presenting with SSBT kind of thing, but it is important to take care, keep this thing in mind. So thank you, Dr. Thomas.
So one question to Professor DiMiglio. Do you take into account the pivotal status while interpreting BMD during adolescent years?
So yeah, we have to look at puberty, and sometimes we will adjust the bone density for the bone age. Although if you do that in a child that is has a delayed bone age, you'll actually overestimate the bone density. So Babette Zimmel has looked at that from the bone mineral density in childhood study. Because that child has had more time to grow, the bone density is higher than you would expect if they that you would expect for the bone age. So you can't always correct for bone age. We do that a lot. But definitely you want to think about where they are in puberty, because puberty is the time when you would increase your bone mass. And if you're prepubertal at an age when other kids are pubertal, their bone mass will lag just simply because of puberty. And we've seen, I'm sure others who have treated these kids have seen kids that catch up with delayed puberty over time.
Thank you, Dr. Sriram. Dr. Sriram, you can ask questions. You can involve the panelists.
I profusely thank Professor Sheshadri sir to join, as well as Dr. Badada sir. And we also thank the international speakers, Dr. Dimiglio and Professor Cherali, for answering many of the questions in the chat itself. That was really nice of them, and on the behalf of the organizers, I thank them. And few questions, I think a couple of them to Dr. Khalid Hussain is pending. And before that, we have invited senior endocrinologist, Professor Sheshadri, quite late. Sir, your comment on the speakers, the topics here, and any Indian perspective to the talks given by the international speakers, you can, from your extensive experience, you can please add, sir.
I think in terms of numbers, fractures in children, one of the most important things in India would be corticosteroid use. I think this is something that we need to be aware of. We do have a large number of children with nephrotic syndrome who are given corticosteroid. There are children with asthma who are given inhaled steroids and short courses of oral steroids. And when they are on medication, attempts at skeletal protection are probably very important. In fact, one of the pediatric postgraduates did a thesis with me on just simple vitamin D supplementation during treatment of nephrotic syndrome, which seemed to have a very important effect on bone mineral content. Another comment I would invite from Professor Linda is whether bone mineral content should be used rather than bone mineral density in assessing a child for bone strength. There are people who feel that bone mineral content might be an important variable to look at because it gives you an idea.
Yeah,
response.
go ahead. Sorry, yeah, I was going to say, I think bone mineral content is very important to look at over time, as well as bone density, because as you know, since bone density is grams per centimeter squared, it's going to be affected by bone size a lot. And so often, I think the recommendations are that we use bone mineral content only in young kids, the very young infants, before there is like normative data around bone density, but certainly it's important to look at that clinically. And when I do my reporting of my DEXAs for my kids clinically, I watch that as well. I don't have a way, and the software that we use does not generate Z-scores for that. So it's a little harder to track, but I will look at the changes in bone mineral content, particularly when the density is not moving in the way I want. And that forces me to then look at bone area. But I think I think more normative data that's easily available around BMC would be very helpful.
Can I also invite a comment from you about what you would do to a child with nephrotic syndrome getting corticosteroids to protect the skeleton?
Yeah, so in kids that it depends on how long the steroid use is anticipated and whether or not they're fracturing. So I don't routinely see those kids unless somebody refers them to me for fracture. But in children that are going to be on steroids that have low bone mass or fractured, I have used bisphosphonates for periods of time. I don't think I've done it in the context of nephrotic syndrome per se, but I've done it more in the kids who have had cancers where they've gotten a fair amount of steroid as part of their therapy, and then they've had low bone mass and fracture. But those kids are sometimes screened by their the oncologists, the cystic fibrosis group, and the neurologists are the three groups that are doing the most screening for low bone mass. And those kids, if they're referred, if for the kids like that are referred on steroids, I have put them on bisphosphonate for a period of time until the steroid use is done.
This is my question. One question I wanted to ask Dr. Seshadri. What is Professor Seshadri is my teacher. I take the liberty. What is your comments on endocrine disruptors in an Indian setting, especially in children?
I think it's a grossly neglected area in India. In fact, when I went for an interview to the SGPGA staff selection, one youngster wanted to take it up as his challenge as an endocrinologist, but I have not seen any output in terms of research publications. Considering the very widespread use of plastics, chemicals, phthalates in India, I would be very surprised if we do not have a very large number of individuals affected and going unrecognized. I think it's a fertile area for research, and perhaps CMC should take it up.
In that
Over
note,
to Dr. Sriram.
in that note, may I add one more comment? A couple of our endocrinologists from Tamil Nadu, which is south of India, they have done work on pesticides in diabetes, type 2 diabetes, and shown, and we have also done a small work, but that's very, very minor work by somebody. But these are all things happening. But one question to Professor Stefano, sir, is, I have been listening to every year in our SCCon, everywhere there is talk on this endocrine disruptors, but ultimately, as a clinician, what can I do about it? Because it's there everywhere. You showed in your slide that even the water, the food, the fish, everything has something which is probably detrimental to one system or the other. I think that should be a huge policy, public health decision taken at governmental level, drastic change and going to our primitive lifestyle. I don't know what is the answer, but at the end of the day, but we understand the pathophysiology or animal studies that it is harmful in some way. Any thoughts on that, sir? I mean, I look pessimistic, but this is just an open question.
Yeah, you're right. I mean, in this study, actually, we also supply some questionnaires about the food habits of the different families in the biomonitoring study. It's interesting because actually we found a relationship between the use of specific packages of food, for example, for the microwave oven, and the increase of excretion specifically of phthalates. So I think from a clinician point of view, I would say from a pediatric point of view, family pediatricians should try to suggest the families, the mothers and fathers, to reduce the use of plastics in general and reduce the use of packaging, including packaging which contains, of course, phthalates, which are the vast majority of packaging in our junk food, as well as food with a rapid cooking in the microwave oven. So I think there are coming out some indications from this kind of epidemiological studies, which relate quite closely the use of specific foods, especially industrial foods, and the risk of, at least, of contamination. Then, the risk of disease is another story. We have to confirm that. But I think if we reduce the contamination, so the excretion of the accumulation of specific chemicals in our body, that would be a very good first step. I would just say one more thing about the question about the Indian situation. I think that each country, as the United States is doing with the analysis study, the Denmark, the North European countries, and then we have just finished the first biomonitoring study in Italy. It's very important to perform this kind of studies because they give us the background, I would say something like the reference standards for the contamination of specific chemicals in our country. So you can compare what you find, for example, in a specific case control study or cohort of patients with cancer or with Alzheimer or with obesity, with a background, if you know the background in your country. So you can, pick up some peaks of contamination and then relate them with a specific disease. I think that would be a very interesting, important study to perform in any country.
I think the more important thing to do immediately is some of the attempts being done by the government, like considerably cutting down plastic use, single-use plastics, just try to get rid of them and use organic fertilizers rather than chemical fertilizers. These are public health measures initiated at the government level, but they will take time for it to show up as end results. The only pity is, I think, when you see somebody with a low sperm count or infertility, you fail to recognize that this may have been because of exposure to an endocrine disruptor. And so it will just go unrecognized. And I think the evidence that was shown by Dr. Stefano that with every successive decade, there is a progressive decrease in sperm count. I think that's very impressive data. And the only thing that they can correlate it with is increasing use of disruptors. Right?
So, Dr.
So there was a question for Dr. Khalid. There were a couple of questions on exercise-induced hypoglycemia. I think that area was resonated well with the audience. So there are two questions on that. One is, what is the mode of inheritance of an exercise-induced hypoglycemia? And the second part of the question is, how do you treat or correct exercise-induced hypoglycemia?
The mode of inheritance is dominant, autosomal dominant. Sometimes it may be just spontaneous, but in the family history, you saw the dominant pattern. In terms of treatment, it should respond to diazoxide because the channel is intact. But occasionally, the patients may need to reduce the exercise and maybe eat something just before the exercise. But the vast majority to respond to diazoxide, good doses of diazoxide.
And so there was a practical question for a lot of endocrinologists who are listening to this talk. How do you use cornstarch? We often prescribe starch and cornstarch for preventing hypoglycemia in these children as a sort of a home remedy for a lot of these children with recurrent hypoglycemia. So what preparation? How do you prepare it? What's your exact kind of advice which you give to parents of these children who?
We don't use it before 6 months of age because it just doesn't work. But afterwards, you can just dissolve it in water. It's cornstarch. And we either can give it as a continuous feed overnight, depending on the severity of the hypoglycemia, via gastrostomy, or you can give it as boluses. But again, some patients they get a lot of tummy pain, vomiting, gastrointestinal problems. So again, it's got to be tailored to a particular patient. Some patients do reasonably well, and some patients show no response at all.
Okay, thank you. Sir,
there were a couple of questions from, some comment from Dr. Badada, sir.
Yeah.
He was raising his.
There is two speakers are there, Dr. Stefano and Dr. Francisco. So there is something corollary between like type 1 diabetes prevalence is also increasing and the endocrine disruptors are increasing almost all endocrine disorders. Is there any connection between rising prevalence of type 1 diabetes and these endocrine disruptors?
Well, so far there is no strong evidence about this. Actually, there are, I would say, 4 or 5 studies, with very conflicting results. The strong correlation has been found between the chemicals exposure and type 2 diabetes, but not with the type 1 diabetes, at least so far.
Just as a short comment on that, there are evidences on the role of endocrine disruptors on, as Stefano said, on insulin resistance, on the receptor of insulin. So in theory, this could enhance the risk for type 2 diabetes, as Stefano said. And possibly, if we believe at the accelerator hypothesis, this could in turn increase the expression of some autoantigens in the beta cells. But as Stefano said, there is no robust evidence to say that endocrine disruptor may increase the risk of type 1 diabetes in children, based on my knowledge.
There was a comment, I think, that came from Karolinska Institute about type 1 diabetes and a very sterile environment in which children are brought up. Do you have any comments about that? I find that interesting. Children brought up in a very sterile, microbiologically sterile kind of environment tend to have a higher chance of developing type 1 diabetes. Is that observed in other places as well?
I can tell you an anecdote, a story about the Bedouin children living in the Negev desert in Jordan and then moving to Amman, to the city. And they described, the Jordanian people described that the prevalence of type 1 diabetes in Bedouin children was much higher in those living in Amman compared to those living in the desert. Which means probably that you are referring to the hygiene hypothesis, which have never been confirmed. So far, again, we do not have strong evidence to make our children living separated from other children in order not to develop type 1 diabetes, to be honest. May I take the opportunity that I have the microphone, because I got a question on the leptin gene. So just to clarify that there have been described several defects in the leptin genes which make altered leptin protein, which cannot bind to the receptor, which gives actually something like a clinical picture similar to the leptin receptor defect. In other words, this leptin either is produced and secreted but is inactive, or is substantially produced and secreted but again is inactive on the receptor. And therefore, this is the reason why in some of the metraleptin may work, because it binds to the receptor and therefore substitute the biological effect of leptin.
Dr. Sanjay sir, just to sort of digress from a topic a little, you have a lot of data on celiac disease and growth retardation. Is there any data on celiac disease and bone involvement in your cohort of children? And what's the impact on growth overall? And can you give some insights on that?
Yeah. So I think, as usual in the story, that celiac disease does not exist in India. So it was maybe 2 decades ago, that was a correct statement that celiac disease does not exist in India. And very few case reports were there. And if I correctly remember, that first case report from PGI Chandigarh by head of department pediatrician, that patient presented with diarrhea, and after some time they are able to thought not responding to the treatment, so suspected celiac disease and put on the gluten-free diet and improved. So similar situation when I think Dr. Shriram was there in our institute at that time. So we did 3 consecutive studies every decade. So almost first 5 years, next 5 years, and next 10 years. So what we did, we looked all the data of the short stature from our endocrine files, what we have in our institute. So initially the most common cause of short stature was actually malnutrition. And that's just 1 or 2 patients of celiac disease. In the next series, when the IgA TTG antibody was available, all of a sudden there is sudden rise in the prevalence of cause of short stature celiac disease. And finally, last 5 years, the celiac disease is the most common cause of short stature in North India. At least those are the few states those are reporting or coming to the PGI Chandigarh. That was in our published series, 18%. Even it is more than hypothyroidism, any other thing, the most common cause of short stature was celiac disease. And when we compare the data, initially the most common cause is malnutrition actually. All malnutrition is because of the celiac disease. So almost is replaced malnutrition to the celiac disease. So there is CSA change in the etiology of short stature, and that is response is very good. And other important problem with celiac disease or in type 1 diabetes is very common. In our own series, 11% of patients of type 1 diabetes are having the celiac disease. 11% of type 1 diabetes are suffering from the celiac disease. Interestingly, most of the patients were found on screening. They were not that symptomatic, but on screening we found that celiac disease. And now coming to your question, that bone-related problem, yes, we have few patients that are presented with the rickets, but even older people, they are presenting osteomalacia, and they are misdiagnosed the osteoporosis, because did the DEXA scan, DEXA cannot differentiate osteomalacia and osteoporosis. That just give the BMD. And they were receiving the treatment contrary to the gluten-free diet. They were receiving the bisphosphonates or some outside gluten, teriparatide and all sort of things. So we have one good series of the metabolic bone disease, a important cause of celiac disease. And some of our students, those are working in Hyderabad, if I remember, Dr. Santosh, and he says that he has seen few patients of celiac disease having the osteoporosis underlying cause. So that is, I think it is quite widespread, maybe much more common in North India as compared to the South India.
Very interesting.
Just a small
yes.
comment, sir. From Punjab to Tamil Nadu, where I work now, celiac disease is extremely rare. I think Dr. Seshadri sir and others will agree. And whatever few patients we saw are basically the migrants who had only those, for a couple of patients whom we see, they belong to either the Sindhi population or they were from Bengal. So even in type 1 diabetes, there is a series from Vaidehi Medical College, Bangalore, where in type 1 diabetes, the celiac disease prevalence in South India is much, much lesser than what you saw in North India. So there seems to be the rice eating belt is totally different with respect to celiac.
That just goes to show India is not just one country. India is just not one country. Actually, many countries mixed together, and so different regions are likely to have different profiles of patients. We need to be conscious of that. I agree. I think the ones with celiac disease we see in CMC are mostly people coming from northern India, not people coming from southern.
So, if no further questions, or Om Lakani, you want to ask any more questions or?
Yeah, so there was this one question in the chat box regarding, and I'll open it to the house. There's a question on DDT, which is commonly used as a pesticide in our country, and in pesticides in general as a form of endocrine disruptor, especially in India. We have a large agrarian society, and a lot of exposure to these compounds. Do we have, sir already said that the data is very limited, but do we have any kind of anecdotal experiences on, any kind of exposure in the agriculture community to pesticides and any impact of that on, possible endocrine disruption?
Yeah, actually, the data I present about the testis degenesis syndrome in the North Europe, especially from Denmark, those data come from the observation of an association between the exposure to pesticide, including DDT, and the risk of developing cryptorchidism, altered semen quality, hypospadias, and testicular cancer. So the DDT have been widely studied because they are, of course, diffuse, and they also, attract the attention of many investigators in this field. I would say that the testis dysgenesis syndrome and the obesity, the link with the risk of developing adiposity and obesity later on, are very well studied, recognized, at least in animal in animal world. Once again, and another point is that many data about pesticides and DDT in particular show also that there's no question that DDT is able to induce epigenetic changes, and these epigenetic changes are closely related to developing of adiposity, because actually they happens in genes which are regulators of adipocyte differentiation. This is, of course, once again, these are data from experimental animals and experimental cell lines, but DDT has been very, very well studied in these models, and his capacity to induce adiposity is very well known.
In Kerala, endosulfan use and the legal tussle that is going on between large communities that have been exposed to this and the government claiming compensation is one of the major instances where an environmental agent used in agriculture actually has caused or has been associated with a lot of human disease. I think it really depends upon the level of education of the public, and if they are very perceptive and they take up an issue with the government, then I think you'll find some action. It's also incumbent on the professional body, like say the Endocrine Society of India, to take it up at the national level and say, look, this is the evidence available all over the world, and these are the compounds that we are using. So as a professional body, we would stand against that. I think that kind of stand might help.
So
in this context, just a small comment, Om.
Yes, sir.
If I'm just a small comment to add, just because you said anecdotal, there are two very nicely done studies from Tamil Nadu. One, Dr. Krishnan Swaminathan from Coimbatore. He has published in at least 3 or 4 papers regarding pesticide use in farmers and prevalence of diabetes. And definitely there is a causal association. And a very small work from our institute also is showing somewhat similar. But these are all the farmers who use very high concentrations. It's and comparing with the general population. There were some limitations in the methodology, but this is now almost getting proven. As Seshadri sir is pointing out, this is to be taken to the next level of, I think, some public health intervention.
Very important, Dr. Sriram. So, yeah, very important. We have to have further research also. Yeah. Thank you. You have done already some work. So, is there any more questions? Then
so I think, sir, we have short the time by
yeah. So from my side, I like to thank all the speakers, co-panelists, Dr. Professor Seshadri, Professor Sanjay, and Dr. Om Lakhani. You are a pillar. You did a wonderful moderation, and to the whole this thing organizing. Dr. Rakesh, Professor Rakesh, and Dr. Sri Nagesh. Thank you very much from my side. Dr. Sriram?
Yeah, I also thank everybody and especially organizers, the international speakers for giving us the privilege of chairing this session. Of course, my co-panelists, Professor Seshadri sir and my teacher, Dr. Badada sir.
Thank you.
Thank you so much, sir.
For the opportunity. Thanks.
Thank you so much, and good night, everyone, and we'll see you again tomorrow for the the remaining sessions. Thank you so much.
Bye bye.
Bye.
Ciao. Ciao, everybody.
Bye.